All those who are sitting towards the back of the auditorium, please come towards the front rows. We have a lot of space in the front few rows. So kindly please occupy those seats. Please be seated so that we can start with the session today. A very good morning to all. I, Dr. Nishant Saxena from ICMR-NITH Jabalpur, again welcome all the eminent luminaries, panelists, speakers, participants for the today's sessions and the second day of the symposium on sickle cell disease in India. And I think after a very motivating inaugural session yesterday, followed by a diverse group of experts who deliberated extensively on the different critical aspects of sickle cell disease in India, we are now looking forward to the today's proceedings of the symposium, where again we'll be touching upon different diverse aspects of sickle cell disease. And we'll be having 6 talks today. All the eminent speakers will be deliberating on different aspects of sickle cell disease, starting from transfusion in sickle cell disease to hydroxyurea, management of pregnancy in sickle cell disease, to bone marrow transplant. And they will be also looking at the universal screening of ANC and PND for prevention of sickle cell disease. And then we'll come to the control of sickle cell disease in Madhya Pradesh, the initiatives by the government of Madhya Pradesh. So moving on, our first speaker today is Dr. Bhavna Dhingra. She is a professor at the All India Institute of Medical Sciences, Bhopal, and she has extensive expertise in sickle cell, thalassemia, leukemia, child health, young adults, hematology, child development, liver, pediatric and hematology, and she has published more than 60 papers in different reputed journals across the globe. And she'll be speaking today on the transfusion in sickle cell disease. So I request Dr. Bhavna Dhingra ma'am to please come on the stage for her talk. Please put on the slides.
Am I audible now? Okay. A very good morning to everyone. And I thank the organizers and ICMR for giving me this opportunity to be a part of this academic feast on sickle cell disease, a topic which is very close to my heart. Before I begin, I would just like to share an experience. I did my undergraduate and post-graduation from MGIMS Sevagram, the Vidarbha belt. So every patient we used to screen for sickle cell disease, and the prevalence used to be around, let's say, at least minimum 50 to 60% of cases who presented to the pediatric ward turned out to be positive for sickling. After finishing my studies, when I moved to Delhi, AIMS Delhi, I remember I was doing my senior residency there, and once there was a slide with a positive sickle cells thing. So it was a commotion among the residents that, have you seen sickle cell? Have you seen sickle cell? So I was surprised that why are they so excited about seeing sickle cell when I have seen at least thousands of them, and we used to see them on an everyday basis. So we know that there are geographical differences in the distribution of sickle cell disease, and MP comes in the high prevalence belt of sickle cell disease. So taking on from there, I will just start my presentation talking of transfusion therapy in sickle cell disease. Next please. So the outline of my talk would be that I would, can you please move the, okay, I'll do that. Thank you. It's not moving. Yeah, okay. So the outline of my talk would be that I would be briefly discussing about the epidemiology, the pathophysiology of the disease in brief to understand why there is a role of transfusion therapy in treatment, selection of the ideal blood product and the types of transfusions you can have in the disease, complications of transfusion, and what are the approach to these complications in sickle cell disease. I think this is not moving. You will have to move it from there only. Okay, so we've all seen these maps very frequently. We know that there is a varied geographical distribution of the disorder, and India comes in a high prevalence belt with around 1 lakh babies being born every year, newborns with sickle cell every year. And within India, we know that this belt, the Vidarbha belt or the sickle cell, ऐसे, okay. So within India, we know that the central part of India has a high prevalence belt, and we fall in that high prevalence belt due to the geographical location. And I don't know. Ma'am, it's still not working. Okay. So the estimated disease burden, we know that there are certain districts in Madhya Pradesh also which shoulder a very high burden because they have a very high percentage of tribal population, to the extent of around 20 to 30% population of Madhya Pradesh is tribal. So these certain specific, please go back to the previous slide. The next one, yeah. Okay, so in MP alone, we know that there are approximately 9,61,000, or let's say around more than 9.5 lakh persons with sickle cell trait, and approximately 70,000 people who are suffering from sickle cell disease. Now, these are all reported estimates, people who have approached a healthcare facility or those who have been screened and diagnosed. This might just be the tip of the iceberg because there are many which go undiagnosed, which never reach a healthcare facility, and most of them die undiagnosed because of related complications. So this is the magnitude of the disease in this part of the country that we are dealing with. We are aware of the pathophysiology of the disease, that this is a monogenic disorder. A single base pair change leads to this sickle-shaped RBCs being formed in the blood circulation, which repeated sickling and de-sickling, the polymerization and depolymerization leads to the vaso-occlusive crisis. There is infarction, ongoing hemolysis, and this chronic hemolysis gives rise to hemolytic anemia and vasculopathy, along with hypercoagulability and inflammation, which is ultimately responsible for the end organ damage of the disease that we see. Now, what are the various genotypes and phenotypes, or the phenotypic expressions of these genotypes that we see? That across the whole country, we see that there is a varied spectrum of clinical manifestations of the disorder, ranging from very mild to very severe phenotypes. There are individuals who do not require a transfusion, who have minimal pain crisis throughout their lives, and there are individuals who are frequent visitors to the emergency, who require regular transfusion therapy, hydroxyurea, and treatment for other associated complications. So based on the genotypes listed here, Most severe genotypes are HBSS or SBS with beta thalassemia, and sickle D Punjab. D Punjab otherwise is innocent, but otherwise with sickle cell it gives rise to a severe phenotype based on this genotype. And all these, the clinical manifestations that we see are the result of end organ damage, the bacteria repeated infections, leg ulcers, thrombotic episodes. Then you have pulmonary hypertension setting in, heart disorders, and end organ damage in the eyes, kidneys. So all possible organs get affected because of this underlying pathophysiology of the disorder. Now coming to the treatment approaches in the disorder, we know that we start routinely with hydroxyurea therapy. We try to maintain the hemoglobin F level, prevention of dehydration by adequate hydration, prevention of infections by prophylactic antibiotics and vaccines, and therein comes the role of the correction of anemia, with transfusion therapy being the mainstay for correction of anemia. Now what can be the types of these transfusions? You can have simple treatment of anemia to give a simple packed RBC transfusion targeting a hemoglobin level of around 10 grams per deciliter, which is a simple packed RBC transfusion. You can also have preoperative transfusions and transfusions which are not given to correct anemia but for prevention of complications like primary prevention of stroke and secondary prevention of stroke. Here the target is not the actual hemoglobin, the target is the level of hemoglobin S, which should be kept less than 30% by regular transfusions, and prevention of these cerebrovascular events by maintaining a stable hemoglobin level and reduction of the hemoglobin S level to less than 30%. So these are the main indications of transfusions. Now the rationale and goal of transfusion is, one, that you dilute HbS level by giving fresh transfusion when you give. So HbA containing RBC content is more in the transfused blood. That dilutes the amount of hemoglobin S which is present in the individual, and once it decreases to less than 30% because of the longer lifespan of transfused RBCs, there is suppression of erythropoietin release, which is caused by the improvement in the hemoglobin because the HbA content of transfused blood is higher. This leads to a decreased production of new HbS containing cells from the marrow, and thereby improving the oxygen saturation level by approximately 1 to 6%, which ultimately improves the tissue oxygen delivery and prevents the complications of cerebrovascular events and other thrombotic complications. So the aim is to bring hemoglobin to patient baseline Hb, and a higher Hb target may put the patient at the risk of hyperviscosity. So please remember that when you are giving regular transfusions, we are not aiming to achieve a higher hemoglobin level. If you raise the hemoglobin much higher than 10, let's say to 11 or 12 by giving more transfusions, that may be more harmful for the patients by predisposing the patient to hyperviscosity syndrome, even though the HbS level has decreased. So the target hemoglobin should be around 10 gram %, and the HbS level should be targeted to be kept around less than 30%. That should be the goal of the transfusion. Okay, so practically indications for transfusions can be either therapeutic, which is to correct anemia, as I said, simple transfusions with this target hemoglobin, or this transfusion could be prophylactic. Prophylactic is to reduce the incidence of vaso-occlusive crisis, primary and secondary prevention of cerebrovascular accidents, and there could be a role of exchange transfusions in these silent cerebral infarcts to reduce the content of hemoglobin S in the blood and improve the outcome. This could also be to treat the acute episodes of acute chest syndrome, acute infarcts, transient ischemic infarcts, multiple organ failures or single organ failure like renal damage. Then you might need an exchange transfusion or simple transfusion also if there is associated anemia. So we must understand that sickle cell disorder is a condition where there is chronic ongoing hemolysis, and there may be an episode of acute anemia over and above that chronic underlying anemia. So to correct that acute anemia, we might require a simple packed red blood cell transfusion to bring up the hemoglobin, and you might require an exchange transfusion to reduce the HbS level significantly if you are treating an acute cerebrovascular event. You can also require a transfusion in a preoperative phase, which could be a simple transfusion to raise the hemoglobin level above 10 gram, around 10 gram per deciliter. Now, certain pre-transfusion requisites, we all know that a baseline CBC and retic count, because we said that we have to bring the hemoglobin only up to the baseline level of that particular patient and not beyond that. Blood group with extended antibody panel. Before you start transfusion therapy, the antibody panel should be known so that you give the least incompatible blood to these individuals to prevent alloimmunization. As we will see further in the complications that we discuss, it is a common complication. Immunization history, viral marker status, and past history of alloimmunization or hemolytic transfusion history should be well established and taken before you start the patient on transfusion therapy. If the patient has presented to you with an acute episode of anemia, we need to rule out and treat the underlying cause of anemia, whether it is an ongoing or a new parvovirus infection, whether it is a sequestration crisis, the RBC is getting sequestered in the spleen or the liver, it is an acute bleeding episode or accelerated hemolytic reaction. Now, selection of blood products. RBC antigen matching, as I said, that we must know an antibody panel before we start on transfusion therapy. An extended antigen panel with D, E, K, Kel, Duffy, whatever is available should be done, and antigen negative units should be given if other alloantibodies are present in the initial antibody screen. Leuko-reduced products should be used, which reduce the reactions of febrile hemolytic transfusion reactions. Fever may necessitate admission and it may increase the oxygen requirement and actually complicate the pain episodes also in these individuals, further necessitating the need for transfusion. So, you must use leuko-reduced or leuko-depleted products. Storage time, they should be as fresh as possible. Units less than 10 days for simple transfusion and less than 7 days for exchange transfusion are preferred. Irradiation is not preferred as it shortens the cell survival, is not available everywhere, and it increases the cost. So, please do not be after procuring irradiated blood for sickle cell patients. Simple leuko-reduced products are fine enough. It should be considered irradiated blood if the patient is being planned for a stem cell transplantation, then you have to consider using irradiated blood. This patient whose blood you are using, the donor blood, should not be sickle cell trait, because again the level of hemoglobin A will be much lesser, so the desired result will not be as good as you want. Now, coming to simple RBC transfusion, we have discussed the indications where we can use the simple RBC transfusion to correct acute anemia in preoperative conditions and in somewhere in treatment of cerebrovascular accidents also. The disadvantage is that it can lead to volume overload, and a sudden increase in hemoglobin can also lead to increased blood viscosity, and over a period of time complications of iron overload may set in, necessitating iron chelation. Now, blood viscosity, as I said, hyperviscosity syndrome, if you raise the hemoglobin level beyond 10 gram per deciliter, it depends on total hemoglobin, the percentage of HbS in the blood flow velocity, and other parameters like if you have hyperleukocytosis, that will again predispose to development of hyperviscosity syndromes even at a lower hemoglobin level. Decrement in HbS must be achieved without increasing the hematocrit unduly, as we discussed. So, in homozygous patients where baseline hemoglobin is less than 9 gram percent and who are not on chronic transfusion therapy, the post-transfusion should never exceed 10 to 20 gram per deciliter above the baseline. So, please, if the baseline level was less than 9, do not aim to raise it to 11 gram percent suddenly by over transfusing. Transfuse slowly, maintain it around 9 to 10. That will take care of the underlying anemia, improve oxygen delivery, and also prevent development of hyperviscosity complications. RBC exchange transfusion, whether you do a manual transfusion or exchange or an automated exchange, which is also available these days. In this, what happens is that the patient's red cells are replaced with the donor cells. So, you take out the patient's cells and you replace them with the donor red cells. In simple transfusion, you are not taking out the patient cells. Here you are exchanging the patient cells with the donor red cells. So, this lowers the concentration of hemoglobin S and maintains the hemoglobin level. It can be used when the patient is acutely ill, there is multi-organ failure, there is sudden deterioration, rapid deterioration, kidney failure, and it should be done regularly on a basis to prevent stroke, acute chest syndrome, and recurrent painful episodes if the hemoglobin S level is significantly high. The advantages of an exchange are there is a more rapid increase in hematocrit and decrease in the HbS level. The risk of iron overload as compared to simple transfusions is much lesser, and there is a lower risk of fluid overload and associated complications as well. Disadvantages that the requirement of blood is much more, there is increased requirement, and you require an ongoing venous access and increased cost of transfusion, though which may be balanced when you look at the long term. This thing, if you are giving simple transfusions, that will lead to iron overload. So the cost of managing the complications, the cost of chelation therapy, that may be balanced against the initial higher cost of exchange transfusion. Okay, one more point which I would just like to emphasize here, that if suppose your baseline level is around 9 or 10 gram per deciliter and the HbS content is much higher, or there is an acute vaso-occlusive episode without significant acute anemia, in those cases you do not need to raise the hemoglobin, total hemoglobin level, so you do not need a simple RBC transfusion. What would be preferred is a RBC exchange transfusion, which will keep the total hemoglobin stable but will reduce the HbS level. So if the baseline HB is normal, then do not go for simple transfusion, go for an exchange transfusion. Prerequisite, we must ensure that the blood is warm prior to infusion. Patient should be pre-hydrated, there should not be any dehydration, and local transfusion practices or the monitoring charts that you use, frequent monitoring should be used with exchange transfusion also. This is just to show the level of evidence for red cell exchange, that in conditions like acute stroke and acute chest syndrome, there is a high level of evidence for use of red cell exchange transfusions, and also in prophylaxis of stroke as well as management of recurrent vaso-occlusive crisis, also in pregnancy as well. I would just like to mention here that I am not talking of management of transfusion in pregnancy here, because we have a separate session on management of pregnancy in sickle cell disease. Now, there are certain complications of transfusions which are specific to sickle cell disease. That does not mean that other complications which are associated with transfusions are not seen in sickle cell disease. So febrile reactions, non-febrile hemolytic reactions, transfusion reactions, they all can be seen in patients with sickle cell disease also. But I am particularly talking about these because they have a higher prevalence and higher relevance in patients with sickle cell disease. So it could be either alloimmunization or development of autoimmune hemolytic anemia, or a hemolytic transfusion reaction, which could be a classical delayed hemolytic transfusion reaction or a hyperhemolysis, and ultimately iron overload with long-term transfusions. Now, alloimmunization is seen in approximately 1/3 or to 1/4 of patients. To delay the onset, to prevent alloimmunization, you should delay transfusion and lead to more severe reactions, as they may precipitate pain crisis. So, alloimmunization can precipitate pain crisis, and it is commonly associated with the RH and KEL system. So, you develop antibodies against the RH and KEL system, which leads to development of alloimmunization, and the response which you want to see to blood transfusion is usually not as much as expected. So, antigen matched blood should be required to reduce the incidence or prevalence of alloimmunization. As I had said, before you start transfusion therapy, an antigen antibody panel must be baseline must be known for every patient. Delayed hemolytic transfusion reaction, it is associated with formation of new alloantibodies. You will have a positive antiglobulin test and shortened survival of the transfused red cells. So whatever you have transfused is getting hemolyzed, and you will require more and more increasing requirement for RBC transfusion. It occurs in around 4 to 11% of patients who are transfused. Fever, jaundice and anemia 7 to 10 days after a history of transfusion, along with painful episodes or a sickling crisis, is the usual presentation. And if the anemia is not severe, do not transfuse to prevent these complications. This gets stuck. So, hyperhemolysis syndrome is that it presents with fever, hemoglobinuria, sudden fall in hemoglobin and severe painful episodes. There is destruction of both donor as well as autologous red cells. Autologous means the patient's own red cells and the donor cells which you have transfused. both are getting hemolyzed. The post-transfusion hemoglobin is lower than the pre-transfusion hemoglobin because of accelerated hemolysis. The HbA level decreases or becomes absent because there is hemolysis of the HbA containing RBCs which were transfused, or the donor RBCs, and all of them have got hemolyzed. So there will be a decrease or absence of HbA, and fall in absolute reticulocyte count. That may be negative, it is usually negative, and new red cell and alloantibodies are frequently not detected. So it is not development of newer antibodies, it is the previous antibodies which were present, there has been an accelerated hemolytic response, and the hemoglobin may actually fall from the baseline hemoglobin. Autoimmune hemolytic anemia usually develops in multiply alloimmunized SCD patients, around 6 to 10% of transfused patients. Then they may present with problems with cross matching and usually mask the underlying alloantibodies which are present. Direct Coombs test here will be positive, and indirect Coombs test may or may not be positive. How to approach these immune problems? You must know the patient phenotype before the first transfusion, as I already emphasized, and after 3 months of transfusion-free interval to see if there has been a change, if there is a development of newer antibodies. Patient genotype for blood group antigens, if there has been a transfusion within 3 months and you do not get a 3-month transfusion-free period, then you must look at the genotype rather than looking at the phenotypic panel. Coombs test and adsorption procedures may be required as per the details of individual case. This is again the approach if you have a post-transfusion hemolysis. You must stop further transfusion if there is an ongoing hemolysis. Start IVIG, 0.4 gram per kg per day is the dose, and total dose over a period of 5 days is to be 2 gram per kg with estimated GFR more than 50 ml per minute. So you have to ensure that the kidney is functioning well, then only you are transfusing IVIG, and high dose erythropoietin may be used if there is associated significant reticulocytopenia. Preventive anticoagulation may be required, and supportive care in the form of maintaining the hydration and oxygen saturation is what you need to continue. If there is acute chest syndrome with hypoxemia or acute development of acute pulmonary hypertension, if there is a stroke or an imminent organ failure like liver, kidney, eye, then eculizumab 900 milligram at day 1 and day 7 can also be considered. You can give a rescue transfusion if there is hemoglobin is less than 3 gram per deciliter, which is a life-threatening severe anemia, and or if there is hyperlactacidemia, significant acidosis which is there, so that will be corrected by giving a simple RBC transfusion. Combination of rituximab and methylprednisolone with transfusion for patients who have a DAT positive or who have screening test on ILSHN positive. So this is the transfusion strategy in detail, what we have just discussed, that you have a baseline phenotypic panel, if there is a weak antigen, or you do go for a molecular analysis, whether this is a partial antigen or a no partial antigen detected. Accordingly, you give cross-matched and type blood depending upon the antigen panel of the individual patient. Okay, so take-home messages in transfusion therapy, that you need to decide to transfuse, and the dosage is important. Whether you give a simple RBC transfusion or you want to give an exchange transfusion, over transfusion is to be avoided. Hemoglobin around 10 gram per deciliter should be maintained, and selection of blood component should be based on the antigen antibody panel of the given individual. Leuko-reduced or leuko-depleted blood is preferred. Irradiated only if you are thinking of a hematopoietic stem cell transplantation. Fresh blood as much as possible, preferably within 7 to 10 days of collection. The donor should not be sickle cell trait. Recognition of post-transfusion complications is important, and early management of these complications is also important. In case you are planning or you are giving regular blood transfusions, then ongoing iron chelation to prevent complications of iron overload is also very, very important. Thank you.
Thank you so much, ma'am. We can take a few questions. Okay.
It was a very clear presentation. I wanted to know what is your experience about, we cannot have IV everywhere, in the periphery especially. So what is your experience about steroids?
Ma'am, steroids work pretty well.
Yeah.
And as the first line of treatment, if IVIG is not available with an ongoing this thing, methylprednisolone works pretty well. So even in our tertiary care setups, the availability of IVIG is very, very, in quotes, not easily available. So the first line that we start is methylprednisolone only.
And the other thing I heard recently is about cyclosporine where available. So what is the role of cyclosporine in?
Ma'am, in our pediatric cases, we have not used cyclosporin in many cases. Probably Dr. Rahul wants to add something to that.
There are two things which we can add. One is the thalidomide in sickle
Yeah.
beta thalassemias. Not only sickle cell, but sickle beta and thalassemia
major.
In patients who are immunized also, thalidomide has worked well by immunomodulation. Second thing, cyclosporin, when IVIG and steroid both has failed, any immunosuppressive therapy you can throw into the ring and see. It will be right now too futuristic to tell about it, but use of daratumumab is coming up in autoimmune disorders. And in kidney disorders. So you are trying to extrapolate. So what has happened is, alloimmunization has happened because the antibodies has been formed. Who creates the antibodies? B cells and the plasma cells. So where the daratumumab came from, CD38 molecule, was a acute kidney rejection people, where the Singaporean people started using daratumumab for chronic kidney rejections through the plasma cells. Then we started utilizing this for autoimmune hemolytic anemias and Evans syndrome in our setting. Wonderful result. I mean, people hemolyzing 4-line refractory daratumumab, 2 doses, wonderfully worked. PRCA, post-transplant pure red cell aplasia. We have not come across any person who's been hemolyzing so badly to use daratumumab after taking an ethical consideration in the subset. But yes, the use of plasma cell depletion can also be utilized in heavily pre-transfused. That's a concept in evolution. But yes, cyclosporin, azathioprine, mycophenolate, all these things can be utilized. Rituximab, of course. I mean, just treat it like an ITP or autoimmune hemolytic anemia, but our experience with cyclosporin has been good. We have used in 3 patients, and they have been able to tolerate because it has been able to suppress the immune system.
Yeah, we recently had a patient who was not actually sickle cell disease, but he had presented with a hemolytic anemia, not responding to any therapy. And for almost a month, that patient required 2 RBC transfusions every day. There were financial constraints, but rituximab worked to a certain extent only, to reduce the requirement of transfusion to, let's say, if not every day 2 bags, 1 bag in 2 days or so. Ultimately, we lost that patient, but any immunosuppressant therapy can be used.
Just another point, role of red cell exchange. I think we should actually be talking about blood transfusion. We should all be talking about the sickle cell, the role of red cell exchange. Since we have started using red cell exchanges pre-transplant, our endotheliopathies and press have started coming down. So sickle cell comes with endotheliopathies in terms of press when you give cyclosporin. Either you change to tacrolimus or sirolimus. We have still not graduated to sirolimus right now. We are still using cyclosporin in transplant. So endotheliopathies and the liver complications have started coming down by using red cell exchange. So extrapolating that, when we are sitting, the government initiators are also sitting here, the role of red cell exchange in the district hospitals needs to be strengthened more rather than just giving transfusion. That's the opening statement and people can discuss about.
Provided they have access to regular transfusions.
Thank you, madam. Your topic is close to my heart because I belong to transfusion medicine. And there are few things I would like to add rather than ask you one question. We did a 7 red cell exchange transfusion in a sickle cell disease patients in acute chest syndrome. And with the spectropia, with a red cells concentrate, leukoreduced, irradiated, and net tested. Out of 7, only 1 is fatal because she has a multiple organ syndrome. So we lost that patient. Rest of the 6 patients are doing very well. And one of them we are planning for the bone marrow transplant with the help of Rahul.
Sir, I will also share my experience here. I have one girl who's been coming to me for the last 10 years, and 2 years ago during the COVID period, she was presenting with a vaso-occlusive crisis. Every week to us she was presenting. Pardon? No, sir. So almost every week she was presenting, and this girl underwent a red cell exchange twice. She had presented with an acute chest syndrome. She underwent an acute red cell exchange, and for the last 1.5 years, touchwood, she's not had a single vaso-occlusive episode. After undergoing that one red cell exchange in the last 1.5 years, she's not had a single vaso-occlusive episode. She's due to appear for her 10th standard board exams. So she came last week to me saying that prophylactically ek bar exchange kar do, so that I don't have any problem in my 10th board exams.
Strengthening of blood banks, we are talking about strengthening of hydroxyureas and fancy medicines in terms of Novartis medicine for pain crisis and other pain things which are coming up. Is red cell exchange is still a viable option for a resource-rich country in India, which is simpler, not very difficult, and the catheter care now is becoming standard. So that's a question for everybody to ponder and discuss in next step.
I think, Dr. Rahul, what you're saying, the awareness on that needs to increase. Ma'am wants to say something.
I want to say, we do at least one transfusion a day, exchange transfusion. So it's and we don't have a machine, we do partial exchange. And it is effective. So it is very commonly done in our center. Anybody can do it. So I think exchange has to be recommended. And it is.
And the machines are becoming available at the tier 2 cities and the district hospital. With the help of the strengthening of the blood bank mission from the NRHM, the apheresis machines have started becoming available at the district levels. So then it becomes all cohesive and collaborative, that you have a machine which is being utilized not only for platelet but also for a red cell exchange can be utilized. So now you have a machine where you just have to put in a cannula and just hook it them, and that's as simple as that.
Yeah, manual exchange is equally effective, ma'am.
Completely agree. But the blood group matching has to be done very carefully. Just to clarify, because I think there are some students here, so all the steroids, the IVIG, all of those things rituximab works for auto-antibodies. So if you have AIHA, when you've developed allo-immunization, none of these things work, right? So that's an important thing to remember, and don't just start giving steroids and immunosuppression and more immunosuppression to your allo-immunized patients. There, the only thing that will work is to have a good transfusion medicine person and to get antigen negative blood if needed. And what we have done is we get a lot of patients referred to us with who are allo-immunized. That's the reason they've sent to us, because they cannot provide blood to these patients. And in these patients, what we tend to do is we try to avoid blood transfusions. We escalate the hydroxyurea, or if they're not on hydroxyurea, we start hydroxyurea, and you manage them well. And if they need blood transfusion, then you may have to type 50 units of blood in order to get them blood. So yes, transfusion is important, but again, don't transfuse like we talked about yesterday for somebody who is stable. But obviously, if you have recurrent crisis, if you're having acute chest syndromes, if you're having those things, those are the patients you must transfuse.
And just an offbeat, where you require blood transfusion, that's a sure shot indication for a bone marrow transplant. Then you have to actually find out a place and get the money for doing a transplant. Because as you started transfusing the patient and the patient is transfusion dependent, then in Madhya Pradesh, Indore, or any other place, or whichever place you can find a slot, I think that's a place where you should refer the patient for a transplant. So there's one of the indications Dr. Bhavna has already put in for the next 2 talks. That's one of the indications to do a transplant for without any discussions.
Thank you so much, sir, and for all the questions.
There's one more question, I think.
Okay, I think we can take just one more now.
Ma'am, yesterday it was told that in preoperative cases, Patel sir has told that he operated even at 6 hemoglobin without transfusion, and here we are in almost everywhere we have read like 9 to 10 is our target.
See, it depends on the type of surgery that you are going to undertake. If you're going to undertake a small excision or an FNAC under local anesthesia, probably you can dare to do that. But if you are thinking of a laparotomy at a hemoglobin of 6 under general anesthesia, no, that cannot be done. So a hemoglobin level of 9 to 10 gram per deciliter has to be maintained.
Splenectomy, yeah.
It is not about the blood loss.
Okay.
Yeah.
Okay, I think Dr. Patel wants to make a comment.
Excuse me, madam. What he quoted was me. I am
Sir?
Dr. Patel from Gujarat.
Sir.
We have got tertiary care center for sickle cell disease management, and we have been doing splenectomies, hip replacement, cholecystectomies, all kind of surgeries that we do. And as a pediatrician and working for sickle cell 35 years, our observations were that the patients who are stable at their stable state hemoglobin, if we can maintain that hemoglobin and subject them for surgery with a critical monitoring even during the surgical period with reserved 1 or 2 blood in the background, I think majority of our patients, we did not give a single blood transfusion. We looked at their stable state hemoglobin. If they are at stable state hemoglobin, we take them for surgery. Even we have done hip replacement with 6.2 gram per cent hemoglobin. We have done splenectomy with 7.2 gram per cent hemoglobin. And majority of them, they remain stable during the surgery. They did not require post-operative blood transfusion also in majority. This is what.
इसको सिंपली जैसे थैलेसीमिया इंटरमीडिया में आज से 10 साल पहले जब हम डीएम से पहले थे तो बोलते थे कि हीमोग्लोबिन 8 या 9 मेंटेन करना है। फिर उसके बाद धीरे धीरे ये कंसेप्ट आने लगा कि जिस पे उसका स्टेडी स्टेट है, जहाँ पे उसका वो कर्व अपन जो फिजियोलॉजी में पढ़ते थे कि कितना वो लेफ्ट शिफ्ट होगा, अगर वो 6 पे भी स्टेबल है तो आप उसको छेड़ो मत, वो चलता रहेगा, हाइड्रोक्सीयूरिया देते रहो, ही विल लिव हिज लाइफ नॉर्मल, डिस्मॉर्फिक फीचर्स ना हो, ही लिव लाइफ नॉर्मल। बट जब हम गोष्ठी में होते हैं कि सम्मेलन में होते हैं तो हम एक क्राइटेरिया से चलते हैं जो जनरल पब्लिक के लिए यूज होता है। आपके सेटिंग में गुजरात का सिकल सेल कैसे बिहेव करेगा मध्य प्रदेश के सिकल सेल से डिफरेंट होगा।
Every patient will be different.
है ना, और वो नागपुर के सिकल सेल से डिफरेंट होगा। तो आपने दोनों मत पढ़ लिए, जो हीमोग्लोबिन 6 पे जहां पे आप कंजर्व कर पाए, 7 पे कंजर्व कर पाए, सैक्रोसेंट नंबर ब्लड ट्रांसफ्यूजन का यहां से मत लेके जाओ। आपने दो विचार सुने, आप नंबर नहीं सुन रहे। हम बहुत बार क्या होता है, हम नंबरों पे फिक्स हो जाते हैं कि 9 पे, हमने पढ़ा था किताब में कि 9 पे ट्रांसफ्यूज करना, तो हम सबको 9 पे ट्रांसफ्यूज करेंगे। तो आप यहाँ पे नंबर पे मत जाइए, यहाँ पे आप भाव समझ के जाइए, फिजियोलॉजी समझ के जाइए कि गुजरात में वो कह रहे हैं कि हमने स्टेडी स्टेट, वो बार बार क्या बोल रहे हैं शब्द, स्टेडी स्टेट। अगर पेशेंट सिक है या ब्रेथलेस है या टेकीकार्डिक है तो आप ब्लड दोगे उसको। तो डॉक्टर भावना भी ये कह रही है कि जनरली 8 या 9 मान के चलो, आपकी सर्जरी में डिस्ट्रिक्ट हॉस्पिटल में वो रिजर्व करके रखते हैं। अगर आपके पास रिजर्व करने का तरीका नहीं है तो आप उसको ट्रांसफ्यूज करके पेशेंट का हित सर्वोपरि है कि मरना नहीं चाहिए पेशेंट।
Reserve blood and the ability to manage any unexpected or untoward emergency. If you have that backup.
नंबर याद करके मत जाओ, आप उसके फिजियोलॉजी समझ के जाओ कि वो भाव किस टाइप से और क्या चीज बोल रहे हैं। अब मेरे को कोई अफ्रीकन सिकल सेल में कहेगी 6 पे, वो अफ्रीकन सिकल सेल 6 पे ऑपरेट ही नहीं हो सकता। मतलब अगर मैं नाइजीरिया से पेशेंट आ रहा है जिसका HbF लेवल 2% है और गुजरात का HbF लेवल 18% है, दोनों में क्या डिफरेंस है ना। सो इसलिए इंपॉर्टेंट ये है कि अगर 6 वाला पेशेंट स्टेबल है तो आप उसको हाथ नहीं लगाओगे, पर अगर पेशेंट अनस्टेबल है और मेजर सर्जरी है, आपको लगता है ब्लड लॉस होगा, तो आप उसको ब्लड दो, उसको स्टेबल करो और उसका सर्जरी करो, क्योंकि उसका आउटकम अच्छा होना चाहिए।
Again, as he said, steady state, which means that this hemoglobin of 6 has been due to an acute blood loss or is a chronic anemia on which the patient has been maintaining for long. If this has been an acute blood loss, the patient will not be compensated at that low hemoglobin.
I think I am afraid we need to move
You also
on.
need to know what the hemoglobin S percentage is, and also what anesthesia is going to be used. So there's a lot of information that comes into this. It's not a simple, you know, standing on the corridor making a consultation kind of a thing.
And your anesthesia team has to be on the same page with you.
Absolutely.
Okay, I think now if there's a few more questions,
there is a lot of controversy and between the transfusion and blood transfusion. Since we have a global expert on sickle cell disease, I request Dr. Sargent to comment on transfusion protocol in sickle cell diseases.
Oh, I'm here to learn, not to teach. Why, I'm very conservative in Jamaica. Remember, we have a different disease. I'm very conservative in the use of transfusion. Probably the commonest is just maintaining oxygen delivery in an acutely lowered hemoglobin, such as the aplastic crisis. That's a perfectly straightforward entity in Jamaica. They come in with a hemoglobin of 3 to 4 grams, 0 retics. They cross-match, they're transfused, and they go home the same day. That's straightforward. We also use it, obviously, in acute sphenic sequestration, but we have very few people on a chronic transfusion programs in Jamaica are not really feasible because of our very limited resources in terms of blood. We're asking the families to actually find a unit of blood every 3 to 4 weeks. It just isn't viable. So we have almost nobody on chronic transfusion. So our major indication for transfusion would be acutely lowered hemoglobin in the aplastic crisis and also in acute sphenic sequestration.
Thank you so much, sir. I think I would request Dr. Tulika Seth, ma'am, to please come on this dais and felicitate Dr. Dhingra Bhan.
Ma'am has been a teacher, so it's really an honor to have her on stage.
Thank you so much, ma'am. Thank you so much. Thank you so much, ma'am. Our next speaker is Dr. Ellie Mohapatra. She's an MD from United States and currently a full professor and head at the All India Institute of Medical Sciences, Raipur. She has expertise in sickle cell disease and thalassemia and has published more than 60 papers in international and national journals. And today she will be speaking on treatment by hydroxyurea in sickle cell disease, and she will be looking at the question of the low or maximum tolerable dose. Thank you, ma'am.
Thank you for the kind words. Good morning, all. Amidst of a very interesting topic that was going on, and now we land up with hydroxyurea. We'll be talking right now about hydroxyurea. And let me just tell you a little like being a native of Orissa, and then after getting my job in AIMS in Chhattisgarh, both are the places where the prevalence of sickle cell is very high. And it was very close to my heart too. So when I became the chairperson of this unit, sickle cell unit, so I just wanted that what are the things to be taken up in order to improve the condition. And being given this topic of hydroxyurea, I may be not clear that much as many of the known and renowned person working on sickle cell are present here. And I'll be happy if I'm being corrected if I'm wrong anywhere. So with that note, I start with my topic. And before I start, just a small glimpse about our institute. It was we had it inception in 2012, and right from the inception I'm there. This is our medical college, and this is the overview of the hospital side of AIIMS Raipur. And this is our working place and worship also. So to start with sickle cell disease, as we all know, it occurs due to the change in the glutamine bivalent due to point mutation, and as a result, the normal blood cells gets converted to a sickle cell defective hemoglobin. And regarding which we know that due to this sickling, there is obstruction in the blood vessels at many times, giving rise to vaso-occlusive crisis. So this is what happens. So this pedigree analysis shows if a two carrier, they marry, so what happens is 25% of the people, the offsprings are found to be normal, 25% happens to have the sickle cell disease, and 50% happens to have carrier. But you don't know when, if a person having married and is having 2 children, you don't know who is going to be affected. You can't analyze, or beforehand you can't say this. So pre-degree analysis is important, but at the same time, you have to do more research at the molecular level. So in order to prevent such kind of formation of carrier or traits in sickle cell disease. The symptoms are, as we know, anemia, pain crisis, then acute chest syndrome, and organ damage due to subsequent occlusion of the blood vessels. And there will be failure of kidney, vision loss, and other things. So this is the picture showing the normal as well as the sickle cell hemoglobin. So when do you say you had a case of sickle cell crisis? Whenever there is any trauma, injury, surgery, wherever there is excessive blood loss, whenever there is any illness due to any infection, then climbing to high altitude where there is thinning of the oxygen, keeping more, and when there is more stress and dehydration and cold temperature. These are all being discussed earlier. I'm just repeating them. So the vaso-occlusive crises are of many types. They are like pain crises are the vaso-occlusive crisis, the plastic crisis, the splenic sequestration, and acute chest syndrome as being described by Dr. Bhavna. So this is what happens when there is occlusion of any blood vessels due to vaso-occlusive event. So next comes the main important factor, that is the hydroxyurea. So it acts by keeping the blood vessels in rounder and more flexible form, as it becomes less flexible once it becomes sickle, say. And till date, we have found this drug to be very proven to be to reduce the frequency of painful episodes, and it does it by not only making the RBC rounded in shape and more flexible, but also increases the level of HbF hemoglobin. And this was first tested in the sickle cell disease in 1984. So a little history about the hydroxyurea. It was started in 1869 by Germany by Dressler and Stein in 1869. And then it was approved by FDA for the treatment of the myelodegenerative diseases, neoplastic diseases in 1967. And then in 1980, it was first used for the sickle cell patients, and it was approved for the adults in 1998 and in 2017 for the pediatric age group. So mechanism of action is usually it acts as the S phase of the cell cycle, arrests the cell multiplication there. It also inhibits the replication, mostly acts by the RNR inhibition, where what happens once the drug is being taken and absorbed, it gets into the circulation, the nitric oxide that is being produced, it goes to the triarosyl free radical, quenches it, and then it gets bind to the active site of the enzyme, thereby causing inactivation of the enzyme. Once the enzyme is inactivated, what happens is there is decrease in the pool of the DNTPs. And as DNTPs decreases, the replication gets slowed down, and that is how the cell death occurs, and that is being the mechanism how it is being used in case of cancer. So not only in so these are the various conditions where hydroxyurea is already being in use, in case of cancer, for the cell cycle synchronization for the treatment of solid cancer, sickle cell anemia, myeloproliferative diseases, and also where it's found to be very useful in case of Alzheimer's disease. So now coming to why it is to be used in case of sickle cell diseases. It reduces the frequency of brain crisis, episodes of acute chest syndrome, and reduces the blood transfusion and the hospital stay. Though we were now discussing that a person needs to be transfused, and it's a very good idea to have the RBC exchange instead of the whole blood, but it suddenly becomes very difficult to get the blood at times. So in those particular time, one can go for this hydroxyurea in order to increase the level of HbF, and it has been shown by different studies that with the use of hydroxyurea, there is certainly reduction in the frequency of hospitalization, crisis, and the requirement of the blood transfusion. So there are, but everything has its own like the side effects that are found to be seen with the hydroxyurea is neutropenia, bone marrow suppression. Again, you are further suppressing a person who is already anemic in nature. And it has certain toxicity also. It usually gives rise to painful skin ulcers, aphthous ulcers, and in long-term therapy, it is responsible for giving rise to gangrene and in the toes and digits, and rarely dizziness and other hallucination all. So how are you going to select the patient? Now you have to select the patient, and for giving this drug, you have to take idle. The weight of the patient is very important. The blood count, which has to be taken every 2 weeks, and then has to be given. And other prophylactic drugs should be administered, like he should be well vaccinated against pneumococcal infection and other bacterial infection also, as he or she is in the chance of getting these diseases more frequently. So acceptable ranges of blood counts, repens, neutrophils should be more than 2000 cubic millimeter. Then a platelet should be more than 80. Hemoglobin should be more than 5.3. And reticulocytes should be more than 80. Now see, as we have already talked, like these are not the rigid range. It differs from place to place and race to race. Now, as I've already told you, like it has to be depend on the strength of the medicine, the daily doses, and what are the timing between the doses. Initially, they started with that of a pediatric age group. Initial dose was found to be 20 milligram per kg body weight, and then it was increased, escalated by 2.5 to 0.5, and to maximum of 35 milligram per kg body weight. In the adults also, it was something similar to that. And as per the US guidelines, they usually start the treatment for the children right from infant state at 9 months age. Whereas in case of India, usually they start at the age of 2 years. Please correct me if I'm wrong anywhere. So, and along with this, one has to go for immunization and penicillin prophylaxis in case of children, as per the Indian guidelines. So I was going through a number of literatures, and this is what I found. This was one of the journal which was being, work was being done by Brazil in 1997. And here, the sample size they took was very small. It was 10, with sickle cell anemia patient to be 8, and sickle with hemoglobin C, and thalassemia to be 2. And what they found, that it was an open label escalation trial, and they found that there was certainly increase in the level of HbF as well as the hemoglobin, and there was less requirement of transfusion, and the other parameters was maintained or were found to be better. And they concluded that the perfect dose of hydroxyurea is found to be 15 milligram per kg per day. Now another, this was being done in the eastern India for the first time, and they found the sample size they had taken was 118, and out of which pediatric age were 27 and adults were 91. And they also found that it was significant that after giving the dose of hydroxyurea, the requirement of getting the patient admitted to the hospital reduces, and it was also found that there was improvement in the clinical as well as hematological parameters. Now, low fixed dose hydroxyurea, it was done in another, in Maharashtra, and one of the authors is also present here, Madam Dipti Madam, and they had done on a case of 60 sample size, out of which they kept hydroxyurea, the sample on hydroxyurea to be 30 and placebo to be 30. And they found that the fixed dose of hydroxyurea of 10 milligram per kg body weight per day of it increased the hemoglobin F significantly, and there was also decrease in the number of painful crises as well as hospitalization. So here this found that there was a clinical benefit with the fixed dose of hydroxyurea of about 10 milligram per kg body weight. And this study also demonstrated that there was less toxicity that was being imparted by the drug, this drug regime. Another drug review, well, it was done in 2014, and it was found with the initial dose of 10 to 15 milligram of hydroxyurea, and further by increasing the dose escalation by 5 milligram, at every 4 to 6 weeks, there was improvement in the condition of the patient. It was there was lower chances of hospitalization, there was less intake of transfusion, and the patient happened to be better also. This was one of the study that was being done in Uganda, and this was the first type of no-harm MTD, first randomized control trial, where the sample size they had taken children was 187. And here they found that the maximum tolerated dose was approximately found to be 30 milligram per kg body weight, and found it to be clinically superior than the fixed dose of about 20 milligram per kg body weight in high-risk population. And this was being done without much toxicity. Then there was another study which was done by the sub-Saharan African country, and there the sample size was 187, where they took 94 at a fixed 20 milligram of hydroxyurea dose, and 93 sample size for dose escalation. Now, and they went for an escalation of about 30 milligram per kg body weight. Now, these escalated one, they found that they had a superior clinical efficacy as compared to that of the fixed one. This was being found in 2022. This study has been done. Initially, when they took the baseline, it was found for the fixed dose group as well as for the dose escalation group. They found that the baseline was almost similar. Like you can see here, the fetal hemoglobin 22.4, 22.5. And after the treatment started, a significant change was found to be seen in case of the escalated one as compared to the fixed dose regime. It was, there was significance, like a requirement of transfusion was less in case of escalated group as compared to the fixed group, and the hospitalization was also less. Then the malaria infection was not that significant, but other grades of sickle cell disease was also found to be significant here. This was a long-term hydroxyurea therapy in sickle cell, which was done. And here, though the sample size was less, but they did it for a longer period of time where they could follow up the cases. They took the population as of infants from 6 to 24 months age, and enrolled about 4 major pediatric sickle cell programs was done with a dose of 20 milligram per deciliter. And they concluded that the use of oral use definitely was found to be beneficial in all these patients. And this was the last, literature I have taken where the sample population is almost 14 studies. It is a systematic review. And here, it was found low dose of 10 milligram was found to reduce the rate of vaso-occlusive crisis and hospitalization and transfusion also. But they suggested that there is a need to conduct research focusing on the varied ethnicity, as we have already talked about. It might change from place to place, even within a country or from one state to another, and one has to take care of the tribal people and non-tribal people to see the change. So more research is required to be seen, because each of the person has their response in different way across the different population and country. So this was the finding where I found that most of the studies showed the escalated dose of this hydroxyurea was more beneficial as compared to the fixed dose, reducing the chances of painful crisis, then also reducing the chances of hospitalization as well as the transfusion cases. So the take-home message, as I would like to say, is escalating dose of hydroxyurea is found to be more beneficial as per these studies as compared to the fixed dose, and more research in this area need to be required to be done at the molecular level, and it should be conducted at different areas and different part of the countries, keeping in mind the different tribe, non-tribal people, population, as different people respond to the treatment indifferently. And right now we have the main powerful strength with us is that of the creating awareness. By creating awareness, by counseling the patient, at least we can reduce the number of sickle cell diseases in the people who are less literate or know less about this disease. I thank you again, the organizing team, for inviting me as a speaker, and I thank you all for this patient listening. Thank you.
Thank you so much, ma'am. I think when I joined ICMR in 2017, then I came to know about hydroxyurea for the first time, and
yeah.
I think there were a lot of questions about using this drug or not using it. But I think now the questions have been more or less settled on its the various aspects of it.
At least something is there,
yeah.
And a number of drug trials are also going on, like on glutamic acid and many other drugs has been mentioned by Rahul also on Novartis and all. But till now, like, we have one thing in our hand, that is the hydroxyurea, apart from transfusion and all. And but my focus is mainly, if we do the counseling and create the awareness, we can, like the pre-marriage counseling and all, so we can reduce itself the number of population which are having sickle cell anemia.
Ma'am, are there any estimates regarding the number of patients in India on hydroxyurea? I mean,
right now in
yeah,
they are, but there is no record of it. Now that I'm grateful to the ICMR team also for giving having a multi-centric study on hydroxyurea with 10 and 20 milligram hydroxyurea fixed dose. So there we have taken into consideration the tribal and non-tribal population also. And here, and most of the studies, one thing I found was the sample size was less and there was no follow-up. So which is very important, to have a follow-up of these patients. And though we say it, it is very difficult to catch hold of those patients also. Getting them for treatment is a difficult task, as well as follow-up. Doing the follow-up also is very difficult.
I think usage of technology can maybe probably help us in that, in some way, to connect with the patients.
Yeah, sure.
I think we can take a few more questions. Are there any questions from the audience? Mic is not working.
When to consider a patient on hydroxyurea is not responding to hydroxyurea and that the treatment of hydroxyurea should be stopped?
If the person is not responding to hydroxyurea.
It is not audible. Just increase.
In certain cases, we found that the hydroxyurea is not responding to well, and in what cases, how to they decide that the hydroxyurea is not working and we should stop the hydroxyurea in that patient.
I think Madam is there. She can answer this better than me.
Thank you. It is actually 80% of the patients will respond to hydroxyurea. And the definition which is given in the literature is wait for 6 months, escalate the dose, because I use 10, but 20% of my patients I have to escalate. And in spite of escalating, if you do not get response, then it's not responders, non-responders. And they are mainly patients of stroke who are non-responders. And instead of stopping the hydroxyurea, if there are no adverse findings, then we add other drugs rather than stopping hydroxyurea. Okay. Hydroxyurea is stopped if there are repeated adverse, which we have not seen. Transient leukopenia, thrombocytopenia is common, but then if we withhold for some time, start again.
So if your patient is not responding well, then hydroxyurea should be continued?
We have to add on and see.
Escalate the dose. What Madam wants.
Escalating the full
even after escalating, there are 10% or 8% who will not respond, who are non-responders to hydroxyurea. In them, see, the drug I had was crizanlizumab for some time.
I just want to add up. In those cases, I think we should go for the molecular levels study. See the polymorphism pattern. Why the person is not responding.
And the answer is we do not still know at molecular level who are the non-responders, madam. We are trying to look at it. But I think the answer is bone marrow transplant. We should go for bone marrow transplant.
Yeah. So
no, immediately for the patient we can go for transplant. But this has to be kept in mind why this is happening in some cases, because we did a study on MTHFR gene, and polymorphism, because folic acid was given and many of the patients were not responding. So we wanted to see whether there was any polymorphism which was causing this to happen. And we were successful in finding this also.
Madam, so, CSR is undergoing this study, and one of the center is Raipur and Nagpur. So we are looking at responders and non-responders. So what are the markers? Yet we are not clear what are the markers for non-responders, and we are looking into it.
That's
CSR
exactly
study.
What I was trying to say, that Dr. Ravin, it depends on how you are assessing the response. The first thing baseline is to ensure patient compliance. Whether the patient is actually taking the drug regularly, then you are saying that the patient is not responding. The second issue which you must consider before labeling a non-responder is that in pediatric age group, there is an expected weight gain which is happening. So the dose had been adjusted accordingly to the patient's weight over a period of time before we label it as a non-response. And as you said, that beyond 6 months of regular compliance, adequate dose being taken, if the patient has not responded, we stop hydroxyurea in our patients. One, not only because of the side effect profile, but because it is a financial implication on the family, and most of our patients are coming from backgrounds where they cannot afford that regular hydroxyurea. So beyond 6 months, if the patient has not responded, we usually stop hydroxyurea.
We do not stop. The reason is, what are your outcomes? You rightly said. Our main outcomes are painful crisis, transfusion, acute chest syndrome. However, we also know by studies that why do we start at 9 months, even if the patient is asymptomatic? This is to prevent organ damage in future. So we do not know whether, before discontinuing, you have to think about the multi-organ involvement, which can be, I think, which has, hydroxyurea has an effect on organ damage. So that is the reason why we continue, unless there are evidence. That is the reason. But then plan for a bone marrow also. Bone marrow transplant is there. But I think one thing is very important. What is your outcome after hydroxyurea? All the studies which you showed, the outcome are 3. Increase in hemoglobin F level, MCV, and I think third was something else. It was a hematological parameter. It was a hematological parameter, not clinical. While the studies we have done in India, our outcome is clinical, not the hematological, because our hemoglobin F is already 16. Yes? So
yes,
there is very little rise in hemoglobin F. I can't have a target of 15 hemoglobin F. So our target is not hematological, it is clinical.
Clinical.
That is what it is.
No, other than that, it was also found that the admission to the hospital, hospitalization,
number
stay,
of admissions,
number
blood
of transfusion,
acute chest syndrome, they were definitely effective. But then what I want to say is, in Indian circumstances, in Indian patients, it has to be seen, and rightly you said, this study which is ongoing will answer
most of the questions.
Quick. Hello. Yeah. The response to hydroxyurea therapy, what should be the minimum observation time? To my understanding, after starting hydroxyurea as per the weight of the patient, I would wait at least for complete 1 year. Not only that, there are variations in frequency of symptomatology in a case of sickle cell disease. So we start with the hydroxyurea, wait for at least 1 year and see the response, look at the hematology and see whether that patient is getting stabilized or not. So I would certainly not stop hydroxyurea any time after 6 months of giving it. That is one. Number 2 is, I think hydroxyurea is one drug which is benefiting patient at a lower cost. It is available to every patient and it is affordable also. So my submission would be, any case who is having a possibility of not responding to hydroxyurea, it requires very, very critical analysis. Many times what we have seen, there are coexisting other elements like rheumatic fever, SLE, rheumatoid arthritis. These are the issues that we must look into. And once we see that, okay, these are not there, then it's fine that you may re-evaluate. But I think majority of the time, I would say in India, every patient should get it as far as possible.
Like with the study that we are going with a multicentric study of ICMR, we're going to follow up the patient for almost 4 years. So with the treatment, and if there is any adverse event and all, we in between will stop and then again start with the same dose or reduce the dose. So that is in
any patient you have seen hyper response of hydroxyurea in the form of elevation of hemoglobin to 13 gram per cent, 40 gram per cent, which will require you to stop hydroxyurea. You have seen that?
I have.
You have not seen?
Okay, I think
I have.
I think we can have the next question during the tea discussion. We'll be having the tea, so you can discuss around that. Because we are running out of time. Just quickly, please.
Dr. Ma'am, in government setting, we are getting in MP we are getting hydroxyurea in capsule form, 500 milligram capsule, but our pediatric patient are 10 kg, 15 kg, so its dose comes around 100 milligram or 200 milligram. So we tell them to give half capsule, but it is very unlikely how to measure half capsule or if 1/4 capsule. So they tell them to dissolve in NS and give. If he is in hospital, we can give them syringe and make the preparation. But in home, how can they make? And so sometimes we tell them to give capsule on alternate day. So it is possible to give on alternate days, twice a week or once a week hydroxyurea.
Alternate days, I think Madam, can hydroxyurea can be given on alternate days? Study. We have now we are being supplied with hydroxyurea 200 milligram tablets, and that can be given. But he is only one person who can supply it throughout India. That's the thing. Yeah, please.
I am not a marketing executive of this tablet, but what I am trying to tell that a tablet form 200 milligram is available. It is a score tablet. It can be cut into half. You can give 100 milligram also, and it is freely available, no issue. The manufacturer is Genflora. It is available in India. It is available in Gujarat. And now there is a tablet form of 500 milligram also. That is also available because we observed that there was problem with the capsule form. It was some problem of getting that capsule was becoming soft. It was difficult to make half and dissolve. Everything was a problem. So now 200 milligram and 500 milligram tablet. It's available. Thank you.
A single vendor is there.
Madam,
only single vendor.
It has come just now, few months, and now I think it's known to we people and majority of us, and now it is available across India. I think that
no, single vendor is there, sir. Because being working in a government institute, we need to have quotation and all three. So the person was not able to provide 3 quotation.
Okay.
So only one single vendor was there. We asked him to get himself in the gem also, so that it becomes easy for us to procure.
Sure.
But
I request Dr. Jyotish Patel sir to please come on the dais and felicitate Dr. Mohapatra. Thank you, sir. Thank you so much. I request sir to stay back. The next talk is by Dr. Jyotish Patel sir. So you will need needing the column?
I'll have a cordless mic this way. Cordless,
So, Dr. Jyotish Patel needs no introduction. He's an eminent personality and scientist and a clinician in the area of sickle cell disease. He has a tertiary care setup in Gujarat, which works exclusively and extensively on sickle cell disease. And I also learned that he has written a book on sickle cell anemia in Gujarati, Hindi and English. So it's an absolute privilege for us that he is with us, and he'll be speaking about the management of pregnancy in sickle cell disease patients. Sir.
Good morning, friends. A case of sickle cell disease and pregnancy went from one place to a second place to a third place, came to us at 7:15 in the evening. In an ambulance, we were called upon to see that patient, and when we saw, she was with a severe pain. She was on the verge of delivering a baby. She had fall in the oxygen saturation, and she was having hemoglobin of 6 gram%. What message I want to give is every case of sickle cell disease and pregnancy should be looked as a severe form, a high-risk pregnancy, and we need to have a definitive management for these patients with sickle cell disease. Here is a protocol that we follow, that in first trimester, usually they should be coming every month. Second trimester, again every month, and SOS, because the complications can be there in the form of painful crisis or anything else. And third trimester, we need to have follow-up at every 15 days. As far as hemoglobin is concerned, we should be monitoring every month in first and second trimester. We should have same hemoglobin estimation at every 15 days in the third trimester, and LFT and RFT at least once a month in initial 2 trimester and every 15 days or month in the last trimester. Ultrasonography should be done in the first trimester, second trimester, and twice at least in the last trimester. The drugs that we use routinely is folic acid supplementation twice a dose than normal, that is 5 milligram twice a day. Iron should be given in the therapeutic doses. We give them chloroquine supplementation. We do not recommend hydroxyurea in these patients. Blood transfusion, we look at their stable state hemoglobin, and it's not a routine that all pregnant ladies should be given blood transfusion. But we certainly have a very close watch on their level of hemoglobin and try to understand that their needs and the possible complications that they can have. Having said that, these are the complications which are likely: preeclampsia, eclampsia, postpartum hemorrhage, oligohydramnios, acute chest syndrome, painful crisis, deep vein thrombosis, and intrauterine fetal death also. You all know about management and routine care of pregnancy. My talk is on sickle cell disease and pregnancy and its vital aspects. Let me cite an example: 21-year-old primary lady, 34 weeks, known case of sickle cell disease, came in an emergency with giddiness, 2 days, weakness, lower limb pain, with a normal temperature, little tachycardia of 116, hypertension of 150/90, oxygen saturation of 94, uterus size was 34 weeks, there was no contraction, it was a breech presentation, and fetal heart was 160 per minute, os was closed. Hemoglobin was 3.8 gram%, which was really a concern, and when we did the ultrasonography, it was oligohydramnios. So now what should be my line of management for this patient? What are my priorities in this case? Should I keep this patient in the ward or the ICU? At what stage I should consult physician and why? And what should I convey to the relatives? It's a high-risk pregnancy with preeclampsia, painful crisis, severe anemia, prematurity. Called physician immediately, he evaluated, and we counseled parents that mother and baby both are having a guarded prognosis, may need termination of pregnancy, intervention at any time. There is a possibility of doing LSCS in this patient and NICU admission for the baby. Having said that, what we did, that there was a sequence of management. The patient was examined, investigations were sent, physicians were called upon, oxygen started, antihypertensive started. Next 30 minutes, we counseled relatives. 2D echo was done. Reports came, medical management started for hypertension, and demand for blood transfusion was immediately sent, and the patient was shifted to ICU. Our ICU is just nearby obstetric, the birthing place. Next 1 hour, we started with blood transfusion, continued with vital and fetal heart monitoring. Patient was comfortable, and ultrasound was done. Outcome was pain decreased, pulse rate came down 106, blood pressure was 134 by 84, and oxygen saturation improved to 97%. Fetal heart also little came down 154, and patient said that I am feeling little comfortable. Why it's not moving? Next please. Hello? Where is that? Because maybe batteries are low. Yeah, that's fine, thank you. It has gone. Yeah, next 24 hours, patient was comfortable, pulse rate came down, blood pressure also came down, fetal heart was 120 to 130. Hemoglobin after 2 blood transfusions was 7.6. At this stage, after 28 hours of admission, fetal distress developed, and we decided to go for, the cesarean section. Fetal heart rate was 114. CTG was abnormal. There was oligohydramnios. Breech presentation was obviously an indication for LSCS. And we shifted patient, we operated. After operation, patient was shifted to ICU, and baby was managed in NICU with 1.8 gram percent, 1.8 kg body weight. This is the second case where a 20 years old primary, 37 weeks pregnancy, sickle cell disease again, came in emergency, labor pain, 120 pulse rate, 134 by 86 blood pressure. 97 was the oxygen saturation. There was significant pallor, and there was a significant icterus. She was in active labor with contractions 2 per minute, 2 per 10 minutes, and when per vaginal examination was done, she was having 30% effacement, and we immediately decided and sent blood investigation. 9.2 was the hemoglobin, and look at the serum bilirubin. It was 12 with abnormal SGOT and abnormal SGPT and low albumin level. So this was really a challenging case. So again, should we keep this patient in ICU or labor room? We kept this patient in ICU, and we started monitoring this patient. We were watching her for anything, any emergency that can come up in due course of time. We gave a guarded prognosis to the relatives. In next 3 hours, what happened was fetal heart sound was 100 to 110 per minute, and it was MSL. So obviously, we took her for cesarean section. We kept 2 blood reserved. It was a high-risk pregnancy, and intraoperatively, patient went into atonic PPH, which was really a challenge. We managed that, and we immediately asked for blood, and it came, and we gave it. What message I want to give, that these are really complicated issues and requires really a good teamwork. a physician, a neonatologist, and a good obstetrician who can handle this situation. We need to have a reserve blood ready for all these patients. Not only that, we should have good backup of the ICU also. So, in a way, the sickle cell disease in pregnancy needs a very specialized care, and they are really requiring good care to have safe pregnancy, delivery, and good outcome of the newborn. We had 2 mortality of sickle cell disease in pregnant ladies, both referred from the government hospitals in the last stage. Rest of the patients who were having good OPD follow-up were fine, and they went safely, and they had a good outcome of the baby and even the mother. One of the lady, she had next pregnancy and delivered again with cesarean section. 10 minutes on sickle cell Swasuraksha Abhiyan, which is close to my heart. I was working for sickle cell in 1983. I was searching for a solution for how there can be a village participation for these cases of sickle cell disease, identification, community involvement, how it can be done. The project partners were village, people, and our foundation. Myself, Bharti, and Narendra Gramit from that time. Narendra Bhai Modi was there as a Chief Minister of Gujarat State, and Narendra Gramit, he was Under Secretary at that time. We designed this project. Let me tell you that it's a tearless death. I have seen, I was by the side of the patient, and I had eye-to-eye contact with the patient. By now, in 35 years, not less than 700 deaths of sickle cell disease I have witnessed. I am standing by the side of the patient. I have eye-to-eye contact with the patient. I have eye-to-eye contact with the relatives, and I have met relative, mother or father, immediately after death of a case. Even we do not ask them to go out from the ICU. We allow them to stand by the side of the patient. And why I have mentioned tearless death, there is a reason behind. I do not know how many of you have witnessed this kind of event. It is very pathetic situation, I tell you. It's very important that every person who is involved with management of sickle cell disease needs to be by the side of the dying case of sickle cell disease to realize that how painful the situation is and how pathetic situation that is. This, in fact, inspired me to design this. Why we thought it was necessary? Because it is a community disease, less known to doctor, less known to people, less known to government. Major cause of death in tribal people, and sickle cell is taken very lightly. I go to doctor friends and say, don't do anything for sickle cell, they require only folic acid and that's it. I said there is lot more thing which can be done for this patient. We named it Sickle Cell Swasuraksha Abhiyan, meaning thereby protect yourself by getting involved yourself. And that is the message we gave to people and solution for the people, and this solution came with community participation. Project design. Stage 1, sensitization of village leaders. How? By giving talk to sickle cell in local language to the sarpanch and the elected members. Sensitization of entire village by all team which came to our hospital for this. Step 3, ask about willingness of village people to get involved into such activity. This was asked by the village leaders to the people of the village, and having done this thing, we decided about their convenient time, their convenient date, and then we went to their place. We gave them the list of the things that we require, and you should be doing it when we come to your village. Having done this thing, we went to the village with the team of the nurses and the doctors and the village leaders. They participated very well. They enrolled all village members. They remained in discipline. They gave sample, and after having received sample from them, we took them to our laboratory, and one thing that we assured them, that you will receive all your results. After 7 days, we will come back to you again. Within 7 days, the cars were prepared and they were given to them. It was a village meeting in which collector was there, DD was there, elected MLA was there, and everybody participated, and we distributed family cards, not individual card. We gave these reports of 5 members, for example, to a single elderly person in the family, and we explained in the village meeting what are our reports, what normal means, what sickle cell trait means, and what sickle cell disease means. We appointed sickle cell health worker, which was selected by them, and what we advised them, that select a person who is committed to do some good work for your village. And having said that, they enrolled one person. We asked them to come to our hospital. We advised him to stay with us, took him into OPD, took him in the indoor round, and then we took him to laboratory also. Having said that, we gave couple of antibiotics, analgesics, antipyretics, BP monitoring, and thermometer, and couple of other gadgets. These worked very well. And when we surveyed all these 11 villages, we analyzed data, and this was the published paper. It was published as a screening for sickle cell gene in Gujarat, a village-based model. It was published in 2012. The model of these, we presented it to Narendra Bhai Modi, and it was adopted by government of Gujarat. I became advisor to government of Chhattisgarh, where also it was adopted, and this model of care has become acceptable to everyone now. What we are doing today is screening. After screening, there is a loop which is required right from village level to higher centers, so that these patients are justified after their diagnosis by screening. I think this is the disease which is going to last for life. We talk about cure, gene therapy, bone marrow transplantation. How many of them are going to receive cure in due course of time? I think what we can assure is, after screening them, assure their care, assure their comfort, assure their education, assure their employment, and assure their needs. I think if we can do that, we are a good sickle cell health worker. We as a doctor are also sickle cell health worker, and one who is not, she is also a sickle cell health worker. It's a combined efforts of all that will put smiles on the faces of people. With this, I end my session. Thank you very much for patient listening.
Thank you so much. I think sir has very rightly highlighted that we need to have connect with the patient and their families, and also kind of emotional connect with them, so that they can have a lot of faith in the clinician who is actually handling them in such critical moments. Thank you sir for sharing your experiences, and we'll be breaking for tea now, but if you have any questions, we can take those quickly. Any questions? Or you can discuss across the tea also, if there are no. Okay, thank you. So we'll be breaking for tea now, and we'll come back in about 15 minutes.
हाँ आगे में इधर से मारोगे किसको? ऐसा कुछ?
request everybody to please settle down. Request all to please take your seats. I request Deepti Jain ma'am to please take her seat and everybody else. Thank you. The next speaker we have today is Dr. Rahul Bhargava. He has an MD Medicine and DM in Clinical Hematology, and he is currently working as the Principal Director and Chief BMT at the Fortis Memorial Research Institute at Gurugram, and we are very elated to have him with us, and he has expertise in blood disorders and bone marrow transplantation, and he will be speaking on the bone marrow transplant for sickle cell disease. Welcome, sir.
Thank you. Hey, good afternoon everybody. Thanks to organizers for giving us an opportunity to showcase where we have reached in this country in terms of bone marrow transplants. It's difficult for many other people in the world to believe that India has taken great strides and leaps in the field of bone marrow transplants.
Please put on the slides.
Perfect. So the topic is very simple, BMT in sickle cell, and the only way to cure bone marrow sickle cell disease is by bone marrow transplant. But are we having a severe disease? That's the question. Does our patient are as severe as Benin and Bantu in Africa, Nigeria, or Middle East, or African American population? Or they are just milder, or there are pockets which needs to be identified and given an opportunity to live longer? That's a pertinent question. What determines the severity? Have we been able to determine, is the HbF the only way to know who's severe and who's not severe? Those are the questions which are burning in our minds. Hydroxyurea will continue to grow. 50, 60 years it has been utilized as a only modality, and Government of India, we are thankful to Government of India that they are trying to organize hydroxyurea and supply hydroxyurea in a continuous fashion throughout the year to the people so that they can live a painful, pain-free crisis, disease or life. But where do we stand in terms of transplants? A country which is still younger, 75 years in independence. The bone marrow transplants in a country of 1.4 billion people, only 5,000 bone marrow transplant takes place. Last 2020 it was 3,000. Probably this year it has gone to 5,000 probably. We'll come to know in this March when people collaborate their data. From 50 hematologists, thanks to institutions like AIMS, PGI, and many other who has produced quality hematologists which has gone and seated themselves into the knock-in corner to produce bone marrow transplant centers. We are hopeful what we need as 70,000 bone marrow transplants is going to be surely at some point or the other we will succeed in that. Because US with a 35 CR population, they do 30,000 bone marrow transplants. That's a gap which we are talking about. And for sure when we say we are the third largest country to have sickle cell disease after Nigeria, Congo, because we travel to Africa, from Gambia to Zimbabwe to Zambia to Tanzania to Kenya to Nigeria, and Nigeria and Congo is severe diseases, where HbF is 2%. Believe me, what you don't see here, you can see there. Every third patient in their children ward is either having a stroke or a painful crisis they are admitted with. I happen to go to Jamaica and Trinidad, and some people from West Indies have traveled all the way to India to get a half-match transplant done. That's the strength of India. That's the soft strength of India, that as a sickle cell, when we are talking about India, this problem, we are not talking just about ourselves, we are talking about the world's problem. Today, these people sitting in this hall are not trying to solve India's problem, but they're trying to solve world's problem. That's how I see a sickle cell. And that's why important is bone marrow transplants, and that's where we come from, that we need to have more transplant centers which are government supported, government funded, where every person, irrespective of their caste, creed and socioeconomic condition, can get a transplant done with the same quality as they will get in America. Because the benchmark is America, and we think we will create our own benchmark of saving lives. That everybody is alive without GVHD, that's an idea. But who will require transplant is a very, very important component of it. Okay? Okay, how do we go ahead?
So you need to. Towards that area?
सर फ्रंट में करिएगा, उधर देख के पॉइंट, हाँ उधर पॉइंटर उधर करिएगा.
Okay. Started. Perfect. So this is my colleague. This is my colleague. And you'll see a lot more people of different colors. Because in India, the disclaimer is, at Fortis, when we do 25 transplants a month, we don't get Indian sickles to get a transplant done. That's a disclaimer. And Dr. Deepti Jain will say that only 21 transplants have happened across India, when we are the third largest sickle cell population in the world after Nigeria and Congo. Okay? So these are the success stories of siblings coming together and getting a transplant done. So introduction we all know, and sickle cell we have all spoken about. Why it is important, why I have put in this map is, when the sickle cell has traveled across Nigeria, somewhere originating in Nigeria, and has traveled to Middle East and to India, somehow it has shed its severity. We have to believe that. We have to see that. Out of 100 people in Africa, you say pick up Nigeria, Africa is a huge lot thing. If you talk about Africa, 70 people are on a severe side. When it comes to Middle East, there only remains 30 people who are severe. And when it comes to India, out of 100, only 10 are severe enough, warranting or setting into the criteria for getting a bone marrow transplant done. That's those 10 people we have to identify. It means you have to find the stick in the hayard. That's where the problem becomes. That's where all of us has to be cognizant what constitutes. It's not like homogeneous disorder like thalassemia, major, that everybody will require a transplant. Can I say today? Can I say that every sickle cell needs a transplant? The answer to that is? Louder? No. It's a specific group who requires transplant, and that's why we feel that we need to understand these data points very importantly. And this is where between 2010 to 2050 we'll be giving rise to 14 crore or 1 crore 14 lakhs people, 40 lakh people more with sickle cell disease, because in Africa it is difficult because of the religious purposes to prevent sickle cell, because you can fall in love with anybody. Somehow Oman and Bahrain has been able to control their sickle cell population in last 1 decade by 70%. Great work done in Bahrain and in Oman in controlling the sickle cell. When it comes to Middle East about thalassemia, Iraq has been able to do a wonderful job in reducing their thalassemia incidence by 80% over a decade. Where are we? If I have to ask all the policymakers today, how many sicklers are taking birth in this country? Probable answer is, we are exploring out from the current figures, but there is no registry. There is no notification. How many thalassemics take birth in this country? Somebody said 1 in hour. In a meeting in Pedicon, somebody said 1 in 1 day. Somebody said 10,000. What is the figure? We don't know. So first thing is knowing the exact incidence. And then only you can say in a decade's time, all these efforts have been able to brought down the significant incidence of sickle cell or thalassemia in this country. So background, hydroxyurea remains the drug of choice. And in Indian setting, if I have to talk about Madhya Pradesh and Chhattisgarh, probably 80–90% people don't have an access to hydroxyurea. That's where there seems to be severe. The moment you put on hydroxyurea, this 80–90% people drops down to 10%. But does it mean that they have to take hydroxyurea lifelong? We haven't discussed about the impotency rates in sickle cell. Have we talked about? These are the very important question, because you put patient on hydroxyurea in a younger age group, their sperm count starts coming down. You withdraw hydroxyurea, their sperm counts goes up by 9 months, but they start developing crisis. So what do you do? It's a gray area. Some transplanters who are hell-bent upon doing transplants, they'll see, let's do the transplant because they have a match. But are they the criteria? So what are the criteria where Indian sickler should be clearly know that if I fulfill this severity score, I need to get a transplant done? That's the need of the hour. And that's what we should be working in the future. In next year, we should have a clear-cut idea for our mindset, for our people of their own social economic condition, that they can understand, look guy, this is how we need to do transplant. ये Google पे लिखा है Indian guidelines में इन लोगों को transplant करने की आवश्यकता है. That's we need. So second point is, after notification, we need better guidelines. So I'll run you through the American guidelines, which they feel where the HbF level of 2% or 3%, does it correlate, does it suit us at a HbF level of 20% or 18%? That's a thing. There's a time to think about it. And we have to really answer those questions from our own perspective. Okay? So HSCT, thus far, HSCT is only curative treatment for transplant, for sickle cell disease. For these disorders, the only way is to have a cure is bone marrow transplant. This is not autologous. You do an allogenic transplant, which means you take it from brother and sister. So I'll show you another problem in front of you. My mother had 7 brothers and sisters. I've got 1 brother, and my son has got 1 daughter, which is called hematology. So my mother had a chance of getting 40% chances of matching within 7 brothers and sisters. I've got 30% chance that I'll match with my brother. But what about my son? They cannot match with hematology. How does he get a transplant? So sibling is one thing. When you go for a match-unrelated donor transplant or a half-match transplant, American says that a match-unrelated donor transplant is as good as a sibling transplant, but can we say it in India? So another problem comes up in front of you. Should I subject this patient for an alternative donor transplant? If he is a match, then it is good. He is severe, we do a transplant. But if he is severe or not so severe and he does not have a match, should I subject him for a match-unrelated donor transplant or a half-match transplant? That problem plagues us all. Because still it is not 90% in Indian setting. If best scenario you see, in our data also it is 85%. It's not 100%. Still there are 15% people who are dying. Let's not talk about how many people you have saved. Let's talk about how many people have died, because that is going to make your strategy to make it 100%. And that's the most important thing. So only 1,000 to 1,500 transplants have undergone transplants for bone marrow for sickle cell disease. Now, current indication. So you have to see the match sibling transplant, you have to see match unrelated donor transplants, and you have to see a half match transplant. That's a very, very important slide for all of us, all the policy makers, because we have to have a very clear-cut guidelines for India. With a mushrooming of centers, and to prevent any gullible people undergoing a transplant without being their knowledge, it's our responsibility to stop also. We should have a policy framework where we are known that who will get a transplant sibling and who will not get a half-match transplant. So very simple. Stroke. Person who has got stroke. So how many people, if I have to ask you, out of 1,000 sickle cells in India, from one particular community, how many people get stroke? There are people from Madhya Pradesh, there are people from, Dr. Deepti Jain is from Nagpur, anybody from Chhattisgarh, probably, I don't know. But in your experience, how many people do you see with stroke in early childhood? Any figures? 10 to 12% from Nagpur belt. What about Madhya Pradesh belt? Any idea? 8 to 10% people do present. When I compare with Nigeria, it is like 30-40%. 40% people in Nigeria gets a stroke. And in America, this figure is almost close to 50% in some certain communities, okay? So stroke remains an important thing. Impaired neurological functions with abnormal cerebral MRIs and TCDs. Another thing is, at the district levels where the sickle cell program has to be there, transcranial Dopplers needs to be introduced. Very, very important, because this predicts whether the patient is going to have stroke in future or not. And then they can be intervened early by referring to a tertiary hospital for doing a transplant or starting hydroxyurea. Recurrent acute chest despite hydroxyurea, recurrent severe pain episode despite hydroxyurea. Now this recurrent word is open-ended. You see, recurrent for me could be 1. For Dr. Tulika could be 5. So it's an open-ended thing. We need definitive things, so as to not to allow the misuse of transplant in this setting. Recurrent, when we say recurrent, we have to define. Rectal alveolization, as we discussed, pulmonary hypertension, recurrent priapism, sickle nephropathy, bone joint involvements, the moment you develop avascular necrosis, sickle retinopathy, and probably a sickle cell lung disease. So if I have to ask you a 21, say 35-year-old present to you with avascular necrosis, with sickle cell, no history of joint, no history of chest crisis, no history of hepatopathy, no blood transfusion. Should we do a transplant? He has a match. He has the money. Or should we just put him on hydroxyurea? He has not taken hydroxyurea ever. Because he never knew, before he developed a avascular necrosis, he never knew that he had a sickle cell disease. It comes boiled down to a neonatal testing, that we could have prevented the avascular necrosis if you would have been hydroxyurea. Patient was put on hydroxyurea, now he's 45 years old, 10 years he has been taking, he has completed his family, he was doing well, so transplant has been avoided. Why? Because the mortality as we go above 12 years of age, as published in Lancet, the transplant mortality starts going up. When it comes to match-unrelated donor transplants, we in China are least represented. 2 biggest democracies, 1 biggest democracy and 1 capitalist communist country, least represented onto the world registry, match-unrelated registries. So indications are that these people from Bahrain, Oman, who are well represented ethnicity-wise, they can be transplanted over stroke and similar indications. Now comes a half-match transplant. So I'll just explain a moment. If the sibling transplant on a scale of 0 to 10, if it is 5 in terms of complexity, then match-unrelated donor transplant is 7 on intensity, and half-match transplant is 9 on severity. So you have to understand that as you go along and do not take the patient on the right indication for doing a half-match transplant, you are definitely going to lose the patient. And that's where this comes in recurrent stroke, severe symptoms unresponsive to hydroxyurea therapy. That's why over 3 columns, the indications have become smaller and smaller and smaller in half-match transplant. So I wish that we could run a study in India to know that how many people will actually ever require half-match transplants. So as to categorically say and review through a committee, central committee, that this patient requires a half-match transplant. Can I have water? So very important, because this is fraught with fear of dying. 60% response rates. If not done in a best of the setting, people can die. So we need to be cognizant when your sickle is not so severe. Then if 10% people require transplant in first category, 4% will require probably an unrelated category. Probably 1 or 2% will, probably less than 1% will require half-match transplant in Indian setting. Let's leave aside the African setting where 30-40% people will require. And if you happen to by chance go to Gurgaon or Delhi, please feel free to visit Fortes, where you'll see of ethnicity of every origin, from Africa to Middle East to India. So it will be eye-opener how these sicklers behave in different communities. And that's the whole idea which we are talking about. So pros and cons of different transplants. Match unrelated potential cure, large cumulative experience, good rate of engraftment, attenuates progressive vasculopathy, disease-free survival is 85, overall survival is 97. Cons, limited availability. This is where we need to work. This should be our strength. We need more transplant centers. Not recommended for adults with severe SCD. The limits we were doing was up to 20 years. Now with newer protocols, this limit has been pushed up to 35 at our centers. Graft rejections, transplant-related mortality. Graft rejections are there, but still does not lead to mortality because everybody has got a now auto backup. In sickle cell, whether sibling or half-match or mud, you always take a auto backup, cryopreserve it, that in case the graft gets rejected, you can take up a backup. Non-myeloablative does not exclude recipient chronic damages, more applicable to adults than severe SCD. Overall survival is 97, but disease-free survival is 79. And I'm happy to see this kind of a data in an Indian setting. Let's encourage. Let the government of India encourage every center to report their sickle cell outcomes to a central lab, where we can show this, to know what is right and what is wrong. And when it comes to half-match, look at the disease-free survival, is 58%. And it is in their best of setting, not in our setting. So you cannot extrapolate this data to an Indian setting. So what I'm trying to suggest to you is, yes, SCD transplant is an option. You have to choose and pick up and choose people very judiciously. This 2021 transplant guidelines came from US. Guidelines suggest SHLA, HLA match sibling transplants, standard of care in patients with SCD who have experienced an overt stroke or have an abnormal PCD. Okay? Second, for patients with frequent pain, the guidelines suggest related allogeneic transplant rather than standard of care. Conditional recommendations very low, certainty the evidence is this. For patients with recurrent episodes of acute chest crisis, the ASH guidelines suggest using match-related allogeneic transplant over the standard of care. For patients with SCD with an indication of HSCT who lacks an MSD, with ASH guidelines suggest using transplant from alternative donor in the context of clinical trial is to be done. An alternative donor transplant has the potential to improve or resolve disease manifestation in patients with severe SCD. The risk related to transplant complications should be balanced with benefits derived from a successful transplant. The very, very important lines which we need to remember. For children with SCD who have an indication for allogenic transplant and match sibling, ASH guideline panel suggests using myeloablative conditioning over RIC. So myeloablative basically is you just ablate everything. You use the conditioning regime very judiciously to kill the cells. Match sibling, 90% chances, cord and bone marrow are similar, but we don't use cord in this country. Long-term results of myeloablative transplant to cure sickle cell. These are the curves which Kaplan-Meier curve shows. There's a huge survival benefit in terms of sickle cell. But do we know, is Indian sickle not surviving as the normal population? Do we know that their life expectancy is reduced by how many years? 5 years, 10 years? Is there an extrapolation from there? Or are all they are surviving 65 years with hydroxyurea? Because these are the questions which we need to answer. If their life expectancy is 65 without doing a transplant and a hydroxyurea, then why to subject them for a transplant? Why to subject the national resources for these problems? But if their survival is less, then they need to be catch up early, which is less than 12 years of age, and then do a transplant and get the survival curves. Because the best transplant result comes in less than 12 years of age. Myeloablative preparation regime, busulfan, cyclophosphamide, ATG is the commonest regime, and if you see, a survival is almost 91%. Myeloablative transplants, ATG has less when you have started using ATG, because the cost of ATG is expensive, it has led to less of graft rejection. You know what is happening? Sickle cell is an hyperimmune state. The immune system of body is hyperactive like thalassemia. When you put a stem cell, they tend to reject. What do you want is an ATG, antithymocyte globulin, to suppress the donor recipient T cells so as not to reject the donor cells. And bone marrow transplant is not a surgery. So 1993 protocol survival shows with busulfan, cyclophosphamide and ATG, which is still a standard for all of us. But what is the problem? Infertility, seizures, press. Because cyclosporine has to continue for 1 year. Endotheliopathy, what we talk about, can be reduced by doing a red cell exchange in these patients. Mixed chimerism is a problem. So it is simpler than thalassemia. Why I say, in thalassemia, the moment you have half donor, half recipient cells, patient rejects. In sickle cell, you can survive with a 35% donor cells as well. So you can allow the chimerism to fall down, and then you can stabilize at 35% and they can still survive. That's called mixed chimerism. So you keep on checking every 30 months, 30 days, 60 days and 90 months of how the donor cells are being established in the body. So mixed chimerism is okay in sickle cell, and that's why we say it is easier. Non-myeloablative transplant, Campeth, is not available in the country, but UK studies shows that is one of the options to utilize, and GCSF is from the peripheral blood and not from the bone marrow. Unlike thalassemia, where you take it from the bone marrow, why you take it from bone marrow? To reduce the graft versus host disease. What is graft versus host disease? When the cells goes inside to the recipient, they fight. They fight and affects eyes, they affect mouth, they affect skin, they affect liver. That's called GVHT. So to avoid that and have a smooth engraftment into the recipient's body, you take the stem cells from the bone marrow. But now, with the availability of peripheral blood stem cells, people are utilizing more of a peripheral blood to be utilized. So what if you don't have a mud? Haploid protocols have come up. Haploid protocol was first reduced conditioning purified CD34. You can isolate the CD34 and give it there. Then come T-cell reduced, partially mismatched donors. And then comes the newer protocols like this, where Joshua has shown that if you use ATG, thiotaper, flu, site, TBI, you can achieve almost 100% survival. Zero mortality and 100% survival. So this was the protocol which has been utilized now. Addition of this ATG, if you can see in this protocol, the ATG has been utilized as half-match transplants. So total patients were 17, MSD3, haplo 14, and you can see the age groups also. So they were going up to 30 years of age. Engraftment in MSD was 100%, engraftment in haplo was 62%. Latest addition of thiotaper reduced the rejection. So from 38%, the rejection dropped down to less than 2%. And that's the success story is. And you see how severe patients were, and they were of the elderly age group also. So it's not getting limited only to children, but also to the adult side also. So expandability of BMT is happening in today's world. Alternative, in the absence of available match sibling donor, the likelihood of minorities having a match rated is less than 20%. 1/4 of SCD transplant limited to use this approach, and most are currently being performed in the context of clinical setting. I will encourage authorities to have a database for a half-match transplant for sickle cell, so that next year if we have this conference, then accumulated data from Indians can come up that what has been the success and how it can be improved upon. And this is the suggested approach for HSCT. Please, dear friends, remember, start early hydroxyurea, which is by neonatal testing, which is soon going to be an Indian program. Start early, treat them early. If they are not responding, subject them early, because these are elective transplants. You can still take 1 year time to collect finances. If you know this patient is having a stroke, if you know this patient is having a recurrent blood transfusion, if you know this patient is having a hepatopathy, if you know this patient is not responding to hydroxyurea, then at leisure you can collect the finances, choose a stem cell center and get a transplant done. Believe me, there are now centers within the government itself which are doing a wonderful job, and the expansion is in front of you, which is Indore. So it is very, very important in terms of transplants, successful transplants. So basically conclusion is HSCT for patients with severe SCD from haploid offers excellent survival. Improved transplant technology coupled with use of alternative donors are associated with reduced graft failures, GVHD and TRMs. For transplants eligible patient without a matched sibling, alternative donor transplants are becoming an option. And probably the haplotransplants are replacing faster than a match unrelated donor transplant because of less of people being represented in India. This is our data, which is a 44 patient data. Disease-free survival was 93% and 81.25% in matched donor and haplotransplants. These are all basically African origin patients whom we have done a haplotransplants and a sibling transplant. This was year back. We have added another 44 patients into this, 50 patients more into this, totaling about to 200 patients. By now we have done sickle cell transplants and the group which does it. So these are the happy faces what you see. Dr. Mansi has moved on. So Dr. Mansi on the left has moved on to Abu Dhabi at Burjeel Hospital for doing bone marrow transplants. Dr. Vikas Dua is heading our pediatric transplants, as we are a group of 20 people, including 5 adult hematologists, 5 pediatric hematologists, along with geneticists and infectious disease specialists. And that's what we do on a day-to-day basis. These are multiple people you will see throughout, and this is what we celebrated 8 months back about journey of 1,000 transplants together in past 8 years. And this is the centers which we had till now in India is 14 bone marrow transplant centers. ESI Faridabad is in government, which is doing free transplants for people. Any person who is from ESI can avail this facility. Bikaner, Indore, predominantly work done by pediatrics. We are a small partners in Indore doing adult transplants. And in Patna, Mahavir Cancer Hospital, again, this is being done free. So ESI Faridabad is free, Bikaner is free, Indore is free, and Patna is free. That's the beauty of the country, is that people in this country, if they know and if you disseminate the knowledge, you can actually do the free transplants for the poorest of the poor and even the middle class people at the reduced cost, because this is the only way you can cure these people. With this, thank you everybody.
Thank you so much, sir. Very glad to see some happy faces at the end of the talk. We'll take some questions.
Excellent talk, Dr. Rahul. A very clear message has been delivered to the audience. Just wanted...
I think instead of message, lots of work has been delivered to the people to do.
Just wanted to know any concern about the splenomegaly in sickle cell anemia patients. Like in thalassemia, we try to reduce the spleen size by giving hydroxyurea and by giving hypertransfusion. So what about in sickle cell?
So first of all, journal sickle cell, the dictate is that you should not have a splenomegaly. Autosplenectomy would have happened and spleen size would have reduced. But if you have a splenomegaly, first thing would be to know whether it's a sickle beta thal or not. And if it is enough sickle beta thal, then also splenomegaly does not pose a challenge. We tend to give a 6 million dose of CD34. Like myelofibrosis, there has been a lot of discussion whether you should do a splenectomy. At our center, we are not worried about reducing the spleen size before doing a transplant. But what is more important, as you have pointed out, is a pre-transplant immunosuppression. So you see, the quest and the hunger of saving lives is so much that evolution brings out the best in the science. The pre-transplant immunosuppression has become a boom for all of us. Pre-transplant immunosuppression means when the patient comes in, they get a red cell exchange, they get an auto backup done, stem cell harvest done, auto backup. Now they get 2 doses of Fludex, fludarabine and dexamethasone, to suppress the immune system. And then this protocol goes in, which makes the life easier because the immune system of the body has been paralyzed and told to accept it. So the pre-transplant immunosuppression is a very powerful agent for sickle and thalassemia in haplotransplants. And if you see the Thailand paper where ATG thiotepa is a very, very powerful drug. And that's how the government has also procured in Rajasthan, both triosulfan, thiotepa and ATG, is the fact that they help in reducing the graft rejections and allowing the things to go smoothly. And that is why it is just not Indian setting. My dear friends, whole purpose when I started the talk is that we are not trying to solve only our problem. There are a group of people in this country who are trying to solve the world's problem as well. So we have a tie-up from Oman, we have a tie-up from Bahrain, we have a tie-up from Nigeria, where people come for a transplant. And that's the soft power of India. That's what makes us proud, is that these centers of excellence have been able to deliver this sickle cell and thalassemia story to Middle East and Africa and make these happy people. Bring a smile on these people.
So you have clearly mentioned the indications of MSD, MUD and Heplo for sickle patients. So same will go with sickle beta thal?
Yes. So I think, so let me put it this way. Every thalassemia should get a mass sibling transplant done. Every sickle beta who's behaving as thalassemia needs to get a transplant done.
Okay.
Now it comes to Haplo. It is a center who shows that 80% plus survival can be shown without fudging the data.
Okay.
Then they're eligible for a half-match transplant, because in a process of having a learning curve, poor people should not die. The whole idea of regulatory approvals and regulation in India has to be that no gullible person without the knowledge, and those people we are talking about sickle cell, they don't know anything. When they are talking about thalassemia, they don't know. Whatever dreams you sell, whatever dreams we tell, they will believe in that.
Yeah.
So half-match transplant has to be carefully picked up in thalassemia. Improvement in science is happening. If you do it with this Thailand protocol, the results are superior, close to 80-85%. And I think now time has become ripe that with the proper centers, they should embark on the journey of half-match transplant in thalassemia as well.
One more.
Please.
So you clearly mentioned the indications for Heplo and sickle. We have a patient, he is not very severe sickle and doing good on hydroxyurea, but he has a history of sibling death in the family. So family is very much concerned about the transplant. How we should go for
So if the sibling did had hydroxyurea and he died of something else, then it's a problem, because he never had hydroxyurea. Now if the sibling who's in question, the patient right now, is doing well on hydroxyurea, he is able to have his normal life, he is able to attend school, psychologically he is becoming better, there are no microinfarcts, he continues to on hydroxyurea. Because every transplant's nightmare is not the success. Once they see the patient dying of GVHD, later down the line, as long as 5 years down the line. That's a nightmare for a hematologist and a transplanter. That is why when you pass out from an institute, you are jumping on everybody to do a transplant. And 10 years down the line, you take a step backward and say, be cautious in your approach of doing a transplant. Do for the right indication so that you don't regret later down the line that this patient didn't require transplant.
Thank you so much.
Thank you very much, Rahul sir,
Sir,
for giving an excellent talk. I would like to know how many adult patients you do the red cell exchange before going for transplant.
Sir, all. So once we have burned our hand with press, with bad cyclosporin-induced posterior reversible encephalopathy and endotheliopathy leading to schistocytes, we made it a policy that we will do in all. So out of 10 adult, which is like 21 years and above, we do red cell exchange in all.
Thank you.
And that's pre-transplant, which makes a life. The idea is, let's bring down the sickle cell to less than 50%. So purpose of red cell exchange, all the students which are sitting here, do whatever. If you bring down the red cell population with sickle cell to less than 50, then you are safe. Then less of complications. Yes, ma'am.
Yeah. So excellent talk. And I really commend you. I think you're doing a stellar job.
Because you taught us. So Dr. Tulika taught us.
Oh, you're so sweet. So one thing I just wanted to comment, and it's more of a comment than a question, that yes, you presented the recent ASH guidelines, and earlier we had the Walters guidelines, and there's also some guidelines that Dr. Krishnamurthy has recommended. But again, these are not based on Indian patients. So I think this is about time that in India, we looked at our data, we got the clinical severity of our patients, and we can come up with our own Indian guidelines. So that is something I would like to propose, and if anybody here would like to contribute, I think this would be a really good thing that we can do, and then we can select the right patients for transplant. And one last point, now we're using PTCY even in match sibling transplant for aplastic anemia. So where do you see that coming in? Because it will definitely help with the costs.
Yes, ma'am. So very important question, ma'am. We did 3 PTCYs for aplastic anemia, and the result reported in the world literature is not even, we are close to that. The reason is, with PTCY, larger number of days for engraftment, which goes to 15, 16 days, and we are still dealing with Klebsiellas either in the hospital or inside the gut. So that's one of the reasons. And second, post-transplant cyclo, the CMV reactivation is a very, very common thing. So that becomes a problematic thing when you start using ganciclovir. So I think we are happy right now with PTCY in haplos, but we have not subjected our patients for PTCY in a sibling transplant. Though we are aware the CIBMTR data shows that PTCY is superior, the CMC Valor has shown that they are superior, or less of GVHD down the line, but in our hands, cyclomethotrexate still holds its ground, and we are still like happy with 88% of real life, real world practices. So we have not changed, but yes, this can be subjected to change depending on which center you have been trained and how you can handle your infections, but that's an open discussion and open field.
Okay, I think we'll take the questions now in the lunch session.
Please, there are 2 questions.
One more. Please, very quick. Yeah.
Sir, splendid discussion. I had one patient at Indore Center Only Medicine Department who was some 17, 18 years old and was actually in sickle cell hepatopathy. He became altered in hepatic encephalopathy. Then after exchange transfusion, he responded brilliantly well, and he came with bilirubin of like somewhere 34, and of which around direct was somewhere 25-30. And after exchange transfusion, he improved phenomenally well, and he was discharged walking with somewhere 3-4 was his bilirubin. I just want to know whether if we are able to provide a proper match for that patient. Only one episode he has developed till now. Should he be subjected to...
So first question is he on hydroxyurea?
Now we have started.
Perfect.
Earlier
so if he is on hydroxyurea previously and on hydroxyurea has developed this, then I said, please jump right now, go back to Indore, find a match and do a transplant. Okay. But now you have started hydroxyurea, watch him for 6 months to 12 months, see how is he doing. If he still comes back at the maximum dose what Dr. Mahapatra has told you, then you can subject them for a transplant. Okay? So idea is, transplant people should be subjected once they have failed a trial of hydroxyurea. Please, when you go back home, of course, a person who's requiring blood transfusion is not going to go better with hydroxyurea. So let's ask ourselves, what are the things which are going to become better with hydroxyurea in terms of sickle cell? Pain crisis? Yes. Thrombosis? Partially yes or no. Probably 30-40% people might respond, but rest will not if the transcranial Doppler velocity is high. Third, chest syndromes will become better. What will not become better is transfusions. A hemolytic of a sickle cell who is requiring recurrent blood transfusion, they are not going to become better with hydroxyurea. They need to be subjected for a transplant early. Okay? So give, Dr. Deepti have a different view. Please. So ma'am, so it is about all or none phenomena in sickle cell. Whether you are transfusion independent or transfusion dependent, that's what makes a difference in sickle cell. In our experience, sickle cell, where there's a hemolysis or a transfusion requirement in sickle cell, we have not been able to achieve a zero transfusion independence or transfusion independence with hydroxyurea. That is our example. That is our experience. Could be different. But rest, of course, these things become better. So you have to find out whether the patient has responding to hydroxyurea or not. And if the patient is not responding to hydroxyurea, suggest them for early transplant.
Number one is correlation of fetal hemoglobin level and a severity of the disease. We analyzed 1400 cases with their HPLC data, and literature says that it is an even distribution of the fetal hemoglobin in the red cell which makes them better. We have a 2% fetal hemoglobin which is fine, and we have a 35.4% fetal hemoglobin which is worst. So I think correlating fetal hemoglobin and the severity of the disease, okay, it's fine. But at the same time,
it's not 100%.
It's not 100%.
Let's put this way.
Yeah.
It's a crude marker.
Yeah.
But it is not an absolute marker.
Absolutely marker.
Agreed.
Over 35 years, I talk about pre-hydroxyurea and post-hydroxyurea. We are that kind of generation.
Perfect.
Yeah. Pre-hydroxyurea, if I have to talk about, we started using chloroquine prophylaxis long back in a patient of sickle cell disease. We know for sure that malaria and sickle cell go together. And even in India today, Vivax malaria is definitely there. And there is a need to include chloroquine prophylaxis or any anti-malaria prophylaxis which is good, which will decrease the frequency of blood transfusion, the splenomegaly, and also the frequency of illnesses they have. This is, I am talking about pre-hydroxy era. After using hydroxyurea, bottom line stays that use of hydroxyurea has made remarkable difference in our cases of sickle cell disease. No argument as far as that part is concerned. Coming to the third thing, that what was the youngest age of Indian patient that you transplanted? What was the youngest age?
We have not.
We have not.
We have only done 2, which is 10 and 18. That's all. We have just got 2 out of our data. 2 Indian patients out of the database of 200.
Okay.
The rest is all African. That's a disclaimer.
So
the reason is, and I tell you the reason is, we hardly find people with sickle cell who are severe enough to get a transplant done. Probably we are either not doing the camps in the right region, or somehow the Indian sicklers are not that severe. There are only 2 reasons which can happen. But in my opinion, in my understanding, in sitting in Delhi, which is either way very, very far away from a sickle belt, where we have to travel and sickle can never travel to our centers for sure, that's the reality.
And 2 that you transplanted, how much time has passed?
Sir, 4 years, 3 to 4 years. एक सागर से है, मतलब मध्य प्रदेश वाली बेल्ट से, एक सागर से, एक खंडवा से.
Okay, so it's just a 4 years.
4-5 years, sir.
And they are totally asymptomatic.
They're asymptomatic. Absolutely. 100%. Chimerism 100% है, sir. So ये अफ्रीका के सर सारे बच्चे ठीक है, क्योंकि वही उन्हीं के पास हर महीने जाते हैं हम लोग. जैसे आप सब लोग गुजरात में जाते हैं, कोई धार जाता है, कोई कहीं जाता है, हम हर महीने कीनिया जाते हैं या बहरीन जाते हैं या हम नाइजीरिया जाते हैं. So my colleague Vikas Dua travels Nigeria every 1.5 months. That's a frequency. And Nigeria is not close. Nigeria जाने में 16 घंटे लगते हैं. तो मेरा मानना ये है कि हम सिकल सेल को अगर राइट टाइम पे आइडेंटिफाई करेंगे और उसको चेन ऑफ कमांड से रेफर करेंगे, तो मुझे लगता है कि आपके पास फिर भी, क्योंकि नंबर इतना बड़ा है, वो 1% भी ट्रांसप्लांट का बड़ा नंबर होगा. बट वी हैव टू आइडेंटिफाई देम. दैट्स द मोस्ट इंपॉर्टेंट थिंग. और वो आइडेंटिफिकेशन में 1000 को आप स्क्रीन करोगे तो शायद आपको एक मिलेगा, क्योंकि आप कहोगे नॉर्मल है, तू नॉर्मल है, तू नॉर्मल. और अगर आप करने लगोगे सबका ही सिबलिंग जिसका है, तो वो फिर वो ठीक नहीं है. बस दैट्स ऑल. इट हैज टू बी यूटिलाइज्ड जुडिशियसली इन सिकल सेल. There are gray areas in sickle cell. Keep on asking ourselves what we can do better. But for sure, bone marrow transplant cures not only sickle cell, but hematological malignancies. And we need, friends, 70,000 bone marrow transplants. And we need your help to propagate कि transplant आखिरी चीज नहीं है, वो appropriate चीज है. Thank you, everybody.
Thank you so much. I now request Dr. Tulika Seth ma'am to please come on the dais and felicitate Dr. Bhargava.
This is nice, right?
Thank you, sir, for the wonderful talk. We now move on to our next eminent speaker. It is Dr. Yazdi Italia. He is the Honorary Secretary in the Valsad Raktadaan Kendra at Valsad, Gujarat, and his field of interest is hemoglobinopathies, blood banking, clinical biochemistry, toxicology, and the government of Gujarat has honored him with an award for his excellent services in the field of public health on the 56th Republic Day of India. And he will be speaking today on the universal screening of ANC and PND for prevention of sickle cell disease.
Hello everybody. I must thank the organizers for inviting me and presenting the Gujarat model as well as what work we are doing on prevention for the sickle cell program nowadays. So greetings from Valsad Raktadaan Kendra where we work. It is a sickle cell anemia control program's birthplace. We are bringing science to the doorsteps of tribal community. We are very much thankful to Dr. Sarjan for coming regularly to Gujarat and giving us guidance, and we started with his advice and everything. I think with Dr. Bhargava's lecture, I must now invite Dr. Jain from St. Jude from Memphis to do some more work on sickle cell. Otherwise, I think it remains incomplete. So, we started our, as we know, in 1952, sickle was found in India. In 1978, the first patient of sickle cell was diagnosed at Valsad, and since then we are working on that. In 2006, Government of Gujarat initiated the sickle cell program, and in 2003 we are working for prevention of sickle cell. So here is my first patient, diagnosed in 1978. He lived for 76 years. He was diagnosed in 1978 and died in 2020. He lived for 52 years after the diagnosis of sickle cell without much crisis. This is the second patient, once again diagnosed in 1978. He was born in 1940, died in 21, lived for 80 years. And he was diagnosed at the age of 28 years. He himself is an Ayurvedic doctor, was an Ayurvedic doctor, and believed in yoga and regular medicines and everything. Without much crisis, he lived a normal life. So looking at this first patients that they are tribal, they will never go to the pathological laboratory for blood tests by spending their own money. And so I thought, it is not a one-man show, it is not Italia's show, or it is not a one organization show, and government must do it for them. So I was successful in advocacy to our politicians, particularly the present governor of Madhya Pradesh, Sri Mangubhai Patel, who was finance minister at that time, he was a tribal welfare minister at that time, and Narendra Modi was our chief minister. Once Modi Sahib has learned about this sickle cell disease, and he clearly guided me to do what you think best. So this is how the program started. And in 13th January 2006, a resolution was passed in the government appointing Valsa Raktadan Kendra as a nodal agency to implement program in Gujarat state, in South Gujarat area. And 13th July 2006 is a landmark written in golden words in the medical history of India that Gujarat is the first state in India to incorporate sickle cell anemia control program in the state government medical services. It was inaugurated by the present governor of Madhya Pradesh, Sri Mangubhai Patel, and other ministers. And Dr. Sargent was also there. Actually, the Dr. Sargent was, he has only inaugurated. Mangubhai Patel Sahib was chairman, was chairing the session. So sickle cell anemia control program is a public-private partnership program run by the government of Gujarat along with Valsa Raktadan Kendra with the aim of prevention of sickle cell disease, childbirth, prevention of death from sickle cell crisis, and improve health status and quality of life of sickle cell disease patients. So there are 14 districts which are tribal. So first we initiated the program in only 5 districts of South Gujarat and then spread it to other areas also. In 2007, another decision was taken by the government to do the mass sickle cell screening of all tribal people of Gujarat. This was something unique. The result of this mass sickle cell screening, that out of 1,40,000 or 1 crore 40 lakh tribal people, 96 lakh tribal people were screened at the doorstep of their house. We found 7,22,000 sickle thread and 29,555 as sickle disease. So this is, if you consider this as an authentic survey, mass surveys, I don't think any other country or any other state has carried out this type of survey before. So here you will find that if you consider the percentage of sickle disease or sickle incidence, then in India we have a population of 139 crore. Out of that, 11.95 crore are tribal. And if you consider 7.46% sickle threat incidence in Gujarat among this mass screening, total 89.73 lakh people are having sickle threat in India and 3.58 lakh people are suffering from the disease. And if you consider 17.64% decadal growth, so every year 6,324 new sickle cell disease births are there. We give them color-coded card, white card for normal person who is not sickle. What we did, we carried out the test with a solubility test. Any person having clear-cut solubility result negative or positive were reported. Those who are doubtful and positive were subjected to HPLC, and after HPLC we have given them yellow and white card for trade and complete yellow card for disease. Most of patients in Gujarat now have this type of cards. So these color coded cards are used for marriage counseling also. The 2 yellow card holders should avoid marriage. Here you can see that IEC is very important for each and every step, every level, and horoscope readers also advise that if 2 yellow card holders marry, then the child may be affected, so avoid it. So this is going on at the moment, at least in South Gujarat area of Gujarat. We did newborn screening also under one Indo-US collaborative project, and we have screened 6,954, total 8,517 newborns, and found 1,341 sickle trait, that is 15.74%, and sickle cell disease patients were 104, that is 1.22. But this is among the high-risk group people, particularly in the area which we have covered were very well known for high incidence of sickle gene. We have given mobile phones at that time to all patients, and telemedicine was initiated at that time. Unfortunately, we have done follow-up for 3 years. If we have done follow-up for more years, I have repeatedly asked ICMR as well as the Gujarat government, but somehow I failed in advocacy that it was not started, otherwise we can have a good follow-up and a natural history of sickle disease patients in India. Modi Sahib has taken a lot of interest, and it is a strong political will because of which we have succeeded. On 21st April 2011, 21st April is known as a Civil Service Day, and that day all good work done by the IAS officers or other government people is awarded, and we got the Prime Minister's award on that day for this sickle cell program because it was going to benefit large number of tribal population which was neglected so far. This is at Vignan Bhavan. So in the program, we give routine medicines like folic acid, analgesic. Hydroxyurea are also provided at the doorsteps to multi-purpose health workers in the field. Hydroxyurea is provided free of cost and medical advice with the due counseling and consent from patients and family members for regular follow-up. When we have made this program, we have written that hydroxyurea should be given uninterruptedly. It should not be like that once you start and at one moment it is not available at the PSCCSs. Pneumococcal vaccine is given to all sickle cell disease patients. Routine investigations are carried out at CSC and general hospitals free of cost. And 108 free ambulance service is also available. We have 184 counselors for sickle cell project. These counselors are always in touch with sickle disease patients, and they have to make at least one phone call in a month to ask about their health and other things. Any patient who has some problem, they always are in touch with these counselors, and these counselors will advise them what to do, what not to do after asking the medical officer of the nearby PSCCS. So this is a SCC EMO group. EMO is an epidemic medical officer, and in Gujarat, every district EMO epidemic medical officer is a nodal officer for sickle cell program. If you write in this WhatsApp group, immediately actions are taken by the nearby counselor and they will also report. During 21-22, out of 2,53,903 total ANC cases in government hospitals, 1,50,581 tribal ANC cases were screened for sickle gene. Out of that, 2,545, that is 1.69% were trait and 169.11% were disease. These are the ANC cases. All positive people's husbands were screened and high-risk couples were counseled for PND, and those who were ready for MTP were subjected to PND before 20 weeks of pregnancy. This is very clear. This is 100% voluntary, purely voluntary, and overall, since introduction of PND services in Gujarat, free services in Gujarat, totally 613 MTP were done. That means 613 sickle cell disease childbirth were prevented. We have also come up with comprehensive sickle cell clinic. It is a concept of GO-NGO partnership program in government hospital only, where government appoints one doctor who is always there, resident doctor who will look after these patients anytime, 24/7. And being a one doctor who is going to look after will have a good rapport with the patients, and patients will also come regularly to them. We appoint, as an NGO, we appoint a technician and a counselor to help these patients over there and see that everything goes well. So all these services are given there. Even if they need blood transfusion anywhere in the Valsad and Navsari district, the counselor will arrange with the blood bank, and all blood banks provide free blood to them. We have appointed one hematologist who visits every month these centers. We have two centers at the moment, one at Rumla and another is at Dharampur. And all services at this comprehensive sickle cell clinic provided free of cost to tribal rural patients at CSC Rumla and Sub-District Hospital, Dharampur. If anything is needed and if it is not available at this center, the NGO provides them and helps them out so that things goes well and the patients are better treated. Sickle cell disease and thalassemia major are preventable diseases. So time is not far away that universal screening of hemoglobinopathy starts in India for all antenatal cases. Valsad Raktadan Kendra has taken initiative, and we have received a CSR funding from Bayer India Private Limited for this purpose. And this is a purely voluntary initiative. Universal antenatal screening for hemoglobinopathy for prevention of thalassemia major and sickle cell disease childbirth in Valsad district means all the patients in rural as well as in urban area are going to be screened in private as well as in government hospitals. So we expect that most of the patients, nearly 100 patients, if not 100, at least 80 to 90 will be screened by this technique, under this program. This is a step forward for Anemia Mukta Bharat. So, to prevent childbirth with thalassemia major and sickle cell disease, every antenatal patient should be screened for hemoglobinopathy by electrophoresis, by HPLC, or by point of care rapid test in case of emergency. And if the pregnant mother is positive for any abnormal hemoglobin, then her husband should be screened. And if both are positive for abnormal hemoglobins, the fetus, the unborn child, should be screened. This is a prenatal diagnosis and should be carried out. PND is purely a voluntary initiative. It is purely a voluntary initiative, and those who agree for MTP are only subjected for prenatal diagnosis. Those who do not agree, we don't touch them. So this is the things we have written in our Gujarati language. So this universal ANC screening program amongst approximately 25,000 to 30,000, that is 100% ANC cases of Valsad district, both in rural and urban areas, as well as government and private hospitals, will reveal precise incidence of percentage of different abnormal hemoglobins in our general public. So far this data is not available. Probably we may be able to give you within a year or two. So this is a CSR activity of Bayer India. This is the form which gynecologist has to fill up. So any family who had come across with sickle cell disease child does not wish to have another such child in their family. They do come forward before marriage for counseling for other family members. The majority of population in South Gujarat, that is Zodia Patel, Game, Chaudhary, etc., understands the gravity of the sickle cell disease, and if explained in a friendly manner, they are utmost willing to improve their health status and will follow most of the advice. So, just give a thought. This is very something unusual I may be telling you. When we say that sickle should not marry another sickle, am I right? Sickle should not marry another sickle. Thalassemia should not marry another thalassemia. Thalassemia should not marry a sickler or any abnormal hemoglobins. Is it not true that we are introducing an abnormal gene, which is sickle, into a normal family? They have to marry with the normal family. The partner should be normal, either thalassemic or sickle. The partner should be normal. So we are adding an abnormal gene into a normal family. Am I right? Every 25 or 30 years, the generation changes. बच्चे के वहाँ दूसरा बच्चा आएगा, उसके बच्चे के वहाँ दूसरा बच्चा आएगा. So after 15-20 generations, probably large number of people will become carrier. फिर शादी किसको करेंगे? You are adding sickle as well as thalassemic gene. Now we have technique of prenatal diagnosis. दो बच्चा है तो डॉक्टर लेबल भी मारेगा कि ये बच्चा सिकल डिजीज वाला है या सिकल प्लेट वाला है. अगर उसको एमटीपी करने का है तो वो सिकल डिजीज वाला का ही करवाएगा. इतना अपना मीन्स we have learned that our sonologists and gynecologists are quite competent enough to do it. लोग प्रेम में पड़ते हैं तो कभी पूछते हैं क्या? नहीं पूछते. तभी क्या करते हैं? हम उसको एडवाइस देते हैं. Don't worry, come to us as soon as you are pregnant. We will advise you what to do. But we are going to advise prenatal diagnosis. So why not let people marry with anybody? Screen all antenatal patients. Screen each and every antenatal patient. Make it compulsory. If it is not compulsory, make it voluntary. I am telling to my gynecologist that if you fail to do hemoglobinopathy test of your patient and if child turns out to be thalassemic, you are responsible. गरीब में गरीब आदमी भी ऐसा बोलेगा कि हमको क्यों नहीं पता है, हम टेस्ट करके लाते हैं, मेरे को यहाँ ऐसा कैसा बच्चा आ गया. One of judge, a young judge in our court, Valsad court, has a thalassemic major child, and he was asking me, kaisa aa gaya? Who is responsible? Is it that gynecologist or obstetrician? Why he has not advised? So, it's not working. Why he was not advised? हम भी तो एडवाइस करते हैं. अगर कोई शादी करेंगे, हम कॉलेज में जाते हैं, बात करते हैं और बोलते हैं कि ठीक है आपको कुछ प्रेम हो गया तो डोंट वरी. हाँ, सब लोग ऐसा अपना क्या नाम, अभिषेक बच्चन एंड कपूर,
हाँ, वो दोनों शादी करने वाले थे। हम अभिषेक बच्चन कपूर के साथ शादी करने वाले थे, वो नाम भूल गया मैं उसका, करिश्मा कपूर के साथ। बहुत चला, लेकिन फिर बाद में कुछ हुआ नहीं, बिकॉज बोथ वर थैलेसेमिया माइनर। अमिताभ बच्चन तो थैलेसेमिया माइनर के लिए ब्रांड एम्बेसडर है। तो वी हैव नॉलेज, वी हैव साइंस। जब भी हमने प्रोग्राम शुरू किया था 2006 में, तब हमने तय किया था कि वी विल ब्रिंग मोलिकुलर लेवल फैसिलिटी फॉर ऑल ट्राइबल पीपल। Even in ICMR has initiated one program under Jai Vignan to establish this molecular level characterization at different levels. We were also partner in that. We have also molecular laboratory in Valsad. I had invited 6 medical college people from Gujarat, from different areas, to take training. Dr. Ghosh and Dr. Roshan Kola and the team came to us, and they have given training to them. 1 or 2 secretaries of Gujarat, health secretaries, were also of the opinion that we must start this molecular lab in different all RDD regions, means regional deputy director जो है, वो हर एक region में एक ऐसा center होना चाहिए. But after they were changed, another people came in power. They had no interest in sickle cell, and I was not able to make them understand this point. And later on, now we have outsourced the whole P&D process. So government has appointed doctors who collect a sample and laboratories who test it instead of government medical colleges. Anyway, things are being done, and it is done in a very good manner. On Saturday, I received a phone call from a doctor, private doctor. One of my couple is sickle positive. I told her to send me the names and address and phone number. And today I received the message from this group of sickle cell on WhatsApp that patient's PND is done today. Their photograph with the PND जो क्लिनिक है वहाँ से उनका नाम भी उसमें दिखता है, कपल भी दिखता है, और उसका PND done, report is awaited. So all these type of things are going on in Valsad, in Gujarat. PND is absolutely free. If you are a hematologist and seeing the patients of Gujarat, don't hesitate in sending them back to the government centers to take medicine. Most of the crises are also being treated under different programs of government. So this is my one. I have presented this at the anthropology laboratory, at the anthropology conference at Delhi University also, about this increasing the number of trade and carriers. So road to anemia Mukta Bharat, which is a dream of our Prime Minister, goes via thalassemia major and sickle cell disease Mukta Bharat. So we have to work for that. Our sicklers are born with pain, live with pain, and die with pain. They hardly complain. Thank you very much for paying attention to them. Thank you.
Thank you so much, sir, for your for letting us know about your extensive work and the way you have worked for the tribal population of our country. And it's really a wonderful. I mean, it's really an honor to know about the kind of work you are doing. We can take few questions. If anybody has any questions anybody wants to know something more.
I'm not a clinician, neither am a big scientist. I'm just a translational scientist. Whatever I have learned, I have tried to implement for the benefit of the people. Thank you.
Thanks. So you can just please go. I would now request Dr. Vinita Srivastava to please come on the dais and felicitate Dr. Italia. Thank you so much. We now move on to the last speaker of the day. It is Dr. Ruby Khan. She's a MD in pathology, MD pathology, and working as Deputy Director in the NHM. She is the Nodal Officer for Blood Transfusion Services, Laboratories, Diagnosis, and she's also taking care of the state hemoglobinopathy mission. And she has been instrumental in strengthening the healthcare facilities by various innovative practices like introducing the PPP model. So I now request Dr. Ruby Khan to please come on the stage for her lecture.
Good afternoon all. My lecture is just before. My lecture is just, after my lecture there is lunch, so I think I should complete it early. Because, but after listening many experts here, and so I felt that I am on the ground. I have to do a lot of work here for the people of Madhya Pradesh to get rid of this sickle cell anemia. So first I will, actually I am here working since 2018-19. I have started because I was looking after the blood transfusion services and lab services in Madhya Pradesh. Previously there was no dedicated program or cell for the sickle cell in Madhya Pradesh. The things or any requirement comes from the district level for the patient of sickle cell or thalassemia. They will go to the NCD. Then NCD people send it to the blood transfusion people. Then we send it to the pediatric child health. So it is like that nobody is taking ownership of this program. And then I don't know how it like the doctor who was the nodal looking after this program like sickle cell and NCD, she was in leave, so that came to me that because you are looking after the blood transfusion, till then you also look this program also. So I started because I was working in the district. Previously I was a blood bank officer there. I was a pathologist there. So I was feeling like when the children of the sickle cell and thalassemia came to the blood banks, we could not offer much help to those patients except for providing blood transfusion and some testing services, but previously in district hospital we could offer only the CBC or routine diagnostic services to them. So when I joined, I was working for strengthening of blood transfusion services along with laboratory services. So we started so many new things because I was lucky we have very good administrator with us, so they helped me a lot. They understand my needs, what I want to do, and they helped me, so I could able to do this. So here I will start my what initiative the government of Madhya Pradesh has taken for the sickle cell. So next. Okay, I will just. So this is the basic introduction of sickle cell anemia. I think all of you know. I had put this slide because. So this is all sickle cell, and this is type and symptoms of sickle cell anemia along with the inheritance of sickle cell with symptoms. I will rush to the next slide. This is the prevalence of abnormal the sickle cell anemia. Previously, like in Madhya Pradesh, it is a vast state. Like we have 52 districts and 22 to 26 tribal dominated districts, where 20 districts are where the 80 or 90% population are from the tribal areas, or they belong to the tribal areas. And many small, there are like ICMR, we are doing the studies, they were doing the screening, and many NGOs were there who are working in the tribal areas, they were performing screening, but we at the state level, we were not having any data of the screening, like what is the prevalence, what is the actually the number of the sickle cell patient in the state. So we have taken only the data which like previously work done by the ICMR Jabalpur, and we could able to know there are the districts where the high prevalence of sickle cell were there, in which the most affected tribal dominated districts were Alirajpur, Baitul, Shahdol, Chhindwara, Barwani, Dhar and Jhabua. But I found that even like it was thought that it is only in the tribal community, but we could able to found that in other community like in OBC and in other here in Bhopal also we had diagnosed many sickle cell patients. So due to migration, I think because many children from the tribal district, they are migrating to the other metro cities for education or other thing, and they are living there, they are studying. So we are getting patients in other district also. So this is like if the patient, 20% of the children with sickle cell dies within 2 years, and 30% of children from the tribal community suffering from sickle cell disease and die before adulthood, because there was no clear-cut guideline for the treatment, for the testing of these patients. The average age of the sickle cell patient in India is, thank you sir. Now, in 2021, I think when, because we had started, I put lot of efforts, and my team, my administrator, I told again and again, like if you're talking about screening, you're talking about for anemia Mukt Bharat, and in various like whenever we do the maternal death review, then we came to know there are the many deaths in antenatal period. It is due to the anemia, and when we trace those patients, they were from the tribal areas, and when we go like we have seen the reports of those patients, then they are either trait or they are not diagnosed, but there were some hemoglobinopathy or some hemolytic anemias to those patients. So at that time I emphasized then. And at the same time, the governor, Shri Mangubhai Patel ji have joined in Madhya Pradesh, and then we started in June 21, we had started hemoglobinopathy mission for screening and for management, for prevention of sickle cell, thalassemia and other hemoglobinopathies. We had started a pilot project and in the Jhabua and Alirajpur district on 15th November 2021. And when the Honorable Prime Minister came to Madhya Pradesh, and we launched this project, and then after that launching of that project, we could able to do the provision in the state budget also. Now dedicatedly for state hemoglobinopathy mission, we had a new line or budget head in the state head also. Previously we were getting budget only from the tribal department. Now, we have done strengthening of health facilities for sickle cell anemia in Madhya Pradesh. Like we had established lab for diagnosis of hemoglobinopathies at, we had provided HPLC at each and every district hospital of Madhya Pradesh so that diagnosis could be made at the district hospital level only. Otherwise, previously we have to send the sample to the medical colleges or to the other laboratories. And we had strengthened the treatment facility. Previously, the hydroxyurea was not available to the patient. Now it is in the essential drug list of the Madhya Pradesh, and also it is available free of cost to all patients. Now, we had created sickle cell portal. The major challenge which I was facing, like the record. I was getting record from various agencies, from NGOs, but I was not able to get that whether it is the same report. Sometimes it is a duplication, because many NGOs were working in the one district only. So we had started sickle cell portal for digital health record maintenance of sickle cell patient, and the pilot project which we had started on 15th November, we could able to complete that pilot project on July 31st, 2020. And then after that, we had expanded that project. In the second phase, we started screening in 89 tribal blocks of 20 districts of Madhya Pradesh. So this is how we are saying, like we had taken an initiative in the lab services also. In Madhya Pradesh, we started a new model, wet lease reagent rental lab model, where in district hospital laboratories we have placed all 6 automatic, fully automatic equipment: hematology, biochemistry analyzer, urine analyzer, automatic hormone analyzer, automatic coagulation analyzer, and HPLC machine, so that we could able to cover all the diagnostic facilities. Like various programs are running in the state, because there are a lot of programs in the National Health Mission, like coagulation profile, which we could able to do at the district hospital, so we could able to diagnose hemophilia patients. So by this, along with HPLC, we are having automatic coagulation analyzer. The major challenges, even though like I came to know in the medical colleges, they are having these kind of high-end equipment, but they are not able to perform the test due to unavailability of the reagents, because these are the closed system machines, and for this reagent and consumable they require a good amount of money, which the government could not able to do. So that we were facing the same problem, but we had started in the reagent rental mode. So we had outsourced, or we do a tender, we had done a tender, and we selected a company with the lowest rate, and that is in the discounted rate from the NABL rate, and then we got the price of each and every test, where in the health facility we had provided only the space, the electricity, and the water connection, and the HR part is with us. The agency people are providing all machine, all automated. They have provided bar-coded this sample collection tube, this LMIS for these machines. So now from last 2 years we could able to digitalize the or we can automate all pathology laboratories. We do sample collection in the bar-coded tubes, and that automatic, there is no manual intervention in the pathology. All tests has been done through these automatic machine, and the data is uploaded in the portal. And every day in state, I am having a lab dashboard where I could able to see each and every report, like every day how many patients are there. I am having a big screen in my chamber where I could able to see how many districts are performing which test, the number of tests. Even I could able to see the patient data, how many ANCs are there, how many ANCs who are having less than 7 hemoglobin and other parameters also. So we, along with that, we are doing the capacity building of all health workers, from CHOs, from the PSC doctors, medical officers, and along with that we are doing the capacity building of lab technicians, doctors, pathologists, and specialists in the district. So this model, these are the machines at the district hospital where you could able to see these are all our automatic machines, and we are doing these tests. So for sickle cell management, we had made the action plan, where first we had started with the public awareness, where in which we had taken the help of some NGOs or the volunteer organization, those who are working in the field of sickle cell in the district, where the Jan Abhiyan Parishad and Jan Swasth Sahyog Sanstha, we have taken the help of these people and to create a conducive environment for public awareness. And then we started the screening. Previously, we had started screening with the solubility, and then later on the screen positive samples are sent for the HPLC at the district hospital. We had started on spot or the community level screening along with the facility level screening. We have decided the target group. In the first phase, we have taken all pregnant women and all children up to 18 years of age in the first phase. Then later on, we had extended the age up to the 40 years of age in the second phase. Then counseling, which is very important. Like after diagnosis, like the patient, those who are there in the tribal area, they are not aware about the status. But once we had screened them, we had told them they are the sickle cell trait or disease. So genetic counseling is very important. So we are working on, especially for the genetic counseling and distribution of genetic counseling card to all screened individual. We have developed a very specific kind of card where the patient themselves can get counseled by themselves, and they can get the status whether they should marry or not, and what will be the fate of their marriage. Now the management, in management we ensure the treatment, supply of free medicine, safe blood transfusion, vaccination. and to some extent bone marrow transplant and consultation, because through CSR we could able to support few patients for bone marrow transplantation in Indore. Screening, we are doing community level door-to-door screening or institutional screening. All at OPD, IPD and all ANC clinic we are doing screening, and then screen positive, we collect the samples. After those who are screen positive, then we send it to the district hospital entry, and every time each record is entered in the sickle cell portal, where we could able to trace each and every patient. There is provision of follow up those patients for the treatment, for the hydroxyurea, for blood transfusion, everything is available in that sickle cell portal. Then screen negative or positive report are entry in the portal, genetic card, and along with that portal we have that data we send for the genetic counseling card printing, and then card distribution and genetic counseling. We have integrated centers for hemoglobinopathy and hemophilia and in all tribal districts, where they could able to get the free treatment like hydroxyurea, other drugs and blood transfusion. Now this is the difference. Well, what I could say ki in the pilot project we started with 2 districts, that is Jhabua and Alirajpur. It was the population which we had screened is 8.26 lakh. The target group was 6 months to 18 years, because at that time we were not able to do the newborn screening. But now we have lab here in AIIMS Bhopal. We could able to do the newborn screening. And previously the financial for the this pilot group, we have only amount which we were received from the tribal budget, so that the only amount was with us. The method of investigation was solubility test and HPLC, and now we had extended this pilot project to the second phase. We are taking 89 tribal blocks, and this after the result of this phase 1 and what program which we were running, like say, state hemoglobinopathy mission, that has been appreciated from Government of India. And in 2022 the Government of India also launched the sickle cell control program, and for 17 states in the country. And we have taken target in the second phase. The target group is up to 40 years, and the population is around 1.5 crore. The target districts are 20, and we have made target that we could able to complete this project in 2 years. And along with that, the Government of India appreciated our sickle cell portal, and they have also started a national sickle cell portal along with the mobile app, so that the screening could be done and the entry could be done at the doorstep where the screening has been done. The entry in the portal could be done simultaneously there only. To make screening easier and quicker, to get the result, advisory on POC kit issued by the Government of India, we were knowing about the point of care testing, but we could not able to, because there was no clear-cut guideline from the health department or from the Government of India. Now we had the advisory, and now we had started the process of procurement of the point of care testing, and we had completed that tender also. So very soon we could able to provide the point of care testing in all districts of Madhya Pradesh. As a special campaign, outsourced institution was selected for village to village comprehensive screening and provision of budget in the state head. So this is the result of pilot project in Alirajpur and Jhabua, where in both the district there are the 6 blocks where target population were around 3.5 lakh, and here 4.7 lakh. And there were pregnancy, this was the pregnant woman data, and the children, those who have been screened there. So total positive in screening, there was total positive was 14,053 people there in Alirajpur, and in Jhabua 17,365. Whereas when we have done the HPLC, then we got 701 sickle cell disease and sickle and beta thalassemia 383 patients, whereas in Jhabua 690 patients of sickle cell disease and sickle and beta thalassemia 142. And after getting the report or after diagnosing these patients, they are in continuous follow-up with the district doctors at the PSC, at the CSC and at the district hospital. We have nodal officers in each district hospital, especially for sickle cell and thalassemia. So those who take care of these patients, And these are the data of admission which we had received from the portal, that total admission was in the in Alirajpur during that 6 months is 565, and in Jhabua 509, and total blood transfusion given to the sickle cell was 111, and here in Jhabua 357. So these are the important activity which I already told about, that we had started the point of care technology in the tribal dominated district, and we will start screening soon in these 89 blocks. We had established a newborn screening testing lab in AIMS, and along with that we have a Dastak Abhiyan here, where we started, where we do the screening, anemia screening up to 5 years of age, but after that we had done the screening for sickle cell also, so that around 1200 new patients diagnosed overall in Madhya Pradesh, where those who are on treatment. Genetic counseling card is already, we have taken support of the ICMR Jabalpur for capacity building of district level staff like CMHO, civil surgeon, DPM, DCM. We are doing the trainings of all category, like even the managerial staff, the clinical staff, the supporting staff, even the health worker, those are working in the field, so that they could able to understand the severity of the disease, like what is sickle cell, because previously they were not aware about the sickle cell, what is the genetic inheritance of the sickle cell, and how they have to do the counseling. So ICMR is supporting us in the training. Recently we had completed training of 3 districts, and very soon we will complete the trainings of other districts also. Even with the help of subject expert from the ICMR and AIMS, we are trying to develop SOPs and treatment guidelines, especially for the Madhya Pradesh. It's a booklet which we were released yesterday. It was a part of that guideline, and even we had decided and we have fixed the roles and responsibility of each cadre in that guideline. Along with that, so that the roles of we can monitor the activities or the work done by the health worker in the field, and provision of the fund in the state budget. Along with that, there was a good initiative from the governor sir. What he did, because he was saying कि सारा डॉक्टर लोग जानते हैं कि इवन हेल्थ डिपार्टमेंट जानता है कि सिकल सेल क्या है, लेकिन दूसरे लोग नहीं जानते. तो उन्होंने अपने ही राजभवन में, गवर्नर हाउस पे, वो हर 2 महीने में उनके अंडर में सारे यूनिवर्सिटीज़ आते, सारे यूनिवर्सिटीज़ के वाइस चांसलर को, रजिस्ट्रार को, सारे यूनिवर्सिटीज़ के जितने भी नोडल थे उन सबको बुलवाया, और उन सबको बैठ के हम लोग जाते हैं हर 2 महीने में, एंड वी टीच देम व्हाट इज सिकल सेल. वो और उनको सबको बोला कि they have to adopt 5 villages in the tribal areas where the university student will go, the NSS people, they will go, they will make the awareness in those villages, and they will take care of the health of those the people, those who are residing in those villages, ताकि उन लोगों को पता चल सके, and they ask them to go in the tribal areas only. So every district, along with the health department, the universities are also coordinating with us, at least for awareness. They do the screening camps, and the health department people goes there and they do the screening. So this is also a very good initiative, so that the general people, those like the awareness among the general population is also increasing. And screening and management of sickle cell is studying in the tribal hostel. Also, what he did, he directed to all the tribal staff and tribal department that the health checkup must be done for sickle cell at in each tribal hostels and ashrams and a school, and no child should be left without screening, so that there is a coordination now between the health and tribal department. And we had also, like in RBSK, there is one program in NHM where there is screening of children up to 5 years age of children done, but here we are coordinating with the RBSK team, with RKSK team, where the Kishori Bal Karyakram, जहाँ पे बच्चों को कुछ मॉड्यूल्स हैं जिसमें हाइजीन और दूसरी चीज़ें पढ़ाई जाती हैं, उसमें भी सिकल सेल को इंट्रोड्यूस किया, ताकि जो पीयर सपोर्टर हैं उनके थ्रू बच्चों को स्कूल में, टीचर्स को पता चल सके कि व्हाट इज सिकल सेल एंड क्या करना है सिकल सेल के पेशेंट्स के साथ. Now, availability of all essential medicine, hydroxyurea, folic acid, painkillers, antibiotic, and vaccines also free of cost to all patients, and hydroxyurea up to PSC level. Now we are going to, previously it was only available in the district hospital and block level. Now it is, because we are training to the medical officers also, and there was resistance from the doctors, even like when we started in Alirajpur Jhabua, that you give hydroxyurea. So what they were saying कि नहीं ये तो सिर्फ हम crisis होगा तभी देंगे. They were not ready to give hydroxyurea in the normal, like those who have diagnosed. So we are doing capacity building, we are doing trainings, ICMR people are going, many doctors, Dr. Bhavna की team भी जा चुकी है जो बार-बार, because there are like sickle cell के लिए काम करना है, इतना पहले लोगों को मलेरिया, टीवी और दूसरे प्रोग्राम ज़्यादा इम्पोर्टेंट थे. Previously it was the कोविड ही था सब कुछ. फिर मतलब हम लोग शुरू करते हैं, फिर जीरो पे चले जाते हैं. Then again we are trying again, and we are trying hard. So this is the sickle cell portal, जिसमें हम लोग like national and state level reporting होती है, database tracking of the sickle cell, creation of digital health records, online entry and tracking of screening and confirmatory check at community and institution level, and patient registry facility module is also there, where if any patient is already diagnosed, so they can register themselves, as well as the anybody, clinician can register in that portal, so that the follow-up record can be seen or can be registered in that patient. Even for the university, we have issued the login password for the university people also, so they can also do the registry with the screening camp, about the screening camp and all. These are the special genetic counseling card which we are providing to the patient. Here you can see the special the pink color for the female, and ये उल्टा हो गया है, that pink color for the female and blue for the male. And in the back side, where you can see there is a special cutting, the D-shaped cutting, and here this is the round O-shaped cutting. So when before their marriage, they can overlap, they can put this card like कुंडली मिलान करते हैं, उस तरह इस कार्ड को रख के वो पीछे जिस सर्कल पे, क्लियर एक सर्कल पे ही पास होगा लाइट, तो वही उसका आंसर होगा कि वेदर दे कैन मैरी और नॉट, और वेदर उनको उसका क्या फेट होगा, उसके बच्चों की संभावना क्या हो सकती है. So these are the some pictures where how the governor sir is continuously doing efforts for the sickle cell patient. हमने 2 नवंबर को उन्होंने पहले ही एक मीटिंग करी, बार-बार वो सारे मिनिस्टर्स को खुद गवर्नर हाउस में ही बुलाते हैं, हेल्थ की टीम को बुलाते हैं, ICMR की टीम को बुलाते हैं, एंड वहाँ पे कंटिन्यूसली डिस्कशन होता है. ये 15 नवंबर का पिक्चर है जिसमें ऑनरेबल PM सर आए थे और उन्होंने भी ये कार्ड डिस्ट्रीब्यूट किया था. दीज आर द पिक्चर्स. एंड जो झाबुआ अलीराजपुर में मैं 3 बार गई होंगी, गवर्नर सर 8 बार गए होंगे. द इंटेंसिटी, हाउ ही मॉनिटर द थिंग्स, तो वो कंटिन्यूसली रिव्यू लेते हैं. और ऐसा नहीं कि सिर्फ हेल्थ डिपार्टमेंट का, वहाँ पे कलेक्टर, सारे जो जितने डिपार्टमेंट्स हैं सबको बिठा लेते हैं, और फिर he takes the review there. And this is the sickle. We had released some operational guideline there in Alirajpur only, and this is the integrated center for hemoglobinopathy and hemophilia in Alirajpur and Jhabua, where he usually go. Whenever he goes there, he check the patient, he asks the patient whether उसको testing हुआ है, drugs मिल रहे हैं या नहीं मिल रहे हैं. And this is the camp in Alirajpur and Jhabua. Then this, when the outsource agency has been selected, he has started them, and they have started the pilot project. The governors are inaugurated that. And this is the screening camp picture where the ANCs are, this Asha, Anganwadi Karyakarta and CHO all are now doing screening through solubility. This is the IC material. This is the Panchayat. This is the Gram Sabha, where the Jan Abhiyan Parishad people goes and they discuss about the sickle cell disease. And this is in Khandwa. Now, in every 3 months, Governor sir have visited almost 37 districts in Madhya Pradesh. Wherever he go, he talk about the sickle cell. He do the camps for the sickle cell patient, and all kind. He used to call Ayush department, call tribal department, all there to know about the sickle cell. This is on the day of World Sickle Cell Day on 19th June, where all experts were there in Jabalpur. This is the portal picture, and This was in, then it is in the university. I told na the university people came where we trained them. This is in Amarkantak University where governor sir were there on 2nd October, and there was the camp, sickle cell screening camp. And this is the continuous review in Alirajpur and Jhabua. Again, he had taken review on October. So these are the pictures and of the screening. These are the all IC material. And one more thing, that because I'm looking after the blood transfusion services, I'm happy to say that in Madhya Pradesh we are providing NAT tested blood to all this hemoglobinopathy patients. And I'm very thankful to Vinita ma'am, because of her we could able to provide NAT tested blood in 20. At present we are providing NAT tested blood in 22 districts. But very soon I hope, like, if we will get more fund and we could able to do. So we are doing in hub and spoke model, where the hub is there in medical colleges, where one hub is in Bhopal, GMC, and another hub is Indore. And these district hospitals or blood center has been working as a spoke to these hub centers. And we are, with the help of NHM only, with the ma'am support, we could able to provide blood collection transportation van to each and every district of Madhya Pradesh, where they are collecting more and more voluntary blood from the donors and providing free blood to all. And now we are going to start, as today morning Dr. Rahul sir was saying, that the component is the most important. So at present we are having only 19 component center in district hospital. Now we are going to start that very soon, like in next year maybe, we could able to provide component in each hospital in Madhya Pradesh, because we are going to establish component centers within hybrid model, where the agency people we had outsourced for operationalization of BCTV component separation, TTI testing by CLIA, and gel-based cross-matching, leukoreduction of each bags. We had included that component so that we could able to provide leukoreduced blood to the patient, and digitalization with a robust BBMIS. So this is the last slide, I think. Thank you. Thank you so much.
Thank you so much, ma'am, for letting us know all the different initiatives being taken by the government to reach out to the each and every sickle cell patient. If you have any questions, quickly we can take. No, okay. Then may I request Dr. Raya Subramaniam to please come on the stage and felicitate Dr. Ruby Khan. We'll be having one more presentation after this. I was not aware, actually it was a mistake on my part. We have one more lecture. It is by Dr. Seema Jain, so we'll be having after this, and then we'll break for lunch.
I believe there is a question from
Yes,
Dr. Vinita.
Yes, ma'am, please.
कैसे कर रहे हैं हम लोग? जैसे स्क्रीनिंग कर रहे हैं उसके बाद डेटा भर रहे हैं ना?
नहीं मैम, जैसे अभी पहले तो जैसे हमारा जो पोर्टल भी था वो मोबाइल पे, मतलब जो एंड्रॉइड फ़ोन पे ओपन हो जाता था। अब तो जो नेशनल पोर्टल आया उसमें मोबाइल ऐप है, तो उसमें ये प्रोविजन है सिंपल पेशेंट का डिटेल जैसे ऐप में होता है, पेशेंट का डिटेल फिलअप किया, उसके बाद उसमें अगर इवन दो लाइक नेटवर्क नहीं भी है तो उसमें वो डेटा स्टोर हो जाता है क्लाउड, और बाद में जैसे अगर रिमोट एरियाज में तो वो
हमारे बारकोड सिस्टम्स हैं, है ना, तो उसको स्कैन करके तुरंत डेटा वैसे करो। मतलब ये जो प्रैक्टिस मैंने वहाँ भी बात करी थी, गवर्नमेंट ऑफ इंडिया लेवल पे भी हमने हेल्थ में बात की थी कि दिस इज़ नॉट गोइंग टू हेल्प एंड नॉट गोइंग टू गिव अस दैट डेटा विच इज़ रिक्वायर्ड। तो अब तुम जो पीओसी पे जा रहे हो, पीओसी की बात होगी कि पीओसी में सीधे सीधे बारकोड्स हैं, स्कैन करवाओ डलवाओ, तो रियल टाइम डेटा उसे कहेंगे। और इसको प्रोविजन में ले आओ, अपने यहाँ शुरू कर दो तो उसके बाद वहाँ शुरू कर दिया जाएगा। तो इसको मैं ग्रेजुअली वहाँ पे भी यही चीज़ ले जा रही हूँ, लेकिन तुम अपने यहाँ ये बात शुरू कर दो कि कैसे हम जो है बारकोड में लेके उसको कर देंगे। दूसरी चीज़ जो हाइड्रोक्सीरिया की बात कर रही हो कि हम पीएससी लेवल तक ले जाएंगे, ले जाओ, आसान काम है, कोई बहुत बड़ी चीज़ नहीं है, आराम से की जा सकती। बट वहाँ जो CHO हैं, आधी CHOs को भी पोस्टिंग नहीं है तुम्हारी। एक तो पहली उसको आज मैं हाईलाइट करके आई हूँ, अभी मैं मीटिंग में ही थी, तुम्हारे ही थी मीटिंग। मेरा केवल ये मानना है जो CHOs हैं जितनी ट्रेनिंग है उनकी, क्योंकि वो आयुर्वेदा वाले हैं, दो चीज़ों का ध्यान रखो, क्योंकि उनकी इस मामले में ट्रेनिंग्स बहुत ज़रूरी है, और एक ट्रेनिंग नहीं, एंड वी नीड एटलीस्ट 6 ट्रेनिंग्स। 6 ट्रेनिंग का एक मॉड्यूल है जिसको जो बन चुका है, मेरा ख्याल सारे लोग यहीं पे जिन्होंने मॉड्यूल्स बनाए हैं ये, और एक काउंसलिंग का मॉड्यूल है, 2 मॉड्यूल्स है जिसको मैं शेयर कर दूँ। बट उसकी लेवल पर ट्रेनिंग, क्योंकि क्या हो रहा है कि CHO अभी तुम्हारे यहाँ का ही 1-2 किस्से हैं जहाँ पे कुछ चीज़ें मतलब यू हैव टू टेक अप इन अ बेटर वे। सिर्फ इतना बताना चाह रही हूँ क्योंकि एक अच्छा काम शुरू हुआ है, और अलीराजपुर और झाबुआ की स्क्रीनिंग पे हम बहुत ज़्यादा एम्फेसिस ना दे के जो नई स्क्रीनिंग शुरू कर रहे हैं उसी पे तुम फोकस करो, क्योंकि वो जो है स्क्रीनिंग का जो डेटा है दैट विल बी नॉट सफिशेंट फॉर यू। आई एम जस्ट टेलिंग यू एंड कि वो सफिशेंट नहीं, तो अपनी जो नई स्क्रीनिंग शुरू करो उस पर फोकस करो। और बेसिकली जो PSC पे जो भी जितने भी हमारे हेल्थ एंड वेलनेस सेंटर्स हैं उन पे जहाँ पे हम लोग शुरू कर रहे हैं कि हाइड्रोक्सीरिया वहाँ तक पहुँचनी चाहिए, क्योंकि PSC तो सारी चेंज हो गई है HWC में, मैक्सिमम तो हम चेंज ही कर रहे हैं। तो हेल्थ एंड वेलनेस सेंटर में वहाँ पे एक हेल्थ मेला कैंप, एक हेल्थ मेला होता है उनका, एक 14 तारीख को ही करते हैं, जिसमें वो सारी स्क्रीनिंग करते हैं। उसमें एक तो इसमें स्क्रीनिंग ऐड हो जाए, और दूसरा ये हम कर लें कि उसी दिन हम जब दवाइयाँ दे रहे हैं तो वहाँ पे कोई पीडियाट्रिक या उसकी एक दिन की नॉमिनेशन, CHO पे बिल्कुल मत जाओ, उसको जानकारी होनी चाहिए, लेकिन ये नहीं होना चाहिए एक बंदा कोई या तो पीडियाट्रिक जिसको हमने ट्रेन किया हो,
हाँ।
या फिर कोई गायनेकोलॉजिस्ट या कोई फिजिशियन, इन तीनों में से एक रख के उसको रखो। अदरवाइज हम जहाँ जो बढ़ा रहे हैं ना, जो कह रहे हो कि इतनी तेज़ी से जाते हैं फिर नीचे, उसका कारण भी ये बहुत है। तो ये छोटी छोटी चीज़ें जो 14 तारीख की स्क्रीनिंग का डेट है, एंड विच आई स्पोक टू हर्ष मंगला जी ऑल्सो, कि अब हम उसी को एक फोकस डे बना देंगे वेयर एवरी स्क्रीनिंग इज डन, इट्स नॉट ओनली सिकल, क्योंकि हमारे साथ ट्राइबल में तो और भी इश्यूज बहुत है, तो उनको भी हम कर लें और साथ साथ हम सिकल की भी स्क्रीनिंग कर लें। वेयर ट्राइबल जहाँ पे इंटीरियर्स में तुम्हारा नहीं है तो लोगों को लाने तक की जिम्मेदारी ट्राइबल डिपार्टमेंट लेने को तैयार है, कि वहाँ से वो लोगों को ला के,
हाँ, दैट इज़ अ वेरी सपोर्टिव मैम। हाँ मैम, एट प्रेजेंट लाइक हमारे जो CHOs हैं, वी हैड गिवन अपॉइंटमेंट ओनली इन द सब हेल्थ सेंटर, like in PSC only the medical officer is there, like a doctor is there, so we had not taken to the CHO level, like hydroxyurea to the CHO level, जहाँ पे medical officer appointed है वहीं पे हम उनको मतलब हाइड्रोक्सीयुरिया,
लेकिन उनको भी बहुत,
but for screening definitely we are taking up to the,
हमें बहुत, क्योंकि जितने भी मेडिकल डॉक्टर्स हैं, मैं बात करी थी अभी कुछ लोगों से, कुछ ट्रेनिंग्स हुई, तो बहुत ज़्यादा जानकारी अभी है नहीं लोगों को,
हाँ।
और सिकल सेल मिशन तो अभी लॉन्च हुआ है, तो मतलब ठीक है हम लोग कर रहे हैं, 7-8 साल हो गए करते करते, कितने साल हो गए, मेरे ख्याल 14 से शुरू किया था, 2014 से शुरू हुआ तो आज, लेकिन अभी भी वो जो क्रक्स मैं ढूंढना चाह रही हूँ वो अभी नहीं समझ आ रहा है मुझे, मतलब इवन आई एम ट्राइंग टू फाइंड दैट, तो वो इसलिए मैं ये बता रहा हूँ क्योंकि MP ने इनिशिएट किया है, तो उसका प्रोग्राम को एक अच्छी फ्लाइट मिल सके, उसके लिए मैं बात करना चाह रही हूँ। सो आई हैड अ वेरी गुड मीटिंग विद ऑल, मैं इसीलिए निकल गई थी आज जो मीटिंग, तो उसमें ट्राइबल भी और पूरा जो है दोनों का वो करके किस तरह से इस प्लान को आगे रन करना है, वी विल टेक इट अप।
थैंक यू मैम, थैंक यू।
Thank you so much, ma'am. Actually, it is already 2:15, so we have decided that we will break for lunch now, and then once we get back after lunch, then we will be having the lecture by Dr. Seema Jain, and we'll get on with the panel discussion also. Thank you so much. So we will break for about half an hour for the lunch. 2:45 we'll be coming back.
एनीमिया तो हमें पता है, लेकिन ये सिकल सेल एनीमिया ये क्या होता है? इसको बार-बार बुखार आता है और शरीर में जगह-जगह तेज दर्द होता है।
सिकल सेल एनीमिया एक तरह की बीमारी है, यह अनुवांशिक बीमारी है, यानी माता-पिता से व्यक्ति में आती है। इससे रक्त कणिका का आकार पूर्ण होकर नसिए जैसा हो जाता है, साथ ही उसका लचीलापन भी खत्म हो जाता है, जिससे नसों में खून बहने से परेशानी होती है और शरीर में तेज दर्द होता है। खून की तुरंत जांच करवाएं और डॉक्टर द्वारा दी गई सलाह एवं दवा का सेवन करें। साथ ही ज्यादा से ज्यादा पानी पिएं और स्वच्छता का ध्यान रखें।
क्या हम इस बीमारी को रोक नहीं सकते?
वॉल्यूम कैसे होता है? यदि सिकल सेल से पीड़ित वॉल्यूम कहाँ से बढ़ते हैं? आपस में शादी करते हैं तो उनकी संतान में बीमारी होने का खतरा बहुत अधिक रहता है। इसलिए शादी के पहले तुम्हें मिलवाएं या न मिलवाएं, लेकिन लड़का और लड़की दोनों की खून की जांच जरूर करवाएं, ताकि इस बीमारी को आने वाली पीढ़ी में रोका जा सके। है कि सिकल सेल एनीमिया को जाने और इसे रोके।
चले आप लाइन लग जाएगी। चले आ जल्दी। अब बात तो करनी होगी, ये चीज समझनी होगी। अब बात तो करनी होगी, ये चीज समझनी होगी। एक खून की दुनिया ही है, नींद जानती है ये सारी दुनिया, लेकिन है ये नई बात हम सब माने। सिकल सेल एनीमिया तो भी जाने। लाल रक्त का इलाज से अपना आकार बदलती है, ना बोल रहे ये हंसियां आकार में ढलती है। फिर छोड़ना चिड़ेपन को, ये सब हो जाती है। फिर नसों में गुब्बारों में दिक्कत आती है। ये दिक्कत रक्त बीमारी ढेर हो जाती है। जीवन को मुश्किल और कठिन वक्त बनाती है। क्या करते हैं दुष्कर अनुवांछित बीमारी पर सावधानी बेहतर, जीवन की तैयारी, ये सब सुनने के बाद ना रहे अनजाने। बस लक्ष्य जाने और शत्रुओं को पहचाने। जोड़ों में सूजन, धरती पथरी हो जाना, बार बार बुखार, हो जाना, सर्दी जुकाम होना, या दिल्ली पड़ जाना, लीवर पर सूजन, या बच्चे का बढ़ना, रोगों से लड़ने की ताकत घट जाती है। और ना इलाज हो तो ये जानलेवा बन जाती है। तो जांच खून की करवा कर सच को जाने, फिर ले पूरा उपचार सलामी को माने। सिकल सेल एनीमिया ये बीमारी है नहीं ये संक्रमण या छूत की बीमारी। ये मात पिता से बच्चों में आ जाती है, फिर जीवन को ये बुजुर्गों से बढ़ जाती है। होने वाले बच्चों को सुरक्षा देना है, तो खून की जांच करा कर निर्णय लेना है। यदि युवक युवती दोनों में हो ये बीमारी, तो आपस में इनकी ना होने तो तुम शादी, इसलिए शादी के पहले कुंडली मिलाए रखना। बस सिकल सेल एनीमिया ये खून की जांच जरूर करना, इससे आने वाली पीढ़ी रोग से बचेगी और ये बीमारी रक्त को लगेगी। डॉक्टर और नर्स आशा दीदी की करो, सिकल सेल एनीमिया हो जानो पहचानो।
लोक स्वास्थ्य एवं परिवार कल्याण मध्य प्रदेश द्वारा जनहित जारी।
Good afternoon, all. Let me introduce myself. Dr. Seema Jain, from Research Officer Ayurveda from Central Council for Research in Ayurvedic Sciences, New Delhi. I am having more than 18-year experience in clinical research in the field of Ayurveda. Today I am here to present or talk the role of Ayurveda in the management of sickle cell disease. as you all are most or more eminent expert in the field of this field, so I think I am not taking much time to about discussing sickle cell disease in modern perspective. Directly I am coming to the Ayurveda perspective of this disease. Now, skipping this slide, introduction and what is sickle cell anemia and prevalence, I am directly coming to the Ayurvedic point of view. Sam dosha, sam agnischa, sam dhatu malah kriya, प्रसन्नात्मेन्द्रिय मनः स्वस्थ इत्त विधीयते। आयुर्वेद के इस प्रयोजन और एम के साथ में जहाँ पे धातुओं में समानता है, दोष में समानता है, मल में समानता है, और इसके साथ में आत्मा, मन और इंद्रिय प्रसन्न हैं, उसी को स्वस्थ कहा जा सकता है। तो आयुर्वेद के इस दृष्टिकोण को समझने के लिए, चूँकि आप लोग सभी बिल्कुल डिफरेंट फील्ड है आपके लिए, तो आपको इसकी सिकल सेल डिजीज़ की आयुर्वेदिक पैथोजेनेसिस समझाने के लिए मैं थोड़ा सा आपको ले चलूँगी आयुर्वेद के बेसिक प्रिंसिपल्स की ओर, जो आपको जानना बहुत ज़रूरी होंगे। बहुत कम टाइम में मैं कोशिश करूँगी कि आपको मैं समझा पाऊँ। दोष धातु मल मूलम ही शरीरम। आयुर्वेद में शरीर को दोष धातु मल, जो 3 दोष वात पित्त कफ, 7 धातु रस रक्त मांस मेद अस्थि मज्जा और शुक्र, एंड 3 मल मूत्र पुरीश एंड स्वेद, इन तीनों के कॉम्बिनेशन अगर साम्य स्थिति में है तभी शरीर स्वस्थ है, और उसी के कॉम्बिनेशन को शरीर कहा गया है। तो जहाँ पर रोग की बात आती है, डिजीज़ की बात आती है, किसी भी डिजीज़ में इनकी साम्य, इनका जो साम्य है, इनका जो इक्विलिब्रियम है वो डिस्टर्ब होता है, और उस डिस्टर्बेंस से डिजीज़ होती हैं, और इसी को आयुर्वेद में दोष वैषम्य कहा गया है। नाउ सिकल सेल डिजीज़ को समझने के लिए आप लोगों को हिंदी फैमिलियर है ना? एक्चुअली हम आयुर्वेद को ट्रांसलेशन करके नहीं समझा सकते। मुझे लगता है कि एक्चुअल जो उसकी लैंग्वेज है, मुझे उसमें समझाना ज़्यादा इजी है। सिकल सेल डिजीज़ में आयुर्वेद के अकॉर्डिंगली रक्त की दृष्टि है। रक्त मीन्स ब्लड। जो 7 धातु मैंने अभी बताई हैं, रस रक्त मांस मेद अस्थि मज्जा और शुक्र, ये जो हम आहार ग्रहण करते हैं, जो हम फूड लेते हैं, उसी से 1 माह के अंदर 7 धातुओं का निर्माण होता है। फर्स्ट रस, जिसे हम मॉडर्न साइंस में अगर कोरिलेशन बिठाएं, वैसे एग्जैक्टली हम ये नहीं कह सकते कि एग्जैक्ट प्लाज्मा ही रस है, बट रस जो शरीर की तुष्टि करता है और ग्रोथ करता है। देन रक्त, रस से रक्त में कन्वर्सन होता है, तो वहाँ पर अग्नि, धात्वाग्नि का रोल होता है, जो उसको डाइजेस्ट करके कुछ पार्ट शरीर की पुष्टि, एंड देन नेक्स्ट धातु जो रस से रक्त, रक्त से मांस, मांस से मेद, मेद से अस्थि, अस्थि मज्जा एंड शुक्र धातु का निर्माण होता है। तो यहाँ पर जो रक्त धातु है उसकी धात्वाग्नि में भी मांद्य है, मंद हो गई है, और उसमें उसके मंद होने से क्या हुआ, रस से रक्त जो प्रॉपर कन्वर्शन होना था वो नहीं हुआ। क्योंकि अग्नि मांद्य है, प्रॉपर कन्वर्सन ट्रांसफॉर्मेशन जो होना था वो नहीं हुआ, और इम्प्रॉपरली जो रक्त धातु का निर्माण हुआ, वहाँ पे यहाँ पे रक्त में हीमोग्लोबिन, ब्लड सेल सब कुछ इन्वॉल्व है। तो जो रक्त का निर्माण हुआ, उसी वो एबनॉर्मल ब्लड के कारण सारे सिम्टम्स आते हैं। तो डायरेक्टली यहाँ पे रक्तम जीवयति प्राणानुवर्तनम करोति, जीवन और प्राण का अनुवर्तन करता है रक्त। अगर इसमें प्रॉब्लम आती है तो सारे सिम्टम्स इस तरह के आते हैं कि जीवन संकट में होता है। देन रस क्षय और रक्त क्षय के लक्षण भी बताए हैं। शोणित क्षय त्वक पारुष्य अम्ल शीत प्रार्थना शिरा शैथिल्यम च। देन रसम तुष्टिम प्रीणम रक्तम पुष्टिम च करोति, जो मैंने अभी बताया कि एक धातु से दूसरी धातु की पुष्टि होती है। ये भी मैं बता चुकी हूँ कि यहाँ पर अग्नि का महत्व है। पर्टिकुलर धात्वाग्नि है जो उस उत्तरोत्तर धातु में कन्वर्शन में इम्पोर्टेंट रोल प्ले कर रही है। तो किसी भी डिजीज़ के ट्रीटमेंट में आयुर्वेद में हम सबसे पहले अग्नि की चिकित्सा करते हैं, क्योंकि अग्नि ही प्राण का आधार है। और ये भी कहा गया है आचार्य चरक ने चरक संहिता में कि रोगाम सर्वे अपि मंदाग्निम सूत्रामुद्रणांच, सभी रोगों की जड़ मंद अग्नि है। अगर डाइजेशन प्रॉपर नहीं होगा, डाइजेस्टिव फायर प्रॉपर नहीं होगी, तो उत्तरोत्तर जो भी कन्वर्शन है वो प्रॉपर नहीं होंगे, और इम्प्रॉपरली डाइजेस्टेड जो भी फूड होगा उसको हमारे यहाँ आम कहा गया है, आम की संज्ञा दी है, जो स्टिकी नेचर में होता है। तो यहाँ भी जब रस धातु से रक्त का प्रॉपर फॉर्मेशन नहीं होता और आम रक्त धातु बनती है, दैट इज स्टिकिंग नेचर। तो आप कंपेयर कर सकते हैं कि जो मॉडर्न पैथोफिजियोलॉजी है कि जो सिकल सेल शेप हो जाता है वो सेल्स स्टिकी नेचर की होती है। तो यहाँ पे हम यही कोरिलेशन बिठा सकते हैं कि आयुर्वेद में भी इस तरह का डिस्क्रिप्शन है। एक्चुअली सिकल सेल डिजीज़ डिस्क्राइब नहीं है यहाँ पे, पैथिक व्याधियों में, रक्तज और पैथिक व्याधियों में ही वर्णन मिलेगा आपको। देन एसटीडी इन आयुर्वेदिक पर्सपेक्टिव। STD is not described such as in Ayurveda, but the disease Pandu anemia shown the same characteristic in term of pathogenesis and cardinal symptoms like Raktalpta, hemolytic anemia, Sithilendriya, fatigue, anorexia, aruchi, Hatnal, reduced digestive fire, Swas, acute chest syndrome, dyspnea on exertion, and Arohan Ayas, tiredness on exertion. Pidicodweston means stiffness and tightness of calf muscles, and Jwara fever, Parvabheda, arthritis-like symptoms, joint pain, multiple joint pain, clump tiredness on rest. These all symptoms are similar to sickle cell disease symptoms. The genetical basis of SCD is well established, so the term Kolaj, Anuvansik or Sahaj are mentioned in our classic is to denote the inheritable nature of this disease. As sickle cell disease is a hereditary disorder and is transferred from parents to their offspring, so it is a disease caused by बीज दुष्टि. It is clearly indicated in Ayurveda. Then अगर बीज में दुष्टि होगी, बीज in the sense sperm and ovum, अगर ये defective हैं तो offspring भी defective ही होगी. बीज दुष्टि which is considered under the heading of आनुवंशिक व्याधि और सहज व्याधि. In this disease, particularly the sickle cell crisis, due to certain circumstances like physical and mental stress, exposure to extreme and cold and extreme hot environment, all three doshas, Vata, Pitta, Kapha, get besieged. Vata dosha is initiator of any changes, while transformation or mutation caused by Pitta dosha. वात वृद्धि एंड प्राकृत कफ क्षय, जब तीनों दोष साम्य में है तभी शरीर है, तभी स्वास्थ्य है. अगर एक बढ़ता है और दूसरा दोष घटता है तब भी स्वास्थ्य नहीं है. तो इन पर्टिकुलर इन दिस केस वात वृद्धि एंड प्राकृत कफ क्षय आर ऑब्जर्व्ड रिजल्टिंग टू द एबनॉर्मलिटी इन द शेप ऑफ RBC एंड लो इम्यूनिटी. एज प्राकृत कफ इज द टर्म एज बल, strength of the body. Due to abnormal shape of RBC, normal life expectancy of cell is reduced and causes early destruction, leading to पित्त वृद्धि, and पित्त reside in the association with रक्त धातु. रक्त और पित्त एक दूसरे के साथ ही रहते हैं, तो जहाँ पे पित्त वृद्धि होगी तो वहाँ रक्त धातु की दुष्टि हो जाएगी. Clinically, this disease is अपतर्पणजन्य and has main symptoms like पांडुरा, pallor, kamla, jaundice or sandhigata vata, multiple joint pain. So we can say Pandu described in Ayurveda is Rakt Dhatu Kshay. and deficiency of Rakta Dhatu, and sickle cell disease can be considered as Rakta Dhatu Dushti and Rakta Dhatu Agni Mandya. Then concept of कुलज व्याधि, जो मॉडर्न जेनेटिक्स है इसमें जो कहा गया है बहुत पहले 2000 साल पहले आचार्य चरक ने भी इसको डिस्क्राइब किया है. द टर्म इज डिफरेंट. बीज वर्ड यूज हुआ है स्पर्म ओवम एंड जाइगोट के लिए. बीज भाग, बीज का जो भाग है उसे हम क्रोमोसोम कह सकते हैं. एंड बीज भागावयव, दैट इज जीन्स. It is also mentioned in, clearly mentioned is Charak Samhita. Then I am skipping causes of the SCD, modern aspect of. Then causes of sickle cell disease in Ayurvedic perspective. Ayurved क्या कहता है? According to Shushruta, Acharya Shushruta, father of surgery, नास्तिक यानी जिसको ईश्वर पर भरोसा नहीं है, अशुभ कर्म ऑफ पेरेंट्स एंड वातादि प्रकोप आप रिस्पॉन्सिबल फॉर विकृति इन द गर्भ fetus which may lead to abnormality in beach, sperm, ovum and zygote, big bhaj chromosome and beach bhagavag gene. The disturbance of these three dosas by improper diet and lifestyle and पूर्व जन्मकृत कर्म, यहाँ दैव कर्म भाग्य को भी इम्पोर्टेंस दिया गया है. इन द पेरेंट्स अफेक्ट द नेक्स्ट प्रोगेनी. ड्यूरिंग एम्ब्रियोनिक डेवलपमेंट abnormality is seen in that body part or component which beej or beej bhagayab are affected by the vitiated doshas. जिस किसी दोष का वर्चस्व होगा, जो बढ़ा हुआ होगा, जो कुपित होके अफेक्ट करेगा, वही सिम्टम्स वही बच्चों में आएंगे. और एक बहुत अच्छी चीज़ आयुर्वेद में कही गई है कि जब फर्टिलाइजेशन होता है उस टाइम जिस दोष का आधिक्य होगा वही आने वाली संतति की प्रकृति होती है और वो कभी चेंज नहीं होती. इसलिए आयुर्वेदिक चिकित्सा का सिद्धांत है कि प्रकृति के अकॉर्डिंगली चिकित्सा करते हैं. हम यहाँ पे रोगी के हिसाब से चिकित्सा करते हैं, रोग की चिकित्सा नहीं करते. क्योंकि अगर वातिक प्रकृति का एक रोगी है तो उसमें वो ड्रग काम करेगी, लेकिन वही ड्रग पैत्तिक प्रकृति के रोगी में काम नहीं करेगी. उसके लिए हमें शीतवीर्य औषधियाँ और ऐसी ड्रग्स देनी पड़ेंगी जो उसके पित्त को प्रकोप ना करें. तो यहाँ पर्सनलाइज्ड ट्रीटमेंट होता है. तो इसके लिए आयुर्वेद में प्रकृति को समझना भी बहुत ज़रूरी है. और प्रकृति वो फर्टिलाइजेशन के टाइम ही हो जाती है और उसको थ्रू आउट लाइफ कभी चेंज नहीं कर सकते. और वो लक्षण हम देख के ही पेशेंट में पहचान जाते हैं कि किस तरह का पेशेंट है और उसकी प्रकृति क्या होगी और उसके अकॉर्डिंगली प्लान कर देते. इन शॉर्ट मैं आपको बता दूं, जैसे कि एक पर्सन हमारे पास आता है, बहुत फास्ट तेज चल रहा है, उसका कॉम्प्लेक्शन डल है, वो बहुत फास्ट बोलता है, बहुत जल्दी काम करता है, हाइपर एक्टिव है, देन हम ये अज्यूम कर लेते हैं कि ये वात प्रकृति का है. अगर कोई पेशेंट हमारे पास आता है तो हाइपर एग्रेसिव है, थोड़ी बात में गुस्सा हो जाता है, या उसके फैमिली वाले बताते हैं कि ये एग्रेसिव है, देन और उसको गर्म चीज़ें नुकसान करती हैं या हॉट टेम्परेचर उसको टॉलरेट नहीं होता, देन द पर्सन बिलोंग्स टू पित्त प्रकृति. एंड जो कफ प्रकृति है वो शांत, गंभीर, धीरे धीरे काम करने वाला, स्लोली, और उसका कॉम्प्लेक्शन बहुत फेयर होगा. तो इस तरह से एक रफ आइडिया है. वैसे तो प्रकृति एनालिसिस का CCRS ने बहुत अच्छा सॉफ्टवेयर डेवलप किया है, उससे हम उसकी प्रकृति डिसाइड कर देते हैं. लेकिन ये कुछ कार्डिनल साइंस हैं जिनसे हम प्रकृति एक OPD लेवल पे डिसाइड करके और फिर मेडिसिन डिसाइड करते हैं. सो According to Acharya Charak, defect in बीज, आत्मकर्म, आशय, काल एंड माता के आहार विहार. क्योंकि ओबम माता से फीटस को डेवलप होना है, तो अगर माता भी अगर कुछ अनुचित आहार विहार का सेवन करती है तो भी बच्चे में इफेक्ट आता है. इस तरह की बात आचार्यों ने पहले ही डिस्क्राइब की है. सो मातुर आहार विहार आज रिस्पॉन्सिबल फॉर डिजीज इन संस्थान यानी सिस्टम, और वर्ण यानी कलर, कॉम्प्लेक्शन, और इंद्रिय ऑफ द फीटस, सेंस ऑर्गन इन पे अगर डिफेक्ट आता है तो वो माता से रिलेटेड है। इन द नेक्स्ट दोषा पित्त प्रधानस्तु यस्य गुम्प्यन्ति, ये सिम्टम्स हैं और अगर इन सिम्टम्स को आप नहीं समझ पा रहे होंगे, लेकिन मैं आपको बताने की कोशिश करती हूँ कि जब भी पित्त प्रधान जो आहार विहार के सेवन से जब धातु कुपित होती है और पित्त से रक्त धातु कुपित होती है तो क्या सिम्टम्स आते हैं। शिथिलता बॉडी में, भारीपन फील होता है, वल वर्ण स्नेह मतलब ड्राइनेस बॉडी में आ जाएगी, पेलर हो जाएगा उसका शरीर और उसका ओज क्षय यानी इम्यूनिटी वीक हो जाएगी। इस तरह के सिम्टम्स आएंगे और वो जो रोगी है वो अल्प रक्त का होगा, अल्प मेद का होगा और निहिसार होगा, उसका लस्टर नहीं होगा। उसमें जो हम एनीमिक पेशेंट देखते हैं वाइट पेलर एंड लस्टरलेस होते हैं। तो शिथिल इंद्रिय बिल्कुल लूज और एकदम इनएक्टिव इस तरह की वो आती है, कुछ काम करने में उत्साह नहीं होता क्योंकि उनको प्रॉब्लम होता है। तो इस तरह के डिस्क्रिप्शन मिलेगा और अगर इसको हम कोरिलेट करते हैं मॉडर्न सिम्टम्स ऑफ सिकल सेल डिजीज, सो वी कैन कंपेयर। जब पेलर इज वन ऑफ द सिम्टम तो वैवर्ण आयुर्वेद में कहा गया है, डिस्निया ऑन एक्सर्शन आयुर्वेद में श्वास कृच्छता कहा गया है, बोन एंड बॉडी एक, क्रॉनिक पेन चेस्ट पेन, गात्र शूल, गात्र मीन शरीर, शरीर में पेन, फीवर इन्फेक्शन ज्वर वर्ड आया है, फ्रिक्वेंट ज्वाइंटिस कामला रुक्षता इस तरह के वर्ड यूज हुए हैं, एनलार्ज स्पीन प्लीहोदर वर्ड पंडु में यूज हुआ है और इसमें तीनों दोष का प्रकोप है तो मिक्स्ड लक्षण है इसमें। डिक्रीज्ड ग्रोथ एंड मैचुरेशन, अल्पमेद, निस्सार, फर्दर बहुत अच्छा सा उसका ग्रोथ भी नहीं होगा, डेवलपमेंट नहीं होगा, मैलेज, तोद जिसमें एक वर्ड आया है, प्रिकिंग सेंसेशन, सुई चुभने जैसी वेदना जिसको कहते हैं उसको तोद वर्ड यूज हुआ है। तो मलाज, थकान सा फील होना, दर्द फील होना, इस तरह के सिम्टम्स मिलेंगे। देन डिजीज पैथोजेनेसिस आयुर्वेद पर पर्सपेक्टिव में समझने के लिए हमें संप्राप्ति घटक कौन कौन से दोष और दूष्य हैं जो डिस्टर्ब हुए हैं। दोष वात पित्त एंड कफ, दूष्य त्वक रस रक्त मांस एंड ओज जिसको शरीर का बल कहा गया है, जो क्षय हो जाता है, इम्यूनिटी क्षय हो जाती है तो पेशेंट की डेथ तक हो जाती है। देन श्रोतस, रस वह, रक्त वह, प्राण वह एंड मांस वह, श्रोतस एंड एज पर प्रेजेंटेशन ऑफ द इंडिविजुअल केसेस, जो सिम्टम्स हैं, अगर पेन्स बहुत ज़्यादा हैं तो अस्थि वह श्रोतस दूषित है, ज्वाइंट पेन है तो एक्सेट्रा। एंड धात्वाग्नि दुष्टि, बीज दोष और हेरिडिटरी है तो बीज दोष इन्वॉल्व है ही, उस बीज में पर्टिकुलर दोष का इन्वॉल्वमेंट हो गया है। एंड श्रोतोरोध, मार्ग अवरोध है और धातु पोषण कम जो है वो डिस्टर्ब हुआ है। देन हमने यहाँ पे थोड़ा सा प्रयास किया है आपको समझाने का कि पॉसिबल हेरिडिटरी जो इसका कॉज है उसमें किस तरह से हमारा आयुर्वेद का के प्रिंसिपल्स आ सकते हैं। तो जो पेरेंट्स के जो फॉल्टी डाइट एंड लाइफ स्टाइल है और इसके कारण और साथ में पूर्व जन्मकृत दैव कर्म जो बताए हैं वो, उनके साथ में विशेषण ऑफ दोषा होगा। देन जो ओवम और स्पर्म है वो ही प्योर नहीं होंगे, यानी शुद्ध नहीं होंगे, अच्छे नहीं होंगे, प्रशस्त नहीं होंगे, जिसके कारण जो फ्यूचर में फीटस डेवलप होगा वो भी अच्छा नहीं होगा। अगर किसी भी भाग में उसका दोष का प्राधान्य है तो पर्टिकुलर वो पार्ट डेवलप नहीं होगा, उस पार्ट में दुष्टि होगी, उस धातु में दुष्टि होगी। देन यहाँ हम कोशिश कर रहे हैं कि इस पार्ट में, और यही शायद यहाँ पे हमें बुलाने का एक मकसद भी है कि संप्राप्ति विघटन में आयुर्वेद का क्या रोल हो सकता है। तो जब होमोजाइगस जो बीज है उसमें रक्त धात्वाग्नि दुष्टि से जो सिकल सेल डिजीज़ के सिम्टम्स आए, वहाँ पे जहाँ धात्वाग्नि दुष्टि है वहाँ पे हमारी मेडिसिन्स हैं जो अग्नि दीप्त करती हैं, जो जिनका डायरेक्ट रोल है अग्नि पे, तो वो हम यूज़ कर सकते हैं, लाइक बिल्व, घृतकुमारी, गुडुचि एक्सेट्रा। एंड दैट जब विकृत धातु निर्माण हो गया, एबनॉर्मल HB मॉलिक्यूल जो HBS है वो फॉर्म होने लगा, दैट उस कंडीशन में रोहतक एक ड्रग है, रोहतक, तो रोहतिका रिस्ट हमारा एक क्लासिकल फॉर्मुलेशन आता है, वो बहुत अच्छा रोल प्ले करता है प्लीहा स्प्लीन के विकृति में। देन जब आम फॉर्मेशन हो गया, चूंकि धात्वाग्नि मांद है तो आम, तो स्टिकिंग जब स्टार्ट हो गया, क्लम्पिंग ऑन सिकल सेल्स लीड्स टू इम्पेयर्ड ब्लड सप्लाई, देन उस कंडीशन में उसके बाद ओज क्षय। तो यहाँ पे हमारे आयुर्वेद में एक टिपिकल रसायन थेरेपी होती है जिससे प्रशस्त धातु बनती हैं। तो बहुत सारी ड्रग्स हैं जो रसायन के रूप में यूज़ करते हैं, बहुत वेल नोन आपने सुना होगा आंवला, अश्वगंधा, गुड़ूची, ये रसायन ड्रग्स हैं। इनके कोई साइड इफ़ेक्ट नहीं है, इनको लॉन्ग टर्म यूज़ किया जा सकता है, लेकिन डॉक्टर की सलाह पर, कि उसका, क्योंकि आयुर्वेद में अनुपान भी अलग है। अनुपान मीन्स किससे लेना है, दूध से लेना है, पानी से लेना है, गर्म पानी से, ठंडे पानी से, दही से, छाछ से, शहद से, उन डिफरेंट अनुपान के साथ में उस मेडिसिन का डिफरेंट रोल है। देन ओज क्षय से निस्सारथा शीतलेंद्रिय जब स्थिति आती है तो उस कंडीशन में द्राक्षा, जिसको मुनक्का कहते हैं, द्राक्षावलेह, द्राक्षाधिघृत, ये बहुत अच्छा, चूँकि ड्राइनेस हो जाती है, जॉइंटिस होने लगता है, तो ड्राइनेस होने लगती है, तो उस कंडीशन में भी बहुत अच्छा रोल है द्राक्षाधिघृत, दाड़िमादिलेह इनका। देन ट्रीटमेंट प्रिंसिपल, लास्ट स्वस्थस्य स्वास्थ्य रक्षणम आतुरस्य विकार प्रशमनम चा, ये आयुर्वेद का सिद्धांत है। फर्स्ट प्रिवेंशन ऑफ डिजीज, देन क्योर ऑफ डिजीज। प्रिवेंटिव मेजर्स पे बहुत ज़्यादा ध्यान दिया गया है कि स्वस्थ व्यक्ति अगर ये सब पालन करे तो उनको रोग ही नहीं होगा, और यदि होता भी है तो सेकेंड एम है स्वस्थ आतुर के विकार को ख़त्म करना। तो जो सिकल सेल डिजीज़ के संदर्भ में हम कह सकते हैं फर्स्ट लाइन प्रिवेंटिव मेजर है, आयुर्वेद में डिस्क्राइब्ड है, चूँकि पहले भी अभी बहुत डिस्कशंस आए हैं कि सेम गोत्र में विवाह या सेम फैमिली में, या ये भी हेरिडिटरी जो डिजीज़ हैं उनको आगे ट्रांसफ़र करते हैं। तो आयुर्वेद में पहले ही कहा है अतुल गोत्रीय रजस्क्षयांते, मतलब तुल्य गोत्र में, सेम गोत्र में विवाह नहीं करना चाहिए। अगर आपको जो आनुवंशिक रोगों को रोकना है, सहज रोगों को रोकना है, कुलज को, तो सेम गोत्र में आपको विवाह नहीं करना है। और चूँकि अगर ऐसा है भी उस घर में, जैसे रेसेसिव ट्रेट है, तो उस कंडीशन में अगर वहाँ पे कंसेप्शन, बिफोर कंसेप्शन प्लानिंग के टाइम पे बहुत सारी ऐसी मेडिसिन है, रक्त प्रसाधन ड्रग्स हैं जिसमें हम हस्बैंड और वाइफ को देते हैं, जिससे कि प्रशस्त शुक्र और ओवम का निर्माण हो, स्पर्म और ओवम का, और उसके बाद में काफ़ी हद तक हम उनके सिम्टम्स को, उनके सीवियरिटी को कम कर सकें। तो फर्स्ट लाइन ऑफ ट्रीटमेंट है स्वस्थस्य स्वास्थ्य रक्षणम, एंड देन आतुरस्य विकार प्रशमनम चा। अगर सिकल सेल डिजीज़ का पेशेंट है तो हमारी भी कुछ लिमिटेशंस हैं, जहाँ पे लाइफ थ्रेटनिंग डिजीज़ हैं या जहाँ पे एकदम फास्ट एक्टिंग ड्रग्स की ज़रूरत है, पेशेंट के जीवन को बचाना है, वहाँ हम कभी नहीं कहते, CCRS कभी नहीं कहता कि आप प्योर आयुर्वेदिक ट्रीटमेंट करो या उससे ठीक करोगे। यहाँ पे नीड ऑफ द आवर है कि हमें मिलके काम करना है। हम जहाँ पे हाइड्रोक्सी यूरिया की ज़रूरत है, उन पेशेंट्स के साथ में एड ऑन थेरेपी के रूप में आयुर्वेदिक ड्रग्स हम दे सकते हैं और उनसे ट्रीटमेंट कर सकते हैं। तो एटलीस्ट क्वालिटी ऑफ लाइफ पेशेंट की इम्प्रूव होगी, जो उसको बहुत सीवियर क्रॉनिक पेन्स रहते हैं वो कम कर सकते हैं, स्प्लीनोमेगेली पे बहुत अच्छा काम हो सकता है। तो फर्स्ट स्टेज में हम एड ऑन थेरेपी के रूप में आयुर्वेद को ले सकते हैं, जहाँ पे हम जैसे पेन्स में हम पंचकर्म करते हैं, मृदु, अभ्यंग, स्वेद, उससे पेशेंट को पेन में काफ़ी रिलीफ होता है। जहाँ पे हमको लगता है कि दोष की अधिकता है, वहाँ पे हम माइल्ड परगेटिव भी देते हैं ताकि कोष्ठ शुद्धि हो पेशेंट की। और इस तरह से रस रक्त धातु के प्रमोशन के लिए, उनके प्रसादन के लिए भी बहुत सारी ड्रग्स हैं, वो हम यूज़ कर सकते हैं। सम सिंगल ड्रग्स लाइक सिंगल हर्ब्स, बेल, जिसे आप बेल कहते हैं, वो अग्निदीपन, अग्निपाचन संग्राही है और इसको रक्त धातु के, प्योर रक्त धातु के फॉर्मेशन के लिए यूज़ कर सकते हैं और ये धात्वाग्नि मांदी को कम करेगा। एलोवेरा, घृतकुमारी, गुड़ूची, जिसको बहुत आपने अभी कोविड के टाइम में सभी ने आयुष क्वाथ पिया है जिसमें गुड़ूची है। देन सरपुंखा, ये इम्यूनिटी बूस्ट करती है। देन सरपुंखा, टीनोकार्डिया, टीनोस्फोरिया, परप्यूरा, ये हाँ स्प्लीन पे बहुत अच्छा काम है इसका, और स्प्लीन की इन्फ्लेमेशन को कम करता है, और लीवर यूजफुल इन डिसऑर्डर ऑफ लीवर एंड हेमेटोलॉजिकल कंडीशंस. Sickle cell disease, deformity in red blood cell, early destruction, and ultimately splenomegaly occurs. So Sarpunka is the best medicine to treat splenomegaly. Bhumyamalki Pylanthes amarus. The drug is useful in disease which causes debility in रक्त पित्त क्षय एक्सेट्रा. भृंगराज एक्लिप्टा एल्वा, जिसको हम ज़्यादातर भृंगराज को सब जानते हैं कि बालों के लिए यूज़ होता है, पर ये बहुत अच्छी लिवर हेपेटोप्रोटेक्टिव ड्रग है. एंड अदर सिंगल एंड आल्सो बी यूज्ड. आमलकी एज ए रसायन, मंजिष्ठा रक्त प्रसाधन ड्रग, यष्टि मधु एज ए रसायन, लोद्र पद्मकाष्ठ एज ए रसायन एक्सेट्रा. And some classical formulation also is there. Punarnama Bandur, Sanshamni Vati, Dhatrelo, Yograj Gugul, Pipiladhyasav, Dadimadile, Dadimadigrat, Drakshavle, Drakshagrat, etc. can be used. Chavanpras and Amalki Rasayan also can be used to improve quality of life of the patient. Summary of the this presentation is sickle cell anemia resembles with the presentation mainly of Batash Pandu with few lakshan of Pittash Pandu. Defect in the proper formation of shape of RBC can be attributed to cough, kshay and abnormal activity of Vata. Shorter lifespan of any cell is by the influence of Vata and his Ruksha Guna and lack of Snigdhita of cough. Vidagdhita of Rakt Dhatu by Pitta will cause the derangement in blood and blood components causing Panduta followed by Kamala. This condition is difficult to cure as involve multiple doshas and chronic in nature. Also it is hereditary in nature, so these doses can be taken into account of prognosis. So Ayurveda can be used as add-on therapy with the modern treatment plan to improve the quality of life of the patient. Some research initiative of the CCRS for the management of sickle cell anemia among tribal population also has been taken. The Ministry of Ayush supported a project entitled a pilot study to evaluate the efficacy, safety and tolerability of Ayush drug coded drug SC3 and CCRS formulation Ayush RP in sickle cell anemia patients under EMR scheme, which has been successfully completed during the 2014-15 at Maharashtra Arogya Mandal, SS Ayurved Mahavidyalaya, Pune. The drug SC3 was studied based on the leads of the practitioner at Pune, which is still in use in tribal populated area near to Pune. An article of the study finding also has been published. As per the provision of EMR scheme, joint patent for SC3 tablet has been filed between CCRS and MAM, and MOU has been signed for comprehensive drug development of SC3 in reverse innovation mode. Standardization of raw material and finished products has been completed by CCRS following the existing guideline. And another initiative project has been undertaken following clinical projects on sickle cell disease, which is in pipeline. Prospective randomized open label blinded endpoint exploratory clinical study to evaluate the efficacy and safety of the Ayurvedic regimen as an adjunct to hydroxyurea in the management of sickle cell disease in collaboration with AIIMS Bhopal. यहाँ पे दाढ़ीमादी घृत और वासा गुड़ुच्यादि कषाय को हम यूज़ कर रहे हैं. एंड आयुर्वेदिक इंटरवेंशन एज एड ऑन फॉर प्रिवेंशन ऑफ क्राइसिस इन सिकल सेल एनीमिया इन कोलैबोरेशन विद दत्ता मागे इंस्टीट्यूट ऑफ मेडिकल साइंसेज वर्धा अंडर ट्राइबल हेल्थ केयर प्रोग्राम. TSCRP प्रोग्राम है, इसमें हम आयुष RP और दाढ़ीमादी घृत का यूज़ कर रहे हैं. एंड another study to be undertaken as per the MOU between Ministry of Ayurveda and Ministry of Tribal Affairs, a proposal entitled Screening of Sickle Cell Disorder in Identified Tribal District of Odisha and Administration of Ayurvedic Intervention as an add-on for prevention of crisis in sickle cell anemia in under draft in collaboration with ICMR-RMRC Bhubaneswar. This project is in pipeline. So, lastly, I can say that this is the time when we collaborate and with each other and do the work in to improve the quality of life with the help of Ayurveda and for a specific disease with the modern science. Thank you all. आयुर्वेद में तद्वित संभाषा एक वर्ड है जो कि तद्वित संभाषा मीन्स सिम्पोजियम, सेमिनार, कॉन्फ्रेंस, वहाँ पे भी वर्णन किया गया है कि डिफरेंट अलग अलग स्ट्रीम के लोग एक साथ बैठकर, एक साथ मिलकर अगर किसी डिजीज़ के लिए काम करते हैं और एक फ्रूटफुल रिजल्ट, फ्रूटफुल कोई डिसीजन लेते हैं और उस पर काम करते हैं, तो डेफिनेटली भेषज आरोग्याय यथा ध्रुवम, उस औषधि से आरोग्य निश्चित ही मिलेगा। तो इसी उम्मीद के साथ में कि हम सब मिलके काम करेंगे। यहाँ एक बात और मैं CCRS के बिहाफ पे आपको बताना चाहूँगी कि अगर आप कोई भी इस तरह का ICMR के साथ में या और डिफरेंट ऑर्गेनाइजेशन से आप सभी हैं, अगर आप काम करना चाहते हैं तो अंडर एक्स्ट्रा म्यूरल रिसर्च प्रोग्राम CCRS के थ्रू आप उसको अपना प्रपोजल सबमिट कर सकते हैं। CCRS के साथ कोलैबोरेशन के साथ कर सकते हैं। फंडिंग वगैरह सब CCRS मिनिस्ट्री ऑफ आयुष के द्वारा होगी और आप हमारे साथ मिलके काम कर सकते हैं। आप हमें सजेस्ट कर सकते हैं कि इस फील्ड में हमें आपकी मेडिसिन का रोल देखना है, देन वी विल कोऑर्डिनेट टू यू or we can fight with this disease. So thank you organizer for inviting me and also audience for patiently listening. Thank you very much. Thank you.
Thank you so much, ma'am. If we have any questions, we can take.
Yes.
Any questions from the audience? Thank you, ma'am, for bringing forth the traditional wisdom of our country for the management of the sickle cell disease. I think I now request Dr. Apruv Das to please come on the dais and felicitate Madam Dr. Jain. I now request Dr. Ravindra Kumar to please come on the dais, and we'll be moving on with the panel discussion now. So, रवि है ना, रवि बुलाओ। कितने लोग? 6 लोग हैं, अटेंड करके वेट करना चाहिए।
Thank you, Dr. Nishant, for inviting me. Now I invite Dr. Graham Sargent, sir, for panel discussion. Dr. Tulika Seth, ma'am. Dr. Dipti Jain, ma'am. Dr. Italia, sir. Dr. Jyotish Patel, sir. हो जाएगा। डॉक्टर भावना मैम।
हेलो हेलो हेलो
hello, 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 hello. Hello, 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 hello.
Can we have slide, please? So, जब तक slides आ रही हैं, now I invite Dr. Sargent sir to share some experience about this symposium. And
Hello. Yeah. Right. Thank you. Well, it's been an interesting time. I've thoroughly enjoyed it. Some of the Hindi has passed me by. Some of the Gujarati has also passed me by. But it's been fascinating to see how much interest there is in developing services for sickle cell disease. And this is of a particular relevance to me because as you may know, I've worked in Jamaica now for 55 years, but the disease we have in Jamaica is of African origin. And the more that I see of Indian disease, I realize that there are differences. Some of those differences are quite important, and you're going to have to develop your own services and models of care. And what has been very reassuring at this meeting is the progress that has been made in such a short time with the management of sickle cell disease and also the awareness of the condition. So it's been a privilege to be here. I'm sorry I've been a bit tiresome with the wheelchair, and it's such a stupid thing with the ankle. But so I must thank my hosts for all the trouble they've taken. But it's been a pleasure and a privilege to be at this meeting. Thank you.
Now my question to you also, sir, that a lot of has been talk about the several complications of sickle cell disease. We have several markers for identification of the liver disease and prevention, so that we can although rare, hepatic sequestration in sickle cell disease, I want to know about the symptoms, early symptoms for hepatic sequestration, or what are the management protocols for hepatic sequestration in sickle cell disease?
It's a question for you. Can you read here? Hepatic sequestration in sickle cell disease and
those are for me, are they? I can see two questions.
Yeah,
hepatic.
First is hepatic.
No, hepatic sequestration in SCD and avascular necrosis of what?
Avascular necrosis for prevention. What do we do for prevention of avascular necrosis in sickle cell disease?
Do we know what we're talking about? Avascular necrosis of?
Hip or shoulder.
Hip or shoulder.
Oh, my goodness. All right. Well, let's start at the beginning, which is a good place to start. I know almost nothing about hepatic sequestration. It's something that we see occasionally in Jamaica. It's very poorly characterized. We don't understand why. But I think this may be yet another difference, because I've been privileged to go with a number of Indian colleagues to sickle cell camps around the country. And I've taken a number of photographs of young children with huge livers. And I don't know why that should be so different in India. So whether there is a component related to the diet, or, once again, you need to document your own disease. So get together a group of children who manifest hepatic sequestration, look at their characteristics, get controls at the same time to actually compare them, and then you'll begin to see why some kids seem to get hepatic sequestration. Coming down now to avascular necrosis of the hip and the shoulder, of course, they're quite, involvement of the shoulder is relatively common, but it's not a weight-bearing joint. So most people with avascular necrosis of the shoulders don't really need, they need mild symptomatic therapy. It's often ladies who have difficulty combing their hair, raising their arms in a certain position, but we rarely find shoulder replacement necessary. The story with hip necrosis is totally different. This is a major and important problem. And the crucial factor here is the age at which you develop necrosis of the femoral, of the capital epiphysis. If it's before the epiphysis is fused, in normal people 17 to 18 years, then the whole the whole femoral head may crush down. You'll get a funny mushroom shape deformity, but you retain a good joint space, and you often have pretty good painless function. So these people are often picked up just by x-rays. If, on the other hand, your capital epiphysis has fused, then you get a segmental necrosis. If you continue to weight bear, you drive that dead piece of bone marrow down into the femoral head, creating all sorts of chaos with the vascular supply and with the joint space. So make the diagnosis as early as you can and avoid weight bearing if possible in people who are, well, you need to avoid weight bearing regardless of the age at which it happens. And it sounds simple, but it's often extremely difficult to do. So those are just a few thoughts.
Slides. Now my next question to Jyotish Patel, sir. What is the role in hydroxyurea in pregnancy and post-pregnancy period? And how sickle cell trait and pregnancy, as there is in this is the management is normal to the normal person or a sickle cell disease cases?
Yes. Hydroxyurea and pregnancy and post-pregnancy, whether to use it or not.
Yes, whether to use or not.
Conventional guideline is during pregnancy you avoid use of hydroxyurea. That is one. We come to post-pregnancy status. I heard from one of the talk that in lactation it has been proven that it can be used. Still, I'll have to get more support of that. What I practice at my place is we avoid hydroxyurea till the lactation is there. But with this information, possibly we may revise our thinking process, sure. And as far as sickle cell trait and pregnancy is concerned, I think should be managed like AA with pregnancy. I don't think there is anything to be added, except that if sickle cell trait and pregnancy is there, I would always advise couple to get husband tested for sickle gene, right? And if husband is normal, not only for sickle, now we do even for testing for beta thalassemia, because so many combinations, double heterozygotes are coming up. So husband should always be tested if sickle cell trait is going to become a pregnant. And if there is a chance that husband is beta thal trait or sickle cell trait or any other hemoglobinopathy, E hemoglobin, D hemoglobin, in that case, prenatal diagnosis must be done to find out that what that fetus is. Otherwise, if husband is totally normal and mother is sickle cell trait, they should be treated as normal as others. Thank you. Madam, you wanted to.
So I just wanted to comment on the breastfeeding. So there's a very nice paper by Dr. Vichinsky and his group from California, and they did a detailed study on the amount of hydroxyurea drug that comes into the breast milk, and they found that it was a very, very minuscule amount. And we know that breast milk is so important for our patients. And in fact, in his article, even in the US, they had stated that breastfeeding was safe in women who were taking hydroxyurea. And often the women in the US are taking much larger doses of hydroxyurea than what our patients are taking. So I think because we don't want our babies to not be able to get breastfeeding, I think we should allow it. And I completely agree that it's, in fact, what we recommend for patients who are even planning pregnancy, we advise them to stop hydroxyurea because we don't know when conception will occur.
One important, yes, sir.
I think recently it has been said that if you're to weigh the risk of hydroxyurea with the risk, some patients become very, this is not for all patients. So we don't give hydroxyurea to all patients who are breastfeeding. It's only if they have severe pain. Severe VOC, mainly it's pain, which is say, breastfeeding also. We will give only if there are such, at least for first 3 months, we will give if they are symptomatic. And even during pregnancy, we do not give in the first 3 months. But then in the second trimester, if the patient has severe manifestations, you have to counsel them. See, this is a drug which may cause teratogenic effects, but that period has gone and now you are getting so much of pain. So if they agree, we take a consent ideally and then give hydroxyurea from second trimester.
Because in tribal areas, mostly when the patients are, most of the pregnancy is unplanned or unbooked pregnancy. So most of the problem then when we talk to that, when a patient of 18 years age, we start hydroxyurea, and then if the treatment is going on for the 3 year or 4 year, the patient become pregnant after a 23 year or 25 year. Then suddenly stoppage of hydroxyurea during the pregnancy, it is can cause more severe problems to the during pregnancy, or pregnancy itself is a complication for sickle cell disease. So we should how to counsel that how to taper the dose, or before 3 months it is advisable, or guidelines before the conception of the 3 months the hydroxyurea should be stopped. But it is possible in tribal and rural areas, or how to manage?
My patients, they who are taking hydroxyurea, they come after pregnancy and they're not stopped hydroxyurea.
Okay.
So it's not only trial.
Oh, thank you. नेक्स्ट क्वेश्चन इज स्लाइड ही रहने दीजिए ना, आप ये वीडियोस आप रिकॉर्ड करते रहिए, यहाँ पे स्लाइड प्रेजेंटेशन ही रखें. तो डॉक्टर भावना मैम, sometimes a patient given a transfusion, and after the transfusion the hemoglobin levels certain falls in spite of the increase, and so how to manage the hyperlysis syndrome in sickle cell disease patients?
I think I mentioned in my talk also, and as you correctly mentioned, that in spite of the hemoglobin rising, paradoxically after a transfusion you can have a fall in the hemoglobin from the baseline level, which is because of the exaggerated hemolysis or hyperhemolysis as we call it. You can have it if it happens within the first 7 days, it is the classical or early hyperhemolysis, or you can even have it beyond 7 days wherein alloantibodies form and they can lead to hyperhemolysis of already existing sickle RBCs after you have transfused fresh RBCs. So the diagnostic thing is that there will be a increase in LDH levels, the bilirubin levels will be increased, the hemoglobin will keep falling. In the early or classical, within the first 7 days wherein there is not enough time for the alloantibodies to form, your DAT may be negative. But after 7 days, if it is a delayed presentation, your DAT or a Coombs test might come positive, and there will be reticulocytopenia. There is no reticulocyte formation, the reticulocyte count is not increased. The pathophysiology, what they think is that predominantly it is either complement mediated or activation of macrophages after transfusion of donor RBCs. So complement mediated or activation of macrophages, so treatment again, like most other immunosuppressants, are the mainstay of treatment. IVIG or steroids can be used, and in certain cases monoclonal antibodies can also be used for management of hyperhemolysis syndromes. Further transfusion should not be given because it will lead to further hemolysis and fall in hemoglobin levels.
So what should be done when the patient having hyperhemolysis syndrome and hemoglobin level falls to 3 gram or 4 gram?
Yeah. So the presentation usually is, as I said, there is a history of blood transfusion,
in the past, in the early phase within the last 7 days before presentation, and the patient may present with fever, jaundice and hemoglobinuria. So providing symptomatic and supportive care is very, very important. If there is severe vaso-occlusion, severe pain, you can consider an exchange transfusion also. If there is severe anemia which is giving rise to fluid overload symptoms or congestive cardiac failure, small aliquots of transfusion of 5 ml per kg can be considered, but transfusion as far as possible should not be given if you are thinking of a hyperhemolysis.
Thank you. Now my question to Dr. Dipti Jain ma'am. So hydroxyurea again. So in certain patient, as discussed in the today's morning session, also that Dr. Patel has questioned that the hyperactivity of the hydroxyurea. So in cases when there is a hyperactivity of the hydroxyurea and the hemoglobin level goes up to 12 gram per deciliter, then we should stop the hydroxyurea or lower the doses of the hydroxyurea.
I think it is not mentioned anywhere, if you look into the literature, that you have to stop hydroxyurea. However, in practice, it is a very paradoxical situation. When you start hydroxyurea, what we have seen, I don't know, other clinicians, I don't know about others, but once we start hydroxyurea, hemoglobin starts rising. And once, in most of the patients, if it crosses 12, I would say, yeah, 11.5 aa gaya, 12 hua, they have increased crisis frequency, painful crisis frequency. Initially, when you start hydroxyurea, it will decrease. It is like a magic drug. Jisko itni baar POCs ho raha tha, they will improve. But then they come with complaint. Initially, we were better, but now our crises are again coming. So one thing which is commonly done is increasing the dose. By increasing the dose, they think the dose is inadequate, so they increase. However, the crisis does not go. Now, there are viscosity syndromes, and it is very well known. I think Dr. Sargent has been repeatedly telling, higher the hemoglobin level, more are the painful episodes. And that is what we have experienced. So even my social worker will come and tell me, Madam, if I miss to see the hemoglobin, Madam, iska hemoglobin 12 se uppar ho gaya, isliye usko pain hai. They also know, and the patients also. So I think this is what we have to be watchful about in our practice. And I think all of us, I don't know, Dr. Jyotish will like to say on this, but my experience is, once they reach 12, I go back to 5 per kg. Gradually decrease the dose. Don't stop it. Decrease the dose and watch.
All patients who are put on hydroxyurea, if you look at the rise of the hemoglobin, it's not that the 7 gram person would go to 11, 12. It's an occasional case, yes. In fact, there are cases who are remaining 7 gram person, okay, a patient remains a 7 gram person, but at the same time, the crisis, the symptomatology has gone down. That is because of the even distribution of fetal hemoglobin, which is really an advantage. Talking about, some extraordinary rise, I think there is some background which must be, causing this kind of issue in the body. Which marker is there, I am not aware of. But at the same time, this is really a very occasional phenomenon. Let me tell you, it has occurred in my single patient. And to my surprise, his fetal hemoglobin is 35.4%. And that patient was put on hydroxyurea a couple of years ago. And in fact, the argument could be, why you have put this patient on hydroxyurea. And that his hemoglobin went up to, 16 gram %. And having said that, he had symptoms. He had avascular necrosis head tremor. We had to replace him. So I think these are all exceptions rather than a rule. But at the same time, there are chances that a case may have a profound response.
The guidelines for blood transfusion says sorry, Dr. Sai, says that the hemoglobin should not go above 12 grams while transfusing a child about in sickle cell disease. Okay, if we can, and I think the dose they are giving now, it's increasing the dose maximum to 20. That would, I have seen patients, I don't go usually about 10, but still our patients are, if they are on long-term hydroxyurea, they do go to 12, about 12. Hemoglobin is about 12. Dr. Sarjan.
If I may make a quick comment, beware of steady-state hemoglobin levels. In African disease, most of our patients have steady-state levels between 6 and 9 grams. They're fine. But remember that hemoglobin S in the cell has a huge shift in the oxygen dissociation curve. And this means that a low hemoglobin carries unexpectedly large amounts of oxygen compared to an AA person. And if I could embark on a very short story, it was about Donna. And Donna was a lady who I looked after some years, and she finally emigrated from Jamaica to Atlanta. And her hemoglobin, over 18 years that I followed her, had never been more than 5 grams. And when I last saw her, it was 3.9. She had never been transfused in her life. And you say to Donna, how are you? And she said, oh, I'm fine. I said, what about the end? Oh, she said, at the end of the day, I'm tired. Who isn't? She emigrated. She was in Atlanta for 5 years. And then she thought, well, gosh, you know, I'm mid-40s now. I better go and have a pack. So she went to her primary physician, and he said, just a minute, you have sickle cell, don't you? And she said, yes. And he said, we better check your blood. So we checked the blood, and it was 3.8 grams, 0.1 of a gram different from her last hemoglobin in Jamaica. And she received a phone call to say she must go immediately to accident and emergency, and if she didn't go, she was going to die. So she went. She didn't want to be transfused. Her husband didn't want her to be transfused, but they said, we're not going to take responsibility unless we give you 2 units of blood immediately. And they did that, and her hemoglobin went from 3.8 to 4.9. And then they gave her 4 more units. Within 24 hours, she's now been transfused for the first time in her life with 6 units of blood. Her hemoglobin was now 11.5, higher than it had ever been. 2 or 3 days later, she felt unwell. She bled into her ventricles. They turned off the life support system after 2 weeks. She died because the doctors were treating the hemoglobin level rather than the patient, who said, I'm fine, a bit tired at the end of the day. And at the trial, which I was an expert witness, the jury awarded $11.5 million to the family because the doctors looking after Donna had treated her hemoglobin level rather than her patient. So beware.
Now my next question to Dr. Seth regarding this analysis. When we go to the packet insert also and the various researches, it says that after the infusion, there is a 3% risk of pain in infusion-related pain of cellular, and 15% patients suffer from back pain and 12% from abdominal pain also. So sickle cell disease patients also suffer lots of pain, and further they faced a 3-strand trial that shows that no significant results. So we should wait for more research studies, or we should continue to...
So I was not aware. Dr. Deepthi told me yesterday that perhaps crizoluzumab will now soon be going off the market. But just a little background on that, even during COVID, we had attended some webinars, and there were patients who on crizoluzumab developed vaso-occlusive crisis. So it could precipitate crisis. And there is now recently some data from the STAND trial. The earlier SUSTAIN trial was the RCT, which was done to get approval. Then the STAND trial is a real-world data. And in the real-world data, they actually found that whether you use crizanlizumab at 5 milligrams per kg or 7.5 milligrams per kg or placebo, there was no difference. So with that data, we kind of need to question whether it's worth it, because it is very expensive, it's an injection, there are side effects, and if there's really no benefit, then I don't know. But let's wait and see. I don't know what the company is going to do. We haven't gotten any official notice from them as yet, but this was a very disappointing result.
Okay, one more question from you. You yesterday said that there are 3 more drugs, nalizumab, voxelotor and L-glutamine. So what are the indications for starting the voxelotor over L-glutamine or L-glutamine over nalizumab? So when the hydroxyurea is not working, so which would be the drug of choice first?
Well, voxelotor we don't have in India, and voxelotor, the major benefit of that is to increase the hemoglobin. So again, if somebody already has a hemoglobin of 12, which sometimes our sickle cell disease patients have, then I don't know what would happen in those patients. But the advantage is that it will increase the hemoglobin, and in fact during COVID time it was often discussed in some of the webinars that in patients, if you could not transfuse them, you could put them on voxelotor, but obviously that was not related to India. So voxelotor, again, the trial says that there are decrease in VOCs, but again, I think sometimes we need to look at real world data, and the hemoglobin is improving, and it also had a benefit on the transcranial Doppler. So again, it kind of works like a transfusion support. L-glutamine, I think, again, there's a lot of questions about it, but it seems a very safe thing, and I think it's something that can definitely be added on to hydroxyurea, and we already have some Indian experience from people who are using it. So I think at the moment we don't have many options, and so again we kind of come back to what Rahul was saying, that maybe we need to assess patients who are failing adequate doses and adequate compliance of hydroxyurea, and maybe think of transplant. So just another thing I just wanted to put out there, though we do have cases of patients who have survived till, Dr. Italia spoke about patients who had survived till 80 years, but in many tribal areas the life expectancy is not very high. So now whether it is due to sickle cell or other things, I don't know. So I think we need to think of this as a serious disorder, and if we have options for treating and curing, I think we should take them.
Now, since Dr. Bhargava is left, so I ask Dr. Tulika ma'am again. So, decision to start the bone marrow transplant at the birth or at the earliest when the matched sibling, or try hydroxyurea for a certain time period for 1 year, 2 year, or 6 years, then we thought for the bone marrow transplant. So, what is that should be done?
So, the data for transplant outcomes is best when done in younger patients. So, there's several recent reviews where they've looked at CIBMTR and other data from transplant, and they found that pediatric patients less than 13 years had a much better outcome for transplant. So, if you have a child who right from the beginning is showing a very severe phenotype, there's no reason to wait. And as I said, I think we are in a very important time, because we are now, because with all the work of all of the people here who've been working in sickle cell for so many years, we are now seeing better survival. So many of these babies who would have otherwise died in the newborn period are now surviving, and so we will be seeing children with a more severe phenotype in the next coming years. So that is going to be a new challenge for us. So these would be patients who, if they fit the criteria, we should definitely take them for transplant. But if somebody, and that would be on treatment, obviously, because we would identify them, put them onto hydroxyurea, make sure they are getting the best care possible. But if they have a adverse phenotype, transplant them early. And if at any point of time they are really not failing, then we don't need to wait. As I said, the newer ASH guidelines, they're actually a little bit more liberal towards transplant than the earlier Walters guidelines. So that is because we now are giving transplant to patients who are fitter, right, rather than waiting for them to get irreversible sequelae. And that is also because the results of transplant are better and it is becoming safer. So as we get along, we will probably in India too be offering it to patients who don't have, a major stroke and other things like that. So I think that's what I
So
want
in
to
your
say.
opinion or take-up message, first the person should go for the transplant and
I'm sorry?
once the patient is good, diagnosed with the sickle cell disease.
No, I'm not saying everybody at birth. I'm saying if they have a severe phenotype on standard therapy, if you're planning transplant, then do it early.
Now my question to Dr. Italia, sir, that has several screening programs and shown a wonder that. So in your opinion, sir, what is the best method for prevention? Universal screening, that we screen all population of 110 crore or 130 crore population for India, or we should go focus on targeted screening that certain communities or certain age groups for sickle cell disease prevention?
Very simple answer. पैसा कहाँ से आता है, कितना आता है? See, when we did the screening program in Gujarat, it was funded by the tribal ministry. I was told कि आप 1 करोड़ रुपए का प्रोजेक्ट बना के दो. In the evening, I was told 3 करोड़ का बनाना. फिर बाद में मिनिस्टर का फोन आया, नहीं इतना थोड़ा ज़्यादा बढ़ो, 9-10 करोड़ तक जाओ. और फिर फाइनली नेक्स्ट डे मॉर्निंग जॉब आया, नहीं 3 करोड़ पे ही रखो. 3 करोड़ का प्रोजेक्ट शुरू हुआ, दिसंबर तक कुछ हो नहीं पाया गवर्नमेंट. तो दिसंबर में कुछ समीक्षा बैठक बुलाई गई और उसमें मालूम पड़ा कि सिकल सेल के ऊपर जो पैसा स्पेयर किया है उसके ऊपर काम नहीं हुआ है. तो उस टाइम जो कमिश्नर थे उसने मेरे को बुलाया और बोला कि चलिए आप ले लो, कोई काम करने वाला नहीं है. सो एवरीथिंग वाज हैंडेड ओवर टू मी बाय रिजोल्यूशन ऑफ द मिनिस्ट्री. और फिर बाद में दिसंबर में ये हुआ तो बोला कि अभी तो 3 महीना है, आप एक काम करो, 1.5 करोड़ में जो करना है वो करो. तो फाइनली इट वाज डिसाइडेड कि 1.5 करोड़ में करने का है. 3 महीने में 1.5 करोड़ कहाँ यूज करेंगे?
When it is not a matter of concern of the price or money or budget, then because we have to reduce the burden by 247, so we have to make the appropriate plans for that. So universal screening or targeted for making a zero sickle cell birth.
हमने जो स्क्रीनिंग किया उसमें हमने सिकलिंग टेस्ट खाली सोल्यूबिलिटी से किया.
हाँ.
जो सोल्यूबिलिटी से किया उसको वाइट कार्ड दिया हमने. जो पॉजिटिव और डाउटफुल थे उनका खाली HPL से किया. तो हुआ क्या कि 90% पेशेंट got a white card. Now we don't know about the thalassemia cell. So abhi we are going to correct that mistake by screening all antenatal patients जिसके पास येलो कार्ड है, हाफ येलो और फुल येलो, उसको हम नहीं करेंगे क्योंकि उनका तो हो गया है. दूसरे जो भी वाइट कार्ड वाले हैं वो सबका हम करेंगे और उसमें से जो निकलेगा उसी हिसाब से हम आगे जाएंगे. होता क्या है कि अगर इफ यू वांट टू मेक दिस टाइप ऑफ प्रोग्राम इन पब्लिक सक्सेसफुल, देयर आर नंबर ऑफ इंटरेस्ट. तो हमने सीधा बोल दिया सब गायनेकोलॉजिस्ट को कि अगर आप अपनी लैब में करवाते हैं तो हमें रिपोर्ट भेजो, हम नहीं कहते हैं कि हमारे पास ही करो. अगर वो लोग रिपोर्ट भेज देंगे तो हमारा काम हो जाएगा. तो इसलिए इट इज़ बेटर जब भी ऐसा कुछ प्रोग्राम रहता है तो यू हैव टू बी प्रैक्टिकल विद देम, बिकॉज इफ यू वांट टू इन्वॉल्व प्राइवेट डॉक्टर्स एंड गवर्नमेंट डॉक्टर्स में क्या है कि अभी हमारे वहाँ हर एक वाइट कार्ड वाले हर एक प्रेग्नेंट वुमन का गवर्नमेंट में ट्राइबल एरिया में होंगे. सिकलिंग टेस्ट होता ही, जो सिकल पॉजिटिव आएगा उसका खाली HPL से जाएगा. तो अभी वी आर गोइंग टू स्क्रीन 100% population just because I have got some money.
So screening should be focused for tribal areas only, not for other.
It is urban and tribal area. It is private and government hospital. It is 100% population of the Valsad district.
And yes, you have that. So we should screen the 100% population of that particular.
Pardon?
We should screen the 100% population.
Yes, I intend to do it. Probably 20 to 25% people might have reports, because already there are few yellow card people. We don't want to screen them again. There are private second pregnancy, third pregnancy might have been done previously. So जो report लाएंगे उनका नहीं करेंगे, बाकी सबका करेंगे.
You're in lectures in morning that you showed that the despite of avoiding of marriages between the trait and prenatal focus should be more on diagnosis. Focus should be on prenatal diagnosis and followed by the MTP of affected fetuses. But in rural areas or in tribal areas or in metro cities, the facilities for prenatal diagnosis is still not available at many centers. So what should be the immediate steps should be taken for prevention for the disease?
See, we are successfully doing prenatal diagnosis at the moment. And I am sure that the people with whom I am working with, they have faith in us. If we tell them for their benefit without expectation, they will definitely believe it. Those families who have seen the suffering of the patient, they will never say no. So all these type of things are there, and it is 100% voluntary. It is purely voluntary. So maybe some may not agree with us, and we are not going to force. Those who are ready for termination of pregnancy, that cases only will be subjected for prenatal diagnosis.
Now further one more question that we've seen that in India, sickle cell disease phenotype is from very asymptomatic to transfusion dependent and severe vaso-occlusive crisis, 3 times or 4 times hospitalization per day. So it is advisable for asymptomatic sickle cell disease patient to not to be born or
See, it's a big question. It's a big question, and that is why we have kept this 100% voluntary.
Yeah.
Let people decide whether they want or not.
Yeah, let people decide. So what
you can say that in thalassemia it is 100% justified. What about sickle? I do agree with you in that sense, but let us try what.
Let people decide. So I invite all the faculty members to say one take-home messages to all participants. One take-home message from each faculty.
See, thalassemia patients, thalassemia is a rich man's disease, while sickle is a poor man's disease. So whenever we think about sickle treatment or anything, we must keep in mind that they are low-income people, and the government should provide them whatever is possible for them. I think the present government is doing that, and we are really, the scenario is really good at the moment. Even with introduction of, even with Mangubai Patel coming to Madhya Pradesh, I can see how far within 1.5 years or 2 years development has been done. Such strong leadership, strong will, political will is needed for this type of, and people should take advantage. I always say in my area, you see, government is going to give you all these things free, but you should take advantage. That is most important thing. In government, sometimes what happens that one doctor is keen to do everything, other doctor has no interest. So doctors go on changing. So this type of things happens, but overall it is going good, and whatever is done is good for it.
Thank you, sir. I would say one-line message: prevention is better than cure. Universal newborn screening, and prevent further children from being born with sickle cell disease by offering prenatal diagnosis.
So I think we need to collect data, and I think it's time all of us work together. And we have, somebody told me the other day that we have 1 billion more people than the whole of the United States of America. So I think we need to come up with very large studies and have data of our own patients so that we can treat them in the best possible way.
Let me just make a very quick comment. Obviously, the role of premarital screening is influenced to a large extent by the social, cultural context of marriage in your society. Let's go back to Bahrain in the Arabian Gulf. And for 8.5 years, they did voluntary premarital screening, and they found it halved the prevalence of SS births. So the king passed a decree at the end of 2003 that was implemented in February 2004, which was that no person in the Kingdom of Bahrain should be married without premarital screening of both partners. The same law was actually passed in the Kingdom of Saudi Arabia. And the interesting thing is, if you look at their figures, the last figures I saw of this program was in 2009. They found that, first of all, the partners, the prospective partners for a marriage may never have met. They're mostly arranged marriages. They're organized by the parents. And what happens is they cannot get married without being tested. So they're tested, and the families receive a report that either says this marriage is fine or this marriage is not recommended. They haven't actually said who has the gene, but the inference is that both prospective partners carried a gene that could give them a child with sickle cell disease. The end result was that over half of those planned marriages were cancelled on that basis. So it became mandatory. Mandatory premarital screening is absolutely routine in the Kingdom of Saudi Arabia and in Bahrain. You go to Jamaica, where we have a totally different social context, and marriage is something that you do when your children can come and your grandchildren can come. It's when you can entertain the village as you would wish. You've already had all your children. So it's a totally different context. So what we did was we screened 16,000 kids in the center of Manchester Parish, in the center of Jamaica. And we gave them all their genotypes, and we gave them lectures on sickle cell disease, and we said, fine, you have the sickle cell trait. They've got a little laminated card saying that you have the sickle cell trait, and on the back it said that if you actually have children with somebody else who has the sickle cell trait, you have a 1 in 4 chance at each pregnancy of having a child affected by SS disease. We then monitored their progress over 5 years, and we found there were 5 babies with SS disease born to mothers who knew they had the trait. The projected figure was 5.5. So in Jamaica, it made absolutely no difference at all. And when you interviewed the mother said, listen, doc, I knew I had the trait. I knew I was at risk of a baby with sickle cell disease. So I said to my boyfriend, you must be tested. Me? Nothing wrong with me. And of course, there was nothing wrong with them. They just had the sickle cell trait, and they had a child with SS disease. So when you're talking about marriage and the effect of premarital screening, you can't dissociate it from the society in which you're working.
Madam wants to keep last. Number 1 is, with determination of eliminating or eradicating sickle cell disease by 2047, there is going to be a huge responsibility of clinicians around to effectively manage cases which are diagnosed. Number 2, when they are diagnosed and have critical situations, we need a lot of wisdom on case-to-case basis when we are really managing their critically situated patients. What I learned in last 2 days, and what I feel that it is a need, that there are differences in scenarios of cases across India. Madhya Pradesh has some difference, Maharashtra has a difference, Gujarat and the Chhattisgarh also has a difference. Madam Tulika ji is here. Madam, it is my sincere request that there should be a clinicians meet, and maybe we must go to every place and see with our own eyes and try to understand that why such a huge difference that our patients they have. A place where daily exchange transfusion is required and a place where there are no exchange transfusions done, it is being done occasionally. A place where the acute chest syndrome is a big problem and patients are dying, a place where there are no cases. I think it's a time now that we must go to the places, see patients, not the data. See patients and see why those differences are and try to study them. Number 3, I am still confident and aware that the biggest doctor is nature. And I am the man who would never disrespect nature. The sickle gene which has come to a mankind is 7,300 years ago. There can be an objective of minimizing the birth of sickle cell disease patients, but there cannot be an objective of eradicating sickle gene from our country. The reason is, I have been saying since last 35 years, if sickle gene is eliminated, the tribal population would be eliminated. Let me tell you that nature has given this with some reason which we as a doctor are not able to understand. And last quotation of Pujya Acharya Swamiji, he came to my place to inaugurate our hospital and he said, what is research? Research is whatever was searched, you are trying to relocate with some different angle. So we as a scientist, we as a doctors, we think that we are doing something heroic by doing some research, and this research, the interpretation, the validation, which is good today, which is looking okay today, may not be which will be 180-degree reverse after a couple of years. With this note, I end. I congratulate NITH, Aparup Das ji, and Ravindra and the team for excellent sickle cell update of Madhya Pradesh. It has been managed very well, and I'm sure that the way in which the awareness is created and the participant is there, I think it is a time now that we involve medicine, Indian Academy of Pediatrics, Indian Association of Pediatrics, FOXY, the pathologists, let them come on the one platform and go for the comprehensive management of sickle cell disease. Thank you so much.
I think most of the things have been told. I just want to add now that when we see a patient of sickle cell disease, think that this is the opportunity not only to look at the clinical side. As a doctor, we would just see the patient, give the medicine, and she goes. No. I think I have learned working with sickle cell patient that is the opportunity to talk many things. Also the social side of their life, because that is really bothering them. Their school performance. That is the time when you tell them that next time when you are pregnant, you can go for this. They may not get this opportunity. I just want to tell that in one line that anticipatory guidance is very important. While seeing the patient, you can tell so many things to the parents, to the patients. That is one thing. Second thing is, now we are seeing patients who are growing, coming into second decade, third decade. So one has to take care of organ damage, and that has to be anticipatory testing for organ damage and start treatment. I think that is must. Otherwise, we are doing so much, they will in second and third decade land up with And last, of course, my favorite thing, inappropriate transfusion. Inappropriate transfusion. Yes, there are indications for transfusion, but still I see transfusion is used even when not recommended. Every child, the treatment is tailor-made, specific for that child. You cannot have this child I'm giving this, the other will the same, no. Like probably thalassemia I can quote. In thalassemia it is transfusion, chelation and some endocrinopathies. But in sickle I think great variation and it has to be very specific for the patient. Thank you. And thank you Dr. Das, Dr. Ravi, Dr. Subramaniam, all of you, all the team, and the audience has been great. Thank you very much for this meeting.
Thank you, ma'am. Now I invite Dr. Nishant Saxena for further proceedings.
Thank you, Dr. Ravindra. I now request all my panelists to stay here because we will be felicitating Dr. Graham Sargent, sir. So I request Dr. Apurv Das sir to please come on the dais. And
good afternoon, everyone. It was as mentioned by everyone, it was a fantastic meeting you all. I would request all our NIRTS staff also to please come to the dais so that we can get together and in the felicitation of Dr. Graham Sargent. I would like Dr. Raja Subramaniam to take the mic so that he knows Dr. Graham Sargent much more than anyone in our institute knows. So I would request you to tell something about him, his contribution and his work, which is as far as I know is very illuminating, and as far as the public health of sickle cell disease goes, and your book, sir, the sickle cell disease is really I think everyone who has read something about or knows something about sickle cell disease, it is the book from Dr. Graham Sargent. So I would like Dr. Raja Subramaniam to please say a few words about Dr. Sargent, and then we will officially felicitate him because it's a great opportunity to have him here. Thank you so much, sir, Dr. Sargent. It is great to see you and great to see everyone in this symposium. Dr. Raja Subramaniam.
Thank you, Dr. Das. And it's indeed an honor to speak about Dr. Sargent. And I'm not a hematologist. I'm a basic molecular biologist who learned sickle cell after joining ICMR-NITH. And the first thing my lab mates gave me was to read the book of Dr. Sargent. So, and he is a living legend, and he is an icon. It's a blessing in my life that I'm able to share a dais with him. And like even after yesterday's evening's program, I had wrote to my sister that he is like a Nobel laureate, and I hope he gets one Nobel for the cause that he's been fighting since 1966 in Jamaica. And his commitment to the disease, even today, he mentioned that he has come to India 29 times. And I do not know how many of us would visit our patients 29 times if they don't come to our clinics. It's that constant perseverance and the commitment to the cause that he's taken, and we should all learn from him. And we should thank God that we'll be able to meet him and hear him in this dais. And thank you, sir.
Once again, let me say what a pleasure it is to be here. This is my 28th visit. I hope I can make 29 and maybe 30. At the age of 84, things are beginning to fall apart, as you know, with my left ankle, but hopefully it will recover and I shall come back and plague you again. I've always enjoyed your enormous hospitality, and it's been a pleasure always to be here, to see you and to see some of your patients. Thank you.
Anyone wants to put anything?
I think I've been associated with Dr. Sargent for last 2 decades. He usually comes at least once a year to now. And I must quote one thing, that when I was transferred to Akola, which is a very small place, he came to Akola. There were no hotels. He stayed in the very simple place. And working was morning 7 to night 11. And we saw 91 families of sickle cell patients. And each family he would examine, and my resident would collect the blood, and before sleeping, he'll see all the reports. One day, and if the husband is not there, we must get the husband on the same day. The family would come, but husbands would go to work. He said, no, I want to see him and collect blood. One day, one sample was hemolyzed, so we did not get the report that night. So he knocked at 11 o'clock. Said, Dipti, where is that Nayak's report? I said, the blood got hemolyzed. No, we can't look like that. So at night, my resident took the blood sample and gave him the report at 5 a.m. in the morning. He's that particular, precise, so hardworking. There is so much to learn from you, sir. So much to learn from you. And even entry, ek jagah, ek cheez missing hai. We always have so many columns which have missing data. No, he will not have that. I have to have all the information and could check himself. So I think that is how meticulous he is. Yeah.
Excellent student.
This felicitation, apart from you, also goes to Beryl Sargent. And we remember Beryl Sargent, and we say thank you to her for allowing you to come to India. Thank you so much.
Thank you, that's a very kind thought, and I will convey that later over your phone, if you will allow me to do so. I should explain very briefly that Beryl is actually 8.5 years older than me. So if I'm 84, you can quickly work out that she's going to be 93 in April. But happily, she's very healthy, very well. She thinks she probably will not endure India again, but she's always enjoyed her visits. So she'll be very pleased to get a report of everything that I carry back with me. So thank you for those comments.
Dr. Sargent is a frequent visitor. He stays at my place only. Luxurious. And he always say, I'm going to stay at Italia Residency. Although it is a flat, he will say it is Italia Residency. It's so simple. He knows each and every person in my staff also. He inquires about each of them at the moment. Where is Vishal? Where is Bhaved? And everyone loves him. Probably I have not shown the slide of his presence in my, probably his miss. But everyone knows him very well. Every time he comes, number of patients comes to us, and he remembers the patients each time he comes and asks about them, how is he, how is that. So as you say, Madam said, he is very particular. Thank you, sir. Thank you for your guidance, and thanks for inaugurating our Gujarat program, which is going on well. Thank you, sir. I had been to his place and enjoyed staying at Jamaica for 4 days, 4 or 5 days. Thank you, sir.
works, I wanted to see from where he writes books and where is his laboratory. So I had gone to Jamaica for a meeting and he came to take me to his home. It's a very simple sadi room, okay, which is full of papers and books, microscope and a small lab, that's it. So all this wisdom comes from a very simple place where he stays, a very nice place.
Thank you, sir. Thank you. This, thank you very much for arranging all this. The wonderful things.
Pleased to see us go. It must have been a lot of work.
Yes, taken very calmly, everything well managed, well arranged. All good speakers. Not because I am good, all are good, I am telling. But the subject you have chosen, everything was absolutely.
Thank you, sir.
I now request Dr. Raja Subramaniam to kindly deliver the formal vote of thanks.
Good evening, all the participants. I thank Director ICMR-NITHR for giving me the opportunity to express my gratitude on this special day. And it's the biggest day in the history of our institute. Today we have hosted the biggest sickle cell symposium with most illustrious Dr. Graham Sargent as the expert who shared his experience in the past 50 years. Today more than 300 representatives and more than 15 experts from various institutes and hospitals have participated in the symposium, making the symposium a big success. On behalf of ICMR-NITHR, I express my heartfelt thanks to the chief guest, Dr. Graham Sargent, and I would like to thank all the respected representatives who have blessed us with their presence. I would go sequentially by the names. First of all, I would like to thank Director Tiwari of ICMR-NITHR and for providing us this venue and all his team to make this function a success. And it's very difficult to go and perform a program in somebody else's residence or a place, and he's been gracious enough to provide us the opportunity and the hospitality. So our first thanks goes to him for providing this venue to conduct this program. Then I'd like to thank Dr. Vinita Srivastava, who is a health advisor to the Ministry of Tribal Affairs, who's been a constant source of inspiration and has been the guideline maker and has worked tirelessly towards the sickle cell anemia program. And we also had these speakers from, can I have the list? List. And we had the Additional Secretary, Dr. Jaya from Ministry of Tribal Affairs. We had the Honorable Minister of Public Health and Family Welfare, Madhya Pradesh, and Union Minister for Tribal Affairs, and Dr. Sargent was the keynote address speaker. So our heartfelt thanks for gracing this occasion, and we are blessed to have him here, and we hope we'll continue to have his support and blessings. And Dr. Reena Das from BGI Chandigarh also came and gave us her experience, and shared her wisdom and expertise with us. And I hope all the participants who came from Madhya Pradesh government, students from medical colleges have benefited from her talk and from the other experts. Dr. Anita Nark Kulkarni from ICMR-NITH also shared her experience. She's been one of my colleagues, a senior partner in our joint studies in ICMR-NITH. And I thank her for her time and thoughts. For me, Dr. Deepti Jain is one of the models that I would like to follow, and I hope I will continue to get her expertise to be shared. And she's been a constant source of inspiration. Thank you, ma'am, for coming to the symposium and giving us your thoughts. And Dr. Jyotish Patel has been one of the key persons in Gujarat program. Now he is spreading his experience across, and he has blessed Madhya Pradesh through his expertise. And thank you, sir, for coming to Jabalpur, for attending this and sharing your experiences on pregnancy and management of sickle cell. And Dr. Pradeep Sihare of Bilaspur also was here yesterday, and he shared his experience on hydroxyurea and how he has been using hydroxyurea since last decade or so, and even before it was introduced in Indian clinical practices. Thanks goes to him. And Dr. Tulika Seth is one of the pioneers in hematology and working in AIMS, New Delhi. And she is a very simple person and always accessible. And we thank for your coming and sharing your experiences and giving your advice and suggestions on the program and how the future direction of sickle cell has to go. We thank you, ma'am. We hope we'll get your continued support on this. Dr. Bhavna Dhingra, this is our first experience in person, and it's great to have you here and listen to you and your experiences and the suggestions that you have provided to the doctors so that they take home how to proceed further in the hematology. Thank you, ma'am. Dr. Eli Mahapatra, she is spoken on hydroxyurea, although it is her not her key forte. And thank you, ma'am. She is one of our co-investigators in the hydroxyurea clinical trial. So we took the liberty of giving you that title, ma'am. And we thank you for your time and your expert opinion on this subject. And again, Dr. Jyotish Patel spoke on pregnancy in SCD. Sir, we really appreciate your sharing your clinical notes on how, so leaving the experts upon and asking and making the students understand, just providing the situations and make their thoughts on how to work the situations. That's one of the best ways to make them learn, and we also learn from your experiences. Thank you, sir. And Dr. Rahul Bhargava, I always call him, he is one of the businessmen in bone marrow transplant and in India. He does wonderful bone marrow transplant, and he does for more of the African patients. Hopefully we will have his support for the Indian patients, and we really thank him for his time and making it a successful program. And Dr. S.D. Italia is one of my mentors. I've had an opportunity to work with him, and I shared much of his experience over the years since we started a newborn screening in Madhya Pradesh with him. And thank you for coming here, sir, and thanking your sharing your experience. And Dr. Ruby Khan is one of the people we constantly work in Madhya Pradesh through the sickle cell program in Madhya Pradesh. She is the Deputy Director, Blood Cell NHM, and the coordinator for hemoglobinopathy mission. And she is very helpful, and we hope she will continue her domain in this area. And we thank her for coming to the symposium and presenting her views and her expertise in the area. And Dr. Seema Jain from CCRS has come on a short notice. And ma'am, we are sorry we made you wait till post-lunch session. And it's been a pleasure, and hope all of us will be able to inculcate some of the Ayurvedic thoughts into our sickle cell journey, and make the benefits available to the sickle cell patients. And I also thank the panelists for all the things. And not before I wind up, I want to thank Team Ravindra's students and technicians who are working behind the curtains, because there, in many of the symposiums, we speak, we listen to the speakers, but we forget the team that works behind the scenes. The team Ravindra has been involved in registration, making the brochures, packing the brochures, and ensuring that we are not hampered in any steps. And we also want to thank our technical staff, Nitish, Vivek, Anup, and others. I don't have the full list of names, and I'm sorry if I have missed out any of them. And I want to thank the team food management, because they've not been able to listen to any of the speakers, because they are more involved in making the arrangements and ensuring that we get our timely tea and breakfast and lunch. So thank you for them. And also the team transport, because we would just walk in and say, मेरे को गाड़ी चाहिए भैया, होटल जाना है या airport जाना है, without their commitment and their standing outside and ensuring that we get our transports on time. Thank you, team transport. And one of the people that I intensively want to thank is the MP State, all these chief medical officers who ensured their program officers, nodal officers, students, and the patients to come here. And the biggest thanks goes to the sickle cell champions and their families who made this to come here. I always tell my colleagues and my staff, hamari roti unse aati hai. So thanks to them. And I hope we will be able to provide them the best care that they deserve and make their life better. And I also thank all the participants, and I would fail in my duties if I don't thank the event managers and the audiovisual team, because they are one of the key successes for the program to go smooth. And all the vehicle drivers, the Indian Coffee House who provided the safe and healthy meal, and students and security staff for their help and making this program a success. Thank you again on behalf of Director NIRTH. I thank you all once again. Thank you.
There is arrangement for tea outside. Request everybody to join, and also people can collect their certificates from the desk outside. Thank you.